Assalamualaikum warahmatullahi wabarakatuh. Good morning to all distinguished ladies and gentlemen. We are from Bachelor of Midwifery and Midwifery Proession program, Faculty of Medicine, Andalas University. We'll be delighted to invite you to the second annual Conference of Midwifery, ACM 2022, with the theme, Investing in the Future, Supporting Midwifery Practice, Research, and Education. Thank you very much for preparing yourself to join our event. It is an honor for me to be able to guide you on this spectacular event, which held today on October 27th, 2022 virtually. Before we begin, I'd like to introduce myself first. My name is Siti Hanisa Khaira, and I'm the host of our webinar today. We hope that all of you are in a good condition so that we can pay close attention and follow this event until finish. Should be noted that on this happy occasion, there are several rules that must be obeyed by all the participants. Firstly, please rename your Zoom account by writing the name of institution underscore your name. For example, Midwifery FK UNAND underscore Siti Hanisa. Secondly, please turn off the microphone and listen actively during the presentation. Third, we will feel so happy if you could turn on the video on a polite context in the hope continuity of today's event can be carried out properly. Fourth, Q&A session will be held after the presentation led by the moderator. Fifth, for this participant who wants to ask a question, you can write it in a Zoom column. But however, we will prioritize the participants who want to interact directly with our speakers by using raise hand feature. Sixth, your attendance will be proven by fill in the attendance link on the Google form, which will be shared by the committee twice, first in the morning and second after the session, in the afternoon session. Gratitude and thanks for the blessing that we received so we can gather here today on a virtual connection. The Honorable Director General of Health Personnel and Director of Health Personnel Provision of Ministry of Health, Republic of Indonesia, or the representative, the Honorable Representative from Global Affairs Canada and United Nations Population Fund Indonesia, UNFPA, the Honorable Head of Indonesia Midwifery Education Association, the Honorable Head of the Indonesian Midwife Association, and also the Honorable Head of the Padang City Health Office and attending staff. Furthermore, the Honorable all of the preceptor at the public health centers, Midwifery Independence Practice, and the Network Hospital of the Midwifery. Proession Education Study Program, Faculty of Medicine, Andalas University. And also the speakers, moderators, invited guests, and participants who have been present in our virtual room this morning. Firstly, let's say thanks to our God, Allah Subhanahu wa Ta'ala, the Lord of the world, the Lord of the universe, who has been given us blessing and mercy so that we can gather in this event with peace. Amen. Secondly, maybe peace upon us, our Prophet, Muhammad SAW, who has guided us into the right way of life. Further, for the squares of this morning's agenda, we will sing our national anthem and also the hymns of Faculty of Medicine Andalas University. Ladies and gentlemen, please stand up. Thank you very much, and please have a seat, ladies and gentlemen. So move forward to our next agenda. On this very special occasion, I'd like to invite the head of Indonesia Midwifery Education Association, Dr. Jum'at Ilyas MKes, to give us the first welcoming speech. Please, ma'am, time is yours.
Baik, terima kasih. Selamat pagi. Assalamualaikum warahmatullahi wabarakatuh. Pertama-tama saya ingin menyampaikan terima kasih atas waktu yang diberikan kepada kami dan juga ucapan selamat pada pendidikan profesi bidan di FK UNAND yang pada hari ini mengangkat suatu tema webinar yang luar biasa. Kami anggap ini sangat relevan sekali dengan cita-cita pendidikan profesi bidan UNAND, di mana ini adalah suatu upaya dalam rangka mengangkat suatu program, rangkaian dari program-program untuk pengembangan pendidikan Bachelor in Midwifery di UNAND. Kalau kita lihat temanya di sini adalah ini pada konferensi kedua ya di kebidanan di UNAND ini yang dilaksanakan tahun 2022 ini mengangkat suatu tema yang sangat relevan dengan profesi bidan yang diperjuangkan oleh profesi bidan saat ini, yaitu dengan mengangkat tema Investing in the Future, Supporting Midwifery of Practice, Research, and Education. Dan ini adalah misi-misi yang memang sedang kita perjuangkan di dalam mengangkat peran-peran bidan ini di dalam membangun kesehatan perempuan, khususnya kesehatan keluarga, terutama dalam meningkatkan kualitas hidup dari perempuan dan anaknya. Dan tentu saja ini adalah suatu upaya yang sangat luar biasa, karena dari para lulusannya nanti dan merupakan bidan-bidan muda, bidan-bidan generasi Z yang akan nanti membawa perubahan di dalam pelayanan kebidanan. Ini adalah suatu perjuangan yang berat dan tentunya ini adalah atas kerjasama dan dukungan dari Fakultas, dari Pak Dekan dan seluruh jajaran dari UNAND. Kami juga ingin mengucapkan selamat kepada teman-teman kami di UNAND, khususnya di profesi kebidanan yang setiap saat dalam tahun ini rasanya sudah banyak sekali kegiatan yang dilakukan dalam rangka membangun suatu sistem, terutama di sini sedang membangun sistem pembangunan model praktik profesi bidan, dan ini adalah salah satu langkah menuju ke sana juga. Tentu saja ini tidak selesai dengan webinar saja, kita berharap tentunya nanti aplikasinya di lapangan akan terlihat dengan jelas. Tentu saja kepada Bapak Dekan kami ingin menyampaikan terima kasih dan seluruh jajaran beliau yang sangat mendukung setiap saat, setiap kegiatan dari pendidikan profesi bidan ini, sehingga selalu saja hampir tiap minggu ada kegiatan dan semua berjalan dengan baik. Dan tentunya kami juga berharap ke depan dalam waktu dekat juga akan ada rangkaian-rangkaian kegiatan yang juga tidak hanya disupport dari dalam fakultas, tetapi juga dukungan-dukungan internasional seperti UNFPA, dan juga mungkin ada dukungan lain yang sangat kita gunakan dengan sebaik-baiknya sehingga nantinya pendidikan kebidanan di UNAND ini bisa menjadi memang proyek percontohan sesuai dengan yang sekarang di tema diangkat itu adalah sebagai Center of Excellence. Mudah-mudahan ini terwujud dalam waktu yang tidak terlalu lama. Saya kira saya tidak perlu berbanyak cerita atau sambutan di sini. Selamat datang juga kepada teman-teman kami dari luar yang akan berbicara di sini, antara lain Louis dan juga Angela. Mudah-mudahan saja ini nanti kita akan dapat mendengarkan bersama-sama apa yang disampaikan oleh beliau. Sekian, terima kasih. Selamat pagi. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thus, the speech delivered by Dr. Randa Yumiarni Ilyas MKes. Thank you so much, ma'am. The next one is speech from Head of Indonesia Midwifery Association, Dr. Emi Nurjasmi MKes. Time and screen are yours, ma'am.
Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Selamat pagi dan salam sejahtera buat kita semua. Puji syukur kita panjatkan kehadirat Tuhan Yang Maha Esa. Pagi ini kita dalam keadaan sehat walafiat dan kita senantiasa berdoa semoga kita selalu dalam lindungan Allah Subhanahu wa taala. The Honorable Dean of the Faculty of Medicine, Andalas University, Head of Midwifery Department, faculty members, UNAPA representative, Directorate General of Health Workforce, Ministry of Health, Republic of Indonesia, all speakers, preceptor and mentor, and all participants. First of all, I would like to appreciate the initiative of the second international conference with the theme Investing in the Future, Supporting Midwifery Practice, Research, and Education. These activities is very important in supporting the task of midwife in providing services according to their competence and authority in maternal and child health services, women's reproductive health, and family planning services. The existence of a midwifery professional education program at the Faculty of Medicine, Andalas University, which held excellence in the field of community and family midwifery care and the development of independent practice of midwife, which includes the continuity of midwifery care model, is expected to have a positive impact on the implementation of family-based midwifery services in West Sumatra as well as nationwide. I also take this opportunity to express my gratitude and high appreciation to the speakers who are experts in their fields. In particular, to the Dean who has given strong support for strengthening the midwifery faculty program. I'm also very grateful. Thank you, Bapak Dekan. It is hoped that all this effort will ultimately have an impact on increasing the ability of midwife to provide quality services. Of course, we hope can contribute to improving the maternal and neonatal health status in Indonesia. Once again, thank you to the speakers for their willingness to share information and knowledge, and also for Dean, for faculty members, for mentor preceptor, for the Association of Midwifery Institution Education, and all participants to take advantage of these opportunities. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thus the speech from our great Dr. Emi Nurjasmi MKes. Thank you so much, ma'am. Okay, before we move forward, I would like to greet our outstanding speaker, Andrea Gilkison, already here with us in our screen. Hello, Andrea. Okay. The last one is speech from Dean of from Dean of the Faculty of Medicine, Dr. Afriwardi, SHSP, KOMA. Please, sir, time is yours. Which today will be told by Dr. Hardisman. To Sir Hardisman, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Allahumma shalli wa sallim ala sayyidina Muhammadin wa ala alihi washabihi sallim taslim. Pertama yang saya hormati Bu Yumiarti Ilyas dari Akin, Ibu Dr. Emi Nur Jasmi dari IBI, perwakilan UFPE, kemudian dari Kementerian Kesehatan, terutama dari Direktorat ada Tenaga Kesehatan, dan especially for our invited speaker today that are attending this meeting. We saw it, Dr. Andrea. Good morning, and please allow me to speak in Indonesian language because despite of we call it this international seminar, but most of the participants, maybe all the participants, come from Indonesia. We call it from Aceh to Maluku. Most of them from Indonesia. Usually we call it international seminar. It must be attended by at least 5 countries. The participant must be at least attended by participants from 5 countries. But here we can still call it international seminar because we invited as speakers, experts from international community, international institution. So we hope that by inviting the speakers from overseas, we can get another perspective, update knowledge, and we can apply in our national context. Ibu-ibu hadirin yang berbahagia, karena kita yang hadir pada kesempatan ini adalah para bidan, para pendidik, para praktisi, sebagaimana harapan yang disampaikan oleh Ibu Yum dan Ibu Emi tadi, bahwa ke depannya bidan mesti punya peranan yang lebih terlihat, karena peranan bidan adalah peranan yang strategis. Khusus lagi di pendidikan, kita akan menghasilkan tenaga-tenaga praktisi yang akan bekerja di lapangan. Kalau kita lihat misalnya data dari UNICEF atau dari WHO bahwa lebih 62% persalinan itu sebenarnya adalah persalinan normal yang ditolong oleh bidan di dunia. Apalagi Indonesia mungkin angkanya lebih tinggi. Artinya peranan bidan untuk kesehatan ibu dan anak, terutama dengan masalah maternal, menjadi jauh lebih penting dibandingkan dengan peranan tenaga kesehatan lainnya dalam hal proporsi keterlibatannya. Oleh sebab itu, mempersiapkan tenaga kesehatan, terutama tenaga bidan, dari sedini mungkin yang kita terletak di hulu adalah menjadi tanggung jawab moral, tanggung jawab institusi yang memang mesti kita emban dan kita persiapkan dengan segala resource yang ada, dengan dukungan yang sangat kuat. Oleh sebab itu, kita dari institusi UNAND yang saat ini prodi sarjana kebidanan dan prodi profesi bidan adalah terletak di bawah fakultas kita sangat mendorong agar memang prodi-prodi ini berkembang, sehingga memang peranan bidan yang dihasilkan ke depan sesuai dengan harapan kita semua. Karena memang kita masih punya PR banyak. Tahun 2016 dari SDKI, angka kematian ibu kita sangat tinggi. Kemudian dari SUPAS juga meskipun sedikit menurun, tetap angkanya tetap tinggi juga. Nah, tentu peran bidan di sana mesti dituntut. Mudah-mudahan konferensi ini atau annual conference ini menjadi salah satu momen bagi kita bahwa ada dua. Satu, ilmu bidan mesti upgrade terus. Yang kedua, kita tidak sendiri, tapi ada bersama-sama dari Sabang sampai Merauke untuk menyelesaikan permasalahan itu. Nah, mudah-mudahan kegiatan-kegiatan ini terus memacu kita untuk meningkatkan keilmuan dan peranan institusi pendidikan menjadi lebih baik. Mungkin itu dari saya sebagai dari atas nama institusi. Mudah-mudahan kegiatan ini berjalan dengan baik. Dengan mengucapkan Bismillahirrahmanirrahim, kita berharap kegiatan ini memang mendatangkan manfaat bagi kita bersama. Terima kasih saya ucapkan kepada Ketua Departemen Kebidanan FK UNAND, Ketua Prodi E1, Ketua Prodi Profesi, Ketua Panitia, MC, dan seluruh yang bertugas sehingga acara ini bisa terlaksana dengan baik. Sekali lagi terima kasih semua, khususnya kepada peserta. Alhamdulillah kita ada peserta dari Aceh ya, dari utara, ada ujung barat, sampai kita lihat ada yang dari Maluku. Mudah-mudahan ini menunjukkan bahwa kita bidan atau tenaga kesehatan di Indonesia memang punya kepedulian untuk mengabdi lebih baik, yang ditunjukkan dengan upgrade ilmu yang dibutuhkan untuk praktek kita sebagai dasar evidence based dalam melakukan kegiatan profesi kita. Banyak maaf. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thus, the speech delivered by Professor Dr. Hadisman, MHID, DRPH. Thank you so much, sir. Well, firstly, I would like also greeting our honorable guest from Head of Indonesia Midwifery Education Association in West Sumatra Province and Head of Indonesia Midwifery Association of Padang and also West Sumatra. And now we are going to take a picture together. For all the guests, audiences, please turn on the camera because we are going to screen capture for the documentation. Okay, I would like to ask the operator first to take a picture. Mana Bu? Sudah Bu? Oke, bisa diatur dulu posisinya. Baik. For the first slide, 1, 2, 3. And then the next slide, 1, 2, 3. Lagi, 1, 2, 3. Lagi, 1, 2, 3. Next, 1, 2, 3. Bagaimana operator? Apakah sudah tercover semua? Baik.
Sudah.
Okay, we are done. Thank you, ladies and gentlemen. Now we will begin the first session of our conference today. The keynote speaker for this session is Associate Professor Andrea Gilkison from Auckland University of Technology, New Zealand, with the topic of midwifery practice in New Zealand, midwife-woman partnership with woman-centered care and autonomy. Before we get into the main agenda, let me introduce our special moderator that will lead our discussion today. For the operator, I will share the screen first. Okay. Okay. Buat operatornya bisa dikasih akses untuk saya sebentar, Bu. Okay, for a second. Okay, we can see here, this is our very excellent moderator by Dr. Denada Florencia Leona. Before we begin, let me briefly explain about her background. I will ask for the Dr. Denada started her education journey in medical faculty of Andalas University in 2012 until 2018. So she, along with that term, she managed herself to also get achievement and activities in national and international scope. Like we can see over here, in 2016, she went to Japan for International Society of Exposure Science and the International Society for Environmental Epidemiology. She went to Japan twice actually in that year, and in 2017 until 2018, she also had gone to Korea to do a conference too. In here we can see a conference in Indonesia Students Association in Korean about technology and science, and then symposium and preceptorship program in the 6th Cell International Congress of Endocrine and Metabolism. She also got lots of certificates like in advanced cardiac life support and symposium on cardiovascular disease, PIT conquer Midwifery, and then I saw something very interesting in here, like she had a lot of publication, started from the international until the national one, and then the achievement, she also a scholarship finalist to Sydney in 2010, and it's continue until an exchange student in Japan in 2011, and recently in 2022, actually she got a best abstract at 5th Asia Pacific Cardiometabolic Syndrome Congress in Korea too, and in 2021 she got a best e-poster presentation at the 10th International Congress on Lipid and Atherosclerosis. Okay, I think it's so many more, and her resume related to her track record. I think I would like to greeting Bu Denada. Dr. Denada, are you here yet?
Yes, I'm
Hello?
here already.
Okay.
Thank you.
Okay. How are you today, doctor?
I hope in a good condition.
Okay.
Actually,
Okay, Alhamdulillah. So for the next agenda, I will leave it to the moderator, Dr. Denada. Time is yours.
okay, thank you for the opportunity. Good morning, ladies and gentlemen. Good morning, Dr. Andrea. Dr. Andrea. Hello, good morning.
Hello, good morning.
Hello, good morning. Okay, it's a great pleasure, actually, an honor for me to be appointed again as the moderator of this annual conference from Midwifery Department, Medical Faculty of Andalas University. Okay, ladies and gentlemen, in this lovely morning, we will hear amazing presentation from our outstanding keynote speaker, Associate Professor Andrea Gilkison from Auckland University of Technology, New Zealand. The presentation will be about midwifery practice in New Zealand, midwife-woman partnership, women-centered care, and autonomy. Before we start the presentation, let me give a short introduction about Mrs. Gilkison. Okay, Andrea Gilkison is an associate head of postgraduate in the School of Clinical Sciences, Faculty of Health and Environmental Sciences faculty advisor, and also co-director of the Center for Midwifery and Women's Health Research at Auckland University of Technology, New Zealand. She is a midwife. She's a midwife committed to contribute to the quality of midwifery care provided to the woman, family, and their babies. Andrea's contribution has been focused towards midwifery research and developing high-quality midwifery education programs at undergraduate and also postgraduate level in New Zealand and internationally, specifically also in Indonesia, the Solomon Islands, and Bangladesh. So with this many national and international collaborations, I'm sure she is a leading midwifery educator and also researcher. Okay, to keep it short, let's hear our inspiring presentation from Associate Professor Andrea Gilkinson. So, Mrs. Gilkinson, the time is yours.
Oh, thank you so much. Thank you so much, everybody. And gosh, thank you for the introduction. And to all of you, the Dean, I want to, the Emmy from the Midwives Association, so many friends, and it's so wonderful to see you all again, even though it's on the screen. I just wanted to also particularly thank Yuli Zawati, Head of Midwifery at Andalas University. Yuli, you've been a wonderful friend and kept in touch throughout the time that I've known you. And I'd just like to congratulate all of you here, the educators, the students, participants, for getting together for this really important conference. And it's just wonderful to see how in Indonesia you've really been focused in developing really competent and skilled midwives. So I'm just going to share my screen, and there you go. As you can see, this is a photo when I was last physically able to be at Andalas University in, I think it was 2018, before the pandemic hit us all. And so you can see in this photo, some of the people who I met with then were still, I met in person. And it was really beautiful for me to see the images of Andalas University, and what you're doing now. It's I hope that before too long can actually come and visit in person once again. So again, congratulations on such a wonderful title for this conference, Investing in the Future and Supporting Midwifery Practice, Research and Education. This is so important. This is what we need for the future. We need to be constantly strengthening midwifery practice all around the world. Now, I'm just going to show you, bring you greetings. Sorry, I just have to get onto my. So I'm bringing you greetings from New Zealand, right down here underneath Australia, and I believe that you're up here, West Sumatra. And, I would really hope that one day you could come to visit New Zealand. And here's some nice images to encourage you to come and visit our beautiful country. But most of all, what I have really treasured has been the relationships that we have had between midwives across the world from far away, but still we are absolutely resolute in our determination to be providing excellent midwifery care to improve the health of mothers and babies. And this is this is my mission, my goal in life. And so today I'm going to be talking about the Midwife-Woman Partnership, woman-centered care, midwifery autonomy, the New Zealand Continuity of Midwifery Care Model, and educating midwives for autonomous practice. So I'm sorry, I don't speak Indonesian, so please, there'll be time at the end for us to have questions and discussion. Please put those questions in the chat or think of them so that I can clarify for you what I'm talking about. So I'm going to start off with the midwife-woman partnership. What is that? What does that partnership mean? So in the International Confederation of Midwives, in the scope of practice of the midwife, I'm sure you know, the midwife is recognized as a responsible and accountable professional who works in partnership with women to give the necessary support, care, and advice during pregnancy, labor, and the postpartum period, to conduct births on the midwife's own responsibility, and to provide care for the newborn and the infant. This care includes preventative measures, the promotion of normal birth, the detection of complications in mother and child, the accessing of medical care or other appropriate assistance, and the carrying out of emergency measures. So I've put that there really just to remind us that partnership is right there in our international scope of practice. And the other part that I've highlighted is the midwife's own responsibility. And that's the autonomy part, which we're going to be talking about today as well. So again, what does partnership actually mean? Because in some places we think of a partnership as a business relationship, a business partnership that will, conduct its services. But for the midwifery partnership, that partnership is a relationship that's built on trust. So the midwife and the woman and her family they need to have a trusting relationship. And the other aspect of partnership means that there is shared decision making. So the midwife isn't going to just go in and tell the woman what she's going to, she's going to be induced to have her baby tomorrow. The decisions are made together. And along with that, of course, the woman needs to actively participate in her care. So she has choices, she has wishes, she has unique, as you know, every woman has unique needs. And so as that partnership relationship will support, the midwife can support that woman's choices and what she needs for the health and well-being of herself and her baby. And because it's a partnership, it's not one-sided. The woman and her family's wishes are respected, but also on the other side, the experience and skills of the midwife are respected. So, it doesn't mean to say that the woman is going to make all the decisions and the midwife has to do everything. She would say, no, she might say, in my professional opinion, I believe that this is what we need to do, and sharing that information. And the other part of partnership means, because when we are one-on-one with the woman or one with her family, we know what she wants. It means when we come to work with other health professionals, obstetricians, pediatricians, whoever else, it means that we can advocate for the woman. We know her, we've been in partnership with her, and so therefore we can say, yes, that's thank you, that advice is really good. We need to talk about that, and this is what the woman has decided. So that was partnership. And then the second part of this talk is woman-centered care. And we talked about midwives working in partnership and providing woman-centered care. But what does that mean? So there's a number of definitions, but the definition that I'm sharing with you today is that it means two things. One is that as a midwife, our focus is on the health and well-being of the mother and the child, absolutely. But the other side of it is that woman's individual experience and what does having a baby mean to her? What does she want for her pregnancy and birth? So it's making it woman-centered, means that it's making it both safe for her and the baby, but also that her experience is absolutely foremost as well, alongside with that safety. And, you know, I think I would argue that woman-centered care should be a basic right for every woman. As the World Health Organization said, that all women should have a right to a positive childbirth experience, which includes being treated with respect and dignity, a companion of their choice, so people who they want to have with them, is her right. The woman is entitled to very clear communication by the maternity staff. She's entitled to know and make choices about available pain relief that she may or may not wish to make use of during her labour. And she's entitled to be mobile in labour, walking around and give birth in the position of her choice. So I believe that being woman-centered is an absolute fundamental basic right that every woman in the world should be entitled to when she gives birth. So we've got the partnership with the midwife, we've got woman-centered care, and the next part of this triangle, if you like, is about autonomy, midwifery autonomy. And so, you know, that word autonomy, in the ICM definition, you might remember that I'd highlighted she would conduct a birth under her own authority. So actually at our AUT, we've done some research about autonomy for New Zealand midwives. And the definition of autonomy that we came to was that midwifery job autonomy is the freedom to make decisions, schedule work, and determine how and when to do that work. And of course, if you've got high job autonomy, that will influence work positively. It increases attitudes and work performance and satisfaction with the role is what we have found in our study. So what we found in our study is that for midwives in New Zealand, autonomous practice happened more for community midwives who are providing continuity of care. So I'm going to be talking about that model of care that we have in New Zealand. So I'm guessing in Indonesia, a similarity would be a professional midwife who's working in her own practice. So she's in the community, she's knowing the woman right through the pregnancy, birth and postnatal period, and that midwife would likely have more autonomy than perhaps a midwife working in a hospital setting where medical staff may be making the decisions. The other thing we found that was quite unique, I think, for midwifery is that the midwife said for them, autonomy also meant shared decision-making with the woman. So autonomy for the midwives in our study meant that they were able to get to know the woman, whether that be in the community or the hospital, and make a shared decision and then be able to advocate for her so that she could have what she would ideally like, you know, given the constraints of what's happening for her, and she could advocate for her. In terms of other things, the midwifery expertise, skills and knowledge is absolutely intrinsic to autonomy. So needing to have really good skills and to be very proficient at those skills gave midwives confidence and also meant that they were going to be respected. That they could be respected for those that special midwifery knowledge and skills. And the other thing that we also found in this study was that some things can either support or hinder the autonomy of the midwife. So, and fundamental to that was the collegial relationships. So if you're working in a maternity facility situation where everybody respects the midwife for her knowledge. I'm just giving examples here, the obstetrician for their knowledge and the pediatrician for their knowledge, and that everybody is respected for their own skills will really support autonomy. Where there's a mismatch and perhaps, one group thinks the other group isn't as, hasn't got it right and isn't, their practices isn't what they would do, that can hinder autonomy. So it's a really big aspect, I think, of having autonomy will enable midwives to work in partnership and be woman-centered. So this is that's why I say it's a kind of a triangle. The British Journal of Midwifery also looked at midwifery autonomy, and they said that there's a number of things which can impact, that can either support midwives having autonomy or dampen it down and reduce their autonomy. And over here on the right is the government policy. If the policy is that midwives don't have the legal right to practice, then that in an autonomous way, then that can decrease autonomy. Sometimes, we look at the history of the midwifery profession, and in New Zealand, and I believe in Indonesia, it may have been the same, is that midwifery came out from nursing. And so we had to really define midwifery as its own unique profession, separate from nursing, in order to create autonomy. So that's still it's a big issue, because in a lot of parts of the world, it's not possible to have nurse and a midwife separately. There's a lot of places in the world where we have the dual registration, and so that it can be but once we identify the clear difference between nursing and midwifery, then it enables the midwife to practice in that midwifery scope. The British Journal of Midwifery said social media can have an impact on autonomy, because, good and bad. It could highlight the role of the midwife, or it could, call into question the midwife. Another big thing that we have, which can impact on midwifery autonomy, is the idea of risk, and that it might be too risky to have a midwife. It might be too risky to have your baby at home or in the community. And so that brings the woman potentially into a hospital setting, which might be under the jurisdiction of medical people. And then the other thing that they've identified is perhaps a difference between what is known as a medical model and a midwifery model of care. So, and I'm generalizing big time here, because I know that there's many doctors on this call who, who would be practicing really, really woman-centered care. But the medical model is thought to be not so much concerned with the person, the woman, but to be concerned with making a diagnosis of what's wrong and fixing it. Just, as I say, big generalizations here. Whereas the midwifery model, we say, and again, this is another generalization, is that we're supporting a normal physiological process. We're not looking, we do look to check that there aren't problems, but we're not focusing on those being the main part of what our care is. So those are the three things: partnership, woman-centered care, and autonomy. And now I'm going to talk to you about the New Zealand model of care, which does incorporate all of those things to different different levels. So the New Zealand continuity of care, I'll just first of all define what continuity of carer means, because sometimes there's you read about continuity of care and it might actually not be the person. It might be continuity of care might be provided in one clinic, whereas what we're talking about in midwifery is the continuity of carer. So consistency in the midwife that provides care for a woman, her family, and her baby throughout her pregnancy, labour, birth, and postnatal period. And I just love in this picture that at 9:30 she was pregnant, 11:45 she was birthing the baby, and 2:15 she's postnatal. So yeah, that was a very, very fast one. Obviously, usually those periods are much longer. So many of you may be aware of Cochrane reviews and Jane Sandal's work on her Cochrane reviews that she has done which is reviewing all of the studies which have been done around midwife-led continuity of care models compared with other models of midwifery care. So as she's got here, the take-home points are midwife-led continuity models of care provide a woman with care from the same midwife, or it may be a small team of midwives during pregnancy, birth, and early parenting with referral to specialist obstetric care or whatever specialist care is needed. So the Cochrane evidence does show that midwife-led continuity of care has many benefits for mothers and babies, and no harms were identified. But as Jane Sandal has said in February this year, she's updated this and said we still need to know about a number of things. How to implement and scale up models for midwifery in a sustainable way, in a workable way, and the relative importance of different elements of the models. You know, what are the effects on women who are at higher risk in their pregnancies, or those who are in more disadvantaged communities and those in low and middle income settings. So it is an ongoing piece of work, but the findings from the review, from her last published systematic review, was that if a woman has a continuity of carer, midwife, she would be less likely to experience regional anaesthesia, so that's your epidural anaesthesia. She's less likely to have an instrumental vaginal birth, so forceps or ventouse. Funnily enough, less likely to have a preterm birth, which is an interesting one, and we're doing some research now around this to find out what it is that having your own midwife means that you're less likely to have a preterm baby. And what we think it is it's the relationship, or what we hypothesize is that it's the relationship that the woman has. She trusts the midwife. And so if she's feeling uncertain about something, if she's not sure, you know, then she's more likely to contact the midwife and say, could you check me out? I'm just a little bit worried. And so perhaps more likely to pick up a urinary tract infection or some other cause of a potential preterm birth. And also the other one are less likely to have fetal loss before and after 24 weeks or a neonatal death. And again, these are other areas that we really need to look into, but suspect that it's that relationship and the knowledge. The midwife would have said, if you notice any change in your baby's movements, for example, contact me. I need to check you out. So I think it's probably that the midwife has given that health information, told the woman when it's necessary to come and contact her. And so that might be why there's less fetal loss as well. If you have your own continuity of care midwife, you're more likely to have a normal spontaneous vaginal birth. But there were no differences between groups for caesarean section or an intact perineum. So having your own midwife doesn't necessarily mean that there's a less chance of having a cesarean. If the cesarean is needed, then that would still be provided, of course. So in New Zealand, we have, since 1990, developed a midwife-led and woman-centred continuity of care maternity service. So about 50% of midwives operate as what's a lead maternity carer, or you'll hear me saying LMC, who offers continuity of care working in the community. The other 50% work in hospitals. They're employed by hospitals, whether that be small maternity units or big tertiary hospitals, and those midwives work on rostered shifts. Or all these midwives have exactly the same education. So in 1990, to allow this to happen, to allow this lead maternity carer system to come into place, required a lot of change of law, because prior to 1990, women were under the care of medical doctors who were the ones who were the only ones who could prescribe for them, the only ones who could order blood tests, order scans. And so women would go under the care of a doctor, and then when they were in labour, go to the hospital maternity facility where they were going to have the baby and be looked after by a midwife who would be on the shift. It took a lot. It wasn't a magic wand. Oh, we need to change things. There was many months and years of lobbying, working midwives and women working together and with politicians to be able to really lobby to have the scope of practice expanded. So since that time, midwives can now take full responsibility for the care of mothers and babies experiencing the normal pregnancy, and that's the LMC thing. They can prescribe medicines for the mother and the baby, and only for the mother and baby and to do with the pregnancy. So the most common prescriptions are iron prescriptions and contraceptives. So we could treat infections, urinary tract infections, and so on as well, and breast infections. But it's pretty limited, actually, what midwives do prescribe. Ordering blood tests and screening tests was a big thing. So screening for congenital abnormalities. And of course, it's more than just ordering the test. It's also having the results come back to you as a midwife and then sharing those results with the woman and then taking appropriate action if it's needed. Ordering scans was something that only doctors could do prior to 1990. And of course, make referrals when they're needed to specialist health professionals, whether that be physiotherapist or obstetrician or pediatrician. It's, that also met in the past, that used to be only doctors who could make referrals to specialists. So now we've been able to do that. And the other thing it did is it allowed for a change in midwifery education. So prior to 1990, you had to be a nurse before you could study midwifery, and midwifery was an 18-month course on top of nursing. I think that probably still happens in some places, but now since the law change, we've had a bachelor's degree in midwifery in New Zealand. So I'm going to talk now about how the lead maternity carer system works in providing continuity of care. So those midwives are based in the community, self-employed, so they run like their own business, provide care from early pregnancy and through to 6 weeks after the birth of the baby. As I've said, their scope of practice includes ordering those tests and scans, etc. So in New Zealand, lead maternity carer midwives are contracted to the Ministry of Health. So for citizens and residents, all care is free for the woman. And this is obviously, I've been asked about this before, how can that be possible? And so it's possible through taxation. So we pay taxes, and so to the government pays midwives that way. So the LMCs, the other part of it is that the midwives also need to have access to they're not employed by the maternity facility, so they have an access agreement to whatever their local maternity facilities, so that they can go in with the woman to provide care throughout labour and birth. And the latest statistics are that 95% of women will have their own midwife as their lead maternity carer. And it doesn't mean that that's the only person that she has, of course, but the lead LMC midwife is the one who would coordinate her care. And, obviously a high percentage of those women they need a specialist referral, they need somebody to come and help them to do a cesarean, they might have preeclampsia and need to see a physician. So, those processes are definitely all a part of the midwife's role, is identifying when there's a need to consult or refer to another health professional. And I've just put on this slide, I've said that midwives are contracted to the Ministry of Health to provide services. So these are examples of modules which are funded by the government. So the midwife would claim a certain amount of money for each of those modules, as they're called, provided. So if I was booking in a woman today, I could claim on the first assessment, registration and care planning. Once that woman got to the end of 12 weeks, I could put in a claim that's a fixed amount of money for first trimester care. There is extra supplement money provided for midwives who work in rural areas, because they have to often drive a really long way to go and see women. You saw in the pictures earlier that I showed you of New Zealand, a lot of New Zealand is very rural, so needing to take care out to those women. So I won't go through all of that, but it's just to give you an idea, I think, of what is provided and how the system works. You'll see, for example, LMC for a first birth is one fee. LMC for a VBAC, so vaginal birth out of cesarean, after cesarean section, is actually paid higher than first birth, or about the same price as same claim as a first birth, because we want to encourage women who have had cesareans to have a vaginal birth. But if for multips, for women having a subsequent birth, the fee is less, because usually multips are quicker. So just going to next talk about, how do women find a midwife? So they might find when they become pregnant, they can go and find and choose their own midwife. So what I've got up here is a photo of the online Find Your Midwife website. So women could go in, they could look at the midwives in their area, they can read about them, and they can see when they might be available to take bookings and contact them that way. We also find a lot of women find us through word of mouth, or through other midwives, through their friends, through their family, or through their family doctor as well. Some midwives are positioned within family doctor practices, or general practitioners, we call them. So they might be co-located there. And so sometimes it suits women to stay in that same practice. So choice involved in it. And, some woman could shop around and interview and say, because you want to, they have the right to find somebody who they feel they can get on with and who they feel that they can trust. So many midwives practice in small groups. so that they can share equipment and rent and provide backup to each other. So midwives generally do work with partners, have one other midwife who the woman would meet, at least one other, so that they can have regular time off. So they could often midwifery partners will have every second weekend off. So every second weekend I'll cover for my partner's woman and vice versa. So those arrangements are really important for the sustainability of this way of working. Back when I first started, right around that 1990 time, I never had a day off. I was on call. I did have days off, but I would be on call 7 days a week because I felt that as if I needed to be there for all of the women. But actually, we found that it's much better, much more sustainable, that you have regular time off and you've got someone else who can back you up in times when you might be unwell or other things happen. So, as I said, antenatal care, pregnancy care happens in the community. Midwives are going to assess the well-being of the mother and the baby, provide health education and advice. Planning for birth, and I put planning in that, inverted commas, because these days we've moved away from writing a birth plan, because it seems that it can become, if the woman has a plan and it doesn't go to plan, it can lead to a lot of disappointments. And so we tend to talk about, birth preparation. I think in that birth discussion is discussing where is the best place for this woman to have her baby, and ordering tests and scans and making referrals as you go on. And then, as I've said, the LMC midwives have access agreements to the maternity facilities. So even though there'll be midwives working in that facility, working shifts for women who don't have LMCs or who have to stay in there because they're unwell. So the LMC midwife goes in with the woman, providing usually all the labour and birth care, but often needing assistance from those midwives who are on the floor, or referring to the registrars or obstetricians, anaesthetists, whoever's needed for that woman's well-being. And, the place of birth is something that we discuss. So all midwives can offer birthing at home. So we also have what we call primary birthing units. So that might be what you would know as a birth centre. So it's a small birthing unit. They don't have specialists there, run by midwives. It's often quite homely and in the community. But on the other, and then of course, what we have, the secondary or tertiary level hospitals, which are actually the place where most women in New Zealand still go to, secondary or tertiary level hospitals, even though they might not need it. So that's something else that we all have to work on, having the intervention for those who need it. What's the came out from the Lancet series. So there's one group of women who get too much too soon, so too much intervention and too soon, perhaps when it's not needed, or too little too late, which can happen in a low resourced place. And then the postnatal care in New Zealand, midwives will visit the mother and baby for 4 to 6 weeks after the birth. Some women may stay in hospital or go straight home after the birth. And then once, we have, I think, in some places, midwives carry on caring for an infant through its first year. But in New Zealand, we hand over to Well Child Services, who are nurses, who carry on the care of that infant. So big question. Does it make a difference? Does continuity of care make a difference? So we're really, lucky in New Zealand. We're a very well-resourced country. We have, plenty of facilities and backups for emergency situations. So we're very lucky to have a low infant mortality rate and maternal mortality rate as well. So we can't say that rate that continuity of care has made a big difference to that rate, although as we saw in the Cochrane studies was that less preterm births and less fetal loss if you have a continuity of care midwife. So potentially that is contributing to a lowered mortality rate. The one thing which women are surveyed about how satisfied they were with their care. They're offered the opportunity to give feedback to the midwife. And so 77% of women currently are satisfied or very satisfied with their care. So, it's certainly not 100%. And it's, of course, that's a very, very black and white kind of statistic. It doesn't really tell you what they were satisfied with or dissatisfied with. However, we still have work to do. A 2021 study looked at maternity services in New Zealand and said, is the service delivering on equity? And what the researchers found was that younger women and those from areas of higher economic deprivation and remote rural women were most likely to be dissatisfied. And that was associated with physical access, getting to the midwife, getting to the facility, care that didn't meet their cultural needs, and other barriers which were associated with additional costs. And, one that comes to mind is, I'm aware recently of one of my colleagues, their couple, the baby needed to stay in hospital in the neonatal unit, which was in a main hospital 20 kilometres from where they lived. They didn't have a car. How can they get to see their baby? And, one person from the family might be able to go, but it's all those sorts of barriers which are more physical, not to do with the people, but to do with those costs which can be barriers to equity. So finally, how then do we educate midwives for this autonomous practice? And what is needed is practice, practice, practice. And I'll just alert you to this study. Corina Adnani, Corinne, we call her. I'm sure you probably know her, and I'm saying her name all wrong, but she came and did her PhD with us. And she's published this article, Strengthening Midwifery Education Through Clinical Experience, Findings from a Qualitative Study in Indonesia. So what she found was that there was a great need for practice and for actual hands-on practice, not observing. And observing somebody else or just doing a part of a birth was not really good enough learning. The other thing which she found in her study is that the practice needed to be supervised by midwives. So midwives supervising the student midwives, because the role of a medical person, because medical students, I understand, also learn to birth babies as well. So they need to be supervised by medical people because they're going to be taking that role of medicine, whereas the midwives need to learn about midwifery. The other thing which I think is, which Corinne found and we found right in the beginning when we didn't have these models, is that if students can follow women through, so they meet women in the community and they follow them through their pregnancy, through their birth and postnatal, go along with them. And, they may have different midwives and doctors looking after them, but having that continuity of care experience can be really valuable for the students. So the other thing for for you could be working alongside those professional midwives, so the midwives who are actually out in the community, as the New Zealand midwives are, as lead maternity carers. And I know that those are very sought after placements, and it's very hard. But if a student can have that experience, they will learn a lot. And again, working in their own areas. I've put villages there, so we have our students who might live in a rural area. They do their clinical placements in a clinic in that area, so they're going to stay in their communities once they graduate. And if you want to know anything more about midwifery education in New Zealand, as I said, before 1992, you had to be a nurse before you became a midwife. And then direct entry midwifery meant that people who, without a nursing degree, could study to have a Bachelor of Midwifery. And since 2011, the Bachelor of Midwifery is a 4-year degree. So 2,400 practice hours. So it's a lot. But just sort of coming back to Corinne's finding, it's the practice, which really seems to make a difference for our students. And just to send you greetings, these are from some of our latest graduates of midwifery in Auckland, where I'm from. And as a result of this education, and this is where we all want to head, is midwives with the skills and knowledge for working in partnership, providing woman-centered autonomous practice. And I know that you are all well on the way to, if you're studying midwifery, to be able to provide that much needed care and important care. And I just want to say, I hope that I will see you in Bali next year. I hope that some of you are able to come. I'm definitely planning to be there. And so it'd be wonderful to actually connect with you face to face. That ICM in Bali's, I think it's been cancelled twice already. So this will be the year, I'm sure. And finally, thank you so much. And I really welcome any questions or emailing me as well. So I will just stop sharing.
Okay, thank you, Mrs. Gilkinson, for the inspiring presentation. It's very interesting to me to learn about the continuity of midwives' roles in the patient, because it's a little bit different in Indonesia here. In my knowledge, I know that in Indonesia, the midwives' roles always end after the mothers give birth, and then hospitalized for about 2 until 3 days, and then the midwife's roles will be ended. It's like different from the midwife models in New Zealand. Yeah. Okay, the next session will be discussion. We will accept questions or maybe opinions on maybe some of you would like to share your experience related to this topic. So if you have any questions or opinions, please just raise your hand and unmute the microphone, or maybe write in the chat room. Okay, please, for the audience. Or maybe we have one question from Mrs. Mawan Frisantinai Baho. The question is, from your slide, from your presentation, I hear that the midwives get contracted with the government. So how the midwives get contracted from the government? Is it from the profession organization, or they are individually get contracted by their own lawyer? Maybe they make their own contract with their lawyer, or it is through the profession organization. Maybe that is the
Yeah.
question.
Thank you. Good question. Good question. So once a midwife is registered with the Midwifery Council of New Zealand, she needs to do first year of practice is we have a system called Midwifery First Year of Practice. And so when she's ended that year, she can, just of her own accord, go to the ministry, go online and say, I want to start claiming as a lead maternity carer. Here is my registration. And this is the area I'm going to be practicing in. So she would also need to set up quite a few other things. She'd need to rent clinic rooms, perhaps go in with, find a practice to work with. She'd have to arrange access to the local maternity facilities where she wants to work. So yeah, so it doesn't, so it's, yeah, it is the midwife individually who can do that. Any registered midwife can do that, yeah.
Okay, thank you. So the midwives has the ability individually to make contract with the government.
Correct.
Thank you for the answer. Okay, is there any other questions or opinions from the audiences? Okay, if there's not, I have one question from myself, actually. Maybe I'm not a midwife, but I'm a medical doctor. So it is very interesting to me about the midwives practice models in New Zealand. I saw in your presentation that that the midwife should continually follow up the patient after the mother gives birth, even it's a complicated pregnancy, such as pregnancy with complications, I mean. So how is the role of midwife after the mother gives birth? Because in complicated pregnancy, the mother will get referred right to the obstetrician or obstetrician. Okay.
Yes, I know what you're saying. Yeah, exactly. And again, a very good question. So we have, our scope is for normal. So if a woman needs, for example, a woman has diabetes or she has severe eclampsia, then she is referred under the into the hospital system, where she is looked after by the most, the diabetic midwives and the physicians, the obstetricians, whoever are needed. And in that case, those women probably will be looked after by the midwives who are working in the hospital. And then that LMC midwife would then, once the woman was home, could take back over the care. So there is a system of handing over care when it's needed. So yeah, exactly. It's yeah, and oftentimes we might negotiate it with the specialist at the time. Let's say, once she's in labour, can be there as a second midwife alongside the hospital midwives or alongside yourself. So there's still a contact, and for the most part, we have very good relationships with those specialists. And I think, I think there's now a lot of respect for both, and in most cases work very well together. So, which is the way it should be. Okay. Now, I did see a question in the chat too.
Yeah, there are many questions.
What are the challenges? Yeah, for implementing continuity of care. I think the challenges are for a sustaining continuity of care, and we've done quite a body of research around what makes a sustainable continuity of care practice, because as I said, when I first started, I stayed on call 7 days a week for my woman to have their babies. So what we've found is the most sustainable models mean that the midwives have regular time off. They have a practice partner who will have the same philosophy, so that I'd be happy to have time off knowing that my practice partner, if the woman who I've worked with all through the pregnancy, I know what she wants for the birth, and I'm certain that my practice partner will do a wonderful job in looking after her. So Yeah, so that I think would be the more the challenges in sustaining, and we have had stories of midwives burning out because they it's just so busy. It can be so busy, so many women, and trying to do everything. So I think sharing that continuity of care. So yeah, does that answer your question, Anita?
How about Mrs. Anita? Is it answering your question? Okay, maybe we have one more question from Mrs. Laila Rahmi. Is there any regulation to inhibit the cesarean surgery without indication? Because in Indonesia, it's hard to have with midwives autonomy, because the patient are often seeing the obstetrician to have cesarean surgery without
yes that's a big problem here too. So there's a lot of perhaps fear of birth for some women. Some women are afraid that something might go wrong unless they have a cesarean. And we as a worldwide community, this is something that we really, really have to work on, because it's everywhere. It's not only in the wealthy Western countries. Brazil has an incredibly high cesarean section rate. And even in Bangladesh, where I've been was doing quite a bit of work, it's sort of seen wealthy women think, oh, it's better to have a cesarean. I better go to my private obstetrician and have that cesarean. So, I don't think there's any easy answers, but obviously we need to have our medical colleagues on board as well, so that when the women go to see them, they say, well, yes, if you need a cesarean, of course, but I think, and we have to work with women to really change their approach, and for them to feel confident in their own bodies that they can give birth. That's my opinion, but yeah, and
maybe we
should know what you're doing.
Maybe we should improve the education for the mother, that the vaginal birth is safe and not that pain, maybe.
Yes, that's right, and we know it. We know we do have that information, that information, but it's it's a really, really tough one, because it's the idea that cesarean's actually safe, whereas as we know, it's not as safe, as you're more likely to have complications than potentially from a normal birth.
Have more complication rather than the vaginal birth, the cesarean surgery. Okay, thank you for the answer. There is another question from Desma, Mrs. Desma. VBAC in New Zealand will be paid higher than generally vaginal birth. Delivery assistance is carried out, and the steps taken to avoid uterine rupture risk factors when assisting childbirth.
Yeah, we totally will definitely do that. So anybody who's having a VBAC, we take them to hospital. We consult with the obstetrician during the pregnancy. This is what the woman has decided she would like. How do we need to manage the labor? And we'll do all of the things which I'm sure you would do as well, sort of very continuous or very frequent monitoring of the baby, making sure that we're all the time assessing for that pain and any signs of bleeding or rupture. So yeah, it's midwives would never do anything for that little bit of extra money. Believe me, they want the safe birth, of course, for the mother and the baby. So but it is. I think it's the government's way of saying, because there can also be that idea that once you've had a cesarean, you need to always have a cesarean. And of course, we know that actually, if you keep having repeated cesareans, you can end up having placenta accreta, and we're having high rates of maternal deaths in some states of America because of repeated cesareans and the placenta accreta and the placenta unable to come away after the baby, and the woman needing a hysterectomy. So yeah, it's a big one. Yeah.
Okay.
Oh, you're going to have to translate the next questions, please.
Yeah, I need to select the questions because there are so many questions coming in socially from the audiences. The next question is about women-centered care from Dian Indrayani. How to build partnership with the women? Is there any hardship to build the partnership with the women? Is there any hardship to choose and contribute and women-centered care?
Yeah, that's a good question. I mean, I think that's something which it does need to be learned. Something that our students get to know, particularly our very young students who may not have had much experience of birth, or they might, and so it sort of starts, I think, with communicating, learning to communicate, and I think our students, with those following the woman through and having that continuity of care experience, I think that really helps them to learn about partnership. So if you're, that could be one thing, if you're not already doing it, that's something that could be set up to help your students. And then we get the students always to reflect on that experience. How did they go? How did they feel the communication was? How was the partnership? What could they have done differently? What went well? And so on. So it doesn't happen automatically for every student, does it? Or every midwife. So and it's also impacted by the place. If you're a midwife working in a clinic where things have always been done in a certain way, and every woman has goes through the steps of blood pressure taken, or usually the urine tested, blood pressure by somebody else, weighs by somebody else, and then the palpation, that conveyor belt model, which is used to be so prevalent in our country. So to rethink that. How could we do it differently? Could we have one midwife who does all of those things rather than a whole series of different ones, and then learning about how that partnership relationship can grow that way?
Yeah, based on your answer, so I know that it's important to build partnership with the women, right? It's also related about the cesarean surgery before. It will reduce the cesarean surgery without indication if the midwife can build a really good partnership with the patient or the mothers.
Maybe, but it's ongoing because, as I said, our cesarean section stayed the same, rate has stayed the same.
Yeah,
so
yeah.
To
build partnership, because in Indonesia we tend to choose different midwives after giving birth, maybe to give vaccinations to the baby or contraceptions. We are seldomly choosing one midwife only for the treatment. It's really important to build partnership. Okay, we go on to the next question. The question is really interesting. Is there any chance for midwives outside New Zealand to work and have a career there? And what are the requirements and how to start?
Yes, there are. So if you got the New Zealand, the Midwifery Council of New Zealand would be the place to start. And so for internationally qualified midwives, you can apply there, and they look right back at it's the same for everyone who goes to any other country. You have to submit all of your education and all of everything that you've done, and then it's assessed according to what our training program is. And then And then the next process would be if it's not an automatic transfer, then might be offered the opportunity to sit the exam in your own country, a 3-hour multi-choice exam. And then if you pass that, then come to New Zealand to do a series of OSCEs. So yeah, it's a big, hard process, but it's possible. And we do have midwives come from other countries if they've done a similar program of education to what we have in New Zealand.
Okay, and the next question will be, does it pay well for a midwife in New Zealand?
Well, at the moment, we're having a big pay claim because we don't think it's well enough. We're sort of like many countries, the cost of living has gone up hugely since the pandemic, and so I would say it's definitely well enough. So yeah.
Okay, it will be heard by the midwives in Asia who are interested to continue their career in New Zealand. So we will go on to the next question. It's more related to the topic because the last one is out of topic actually. What is the procedure for midwives to provide continuous care in New Zealand? Are there any special requirements for midwives to continue the care, for example, differentiated by education level?
Yeah, no, we just have the one education level in New Zealand. So yeah, I know from Corinne's research that you have many different kinds of education. So there's just one, that's that 4-year program, and our graduates or our students get a lot of experience working with LMC midwives. About half of their clinical experience will be with LMC midwives and the other half in the hospital. So they have plenty of experience, and any of them they can choose from the day they register. They can go out into community practice or into the hospital. It's their choice, and it's roughly 50-50 what happens at the moment. So yeah, same education level for us. Yeah.
So all the midwives have qualifications to do the COC or continuing.
Yes, it's all a part of it, a part of the scope of practice and so on. So again, that brings down the element of the government policy and the education, the regulation of midwives. The council sets the standards for education and audits every midwifery school to make sure that we're teaching at that standard and that our graduates can be, it can go out and practice in any setting that they like.
Okay.
Yeah.
Thank you for your answer. And we still have many questions in here. I hope you are not tired to answer. Okay, the next question from Miss Ayu from Fakultas.
Oh, hi, Ayu. Lovely to see you.
Yeah. University.
Oh.
Maybe you want to speak directly to Mrs. Gilkinson, or just and I will just read your questions, Mrs. Ayu. Ayu mau langsung atau gimana? Oh, yeah, maybe.
There she is. She's got her hand up.
Oh, she raised hand.
Yeah.
Okay.
There she is.
Okay. Hello, Andrea.
Hello.
Nice meeting you again,
You
Andrea.
too. You
Hello.
too. Hello.
Thank you for your wonderful presentation. I am Ayu. I'm meeting you in Bukit Tinggi in 2018.
Yeah,
I would like to ask you a question relating to your topic. That's a wonderful presentation you shared with us. You said that autonomous practice need practice for a midwife. And in Indonesia, I think we face a lot of challenge to implement this in Indonesia, starting from the confidence we build up, and then the knowledge and the affective to the patient, and then hands-on and not just observe, like Mbak Corina article published in her PhD. I want to ask you, how we implement that autonomous practice and how we help develop our confidence as an autonomous midwife for midwifery practice. Thank you, Ande.
Yeah, no, that's a very important question, Ayu, and you know, and it's, you know, I think we need to really work with the management level of those facilities where our midwives are going for their clinical experience. And I think the relationship between the midwifery schools and those facilities needs probably, according to Corinna's research, to be strengthened, so that you can say, look, our student midwives are coming in these weeks. Could we please have all of the clinical experience for that time? You know, so I know that can be a power struggle, can't it? Because, you know, we have the same thing with other people who want those births as well. But I mean, the other thing would be to look at other places to go for clinical experience. Try to look for places in the villages or in the community where there isn't that competition from other students for that experience. But it's yeah, I don't, you know, and I think your Midwifery Association, I'm sure that they're working tirelessly on this. Yeah, so I can't have any easy answers. But I remember you from Bukitingi. Beautiful place. Oh, so beautiful.
Really? Is it more beautiful than Bali, Mrs.?
Oh, yes. I think so. I think
Bali.
so. Definitely. Bali, it's so touristy. Yeah.
Okay. Thank you, Miss Ayu. Is it answering your question, or maybe you have more question? Okay. Thank you. Okay. We have more audience raising her hand, which is Yulia Ramadhani. Miss Yulia Ramadhani, please unmute your microphone. Or maybe Miss Yulia Ramadhani isn't here yet. Maybe Miss Bararita.
Okay, thank you. Hi, Andrea.
Hi, Bara.
Yeah, so as you mentioned that there is a barrier for people living in a rural village in New Zealand. You mentioned that they have lack of access to the health facility, for example, because they live far away and then they don't have a car. And I wonder, how is the New Zealand government solve this problem? Because it's like common problem in Indonesia, for example, people living in a rural area.
Yeah. Yes, well, I think that the rural community would say the New Zealand government isn't doing enough, but what midwifery does is takes the care to the woman. So providing transport or extra funding so that the midwife can go to visit the woman. If the woman needs to be transported to a hospital facility in labour, then, you know, we do have the opportunity for helicopter transfer sometimes, but a lot of the time it can be very difficult for those rural midwives because, you know, the ambulance or car traffic, the roads might be closed with snow and things. So yeah, I think there's a real skill for those midwives living in those areas, and what they say is that they have developed the skill of being able to really work out which women need to be moved out of that rural area to have their babies. And yeah, it's not ideal. You know, you want to stay at home or close to your family and home when you have the baby, but sometimes women do have to move to a bigger city and wait to have their baby. But it's we've actually done some research about rural midwifery as well. So in Scotland and New Zealand, and found a lot of similar, you know, there's special skills that rural midwives need when you're a long way from any help, and those extra assessment skills and all the time trying to figure out if I transfer, you know, where can the helicopter land, or if I need to get out of here, who shall I have with me, and that sort of thing. So yeah, I think it's an international problem, and so yeah.
Okay.
I don't know if that's answered.
Ms. Baranita, how about it? Have you more questions related to your previous question? Okay, maybe that's enough for her. So you mean that the mother should move, will be facilitated by the government to move to bigger city?
Yes, if it's needed, yeah, she would be provided with some funding. Can be, although yeah, it all depends. If she's got real medical need to go, then yes, funded. But if it's perhaps her choice, she would have to fund that herself, which is again that equity issue. Yeah.
Andrea, I'm sorry, but the committee asked me to conclude your answer in Indonesian language. So please, I will conclude your answer. Jadi jawaban dari pertanyaan Miss Bara Renita tadi bahwa untuk di daerah perdesaan jika tidak ada kendaraan gitu bagi bidannya atau pasiennya sendiri untuk ke fasilitas kesehatan yang lebih bagus, itu difasilitasi oleh pemerintah melalui pendanaan supaya bisa pindah ke kota yang lebih bagus atau lebih lengkap fasilitas kesehatannya jika perlu, atau disediakan ambulans yang lebih banyak di daerah perdesaan tersebut. Okay, we will go on to the next question. Please wait a second, Andrea. I need to sort. I need to select because there are so many in the chat room.
I think.
How? Okay. There is one interesting question from Miss Penny Ariani. I've seen in your slide that there is midwife care schedule with the location. So how is the organization or practitioner can make the mapping? How is the control mechanism for the midwife's care that is given, and is the midwife have been in all area in New Zealand? I mean, is this every area has midwife in New Zealand?
Well, midwives can choose where they go to work, and again, it's a problem particularly in the rural areas, and that some midwives clearly do want to stay in those areas. That's where their family is, that's where they want to live. But some would say, no, I want to stay in the city, or I want to stay in a particular area. So there is difficulty in recruiting midwives to those faraway areas. Yeah, and so there is talk at the moment, as trying to provide incentives for midwives to go and work in the rural areas. And one of the things that we do as a midwifery school is that we have satellite schools. So from Auckland, we have up in Northland, about can be up to 5 hours north of Auckland, student midwives who are studying remotely. They can use Zoom and come to class, and then they can do their clinical practice in their local area. So we do that we have a few places around New Zealand who operate like that, and I think that's another way of growing the midwives to stay in those rural village areas as well. So I'm not quite sure whether, was there more to that question?
I'm sorry?
Just wondering whether there was more to that question. I didn't quite get the first part of the question.
Actually, me myself don't get that question, actually. I don't really get the question.
Oh, okay.
Okay. Okay, there is one more opinion from Miss Baranita earlier that she writes, I knew in African countries, the government provide maternity waiting home near clinics for people who live far away from health facilities.
Good idea. Yeah, that could be a good idea. Yeah.
So it's not like that in New Zealand.
No, it's not. But you know, that's something that potentially you could advocate for in your country, because you know, I know that sometimes it can be very difficult, you know, only access by boat and things to come to a facility. So yeah.
Okay, thank you for the answer, and Miss Baranita. Is there any other questions? Because the questions are already has been answered all in the chat room. Is there any questions from the audiences? Is there any more questions? Okay, it seems like there's no more questions related to the topic, because we have already many questions before, right? About
thank you very much for your interest.
Because your presentations is really interesting and amazing. That is why there are many questions from the audiences are interested to your topic.
Okay.
So maybe that's all for our discussion for today. Mrs. Andrea Gilkinson, thank you for your presentation and your answer. I hope we can see you again in the future for the midwives in Bali, as you said. I'm sorry for the mistakes I've been saying, because maybe it's been a long time for me to speak in English, so I know it is like maybe.
I'm sorry, you've done so well, and I'm sorry that I can't
really
speak Indonesian.
To share opinions about midwives, even though I'm not a midwife. Okay, thank you for thank you for coming. We're really happy to have you here. Okay, maybe I will give the I will call the MC. Mbak Siti.
Okay, thank you very much, Dr. Denada and Andrea. It's very insightful from us, for us, I mean. Okay, thank you for your presentation. I hope that it's also will gain insight for all of the participants over here. Okay, we will move to the next keynote speaker for the next topic is by Leonie Hewitt, PhD candidate from University of Western Sydney, Australia, with the topic of leadership and management in midwifery continuity of care models, which this topic will be led also by Dr. Denada Florencia. So I will just give the screen and also the speaker to Dr. Denada. Please, time is yours, Doctor.
Okay, thank you for the MC. Thank you, Mrs. Gilkinson. Okay, I will go on to the next session. It comes back to me again as the moderator. The next session will be from Mrs. Leonie Hewitt. It will be an amazing presentation too about the leadership and management in midwifery continuity of care models. Okay, maybe can I ask the committee to share the CV, curriculum vitae of Mrs. Leonie Hewitt?
Okay, can you see my screen?
I can see your screen, Ms. Hewitt. Good afternoon. Good morning.
Hello. Yeah, good morning. Now I just can't get my slideshow. There we are.
Maybe if you let me, I will give a short introduction about you for the audience.
I'll be interested to hear it.
Okay. Thank you. Maybe I will, before you start your amazing presentation, I will explain. I will give a short introduction about you. Leonie. Panitia bisa share screen CV Ibu Leonie atau?
Sorry, you want me to stop sharing?
Yeah, but you already stopped sharing actually.
Oh, yeah, I know, but I didn't do that.
Panitianya ada ininya? CV-nya atau dibacain aja ya? Sebentar. Mana dia? CV. Please wait a second, Miss Leonie. Okay, here we are. I will read a short introduction about you. Mrs. Leonie Hewitt is a PhD candidate from University of Western Sydney, Australia. She is I'm sorry. She works part-time as a clinical midwifery consultant and is part-time PhD student. Her area of interest is management, leadership, and models of midwifery care that provide women with continuity of career throughout pregnancy, birth, and after birth. She is also interested in lifestyles that promote health and prevent disease, global warming, and reducing the human impact on the environment and feminist issues. She has many outstanding work experiences and many professional publications. Okay, maybe that's all for the short introduction about you. To keep it short, before we waste any more time, let's hear an amazing presentation from Mrs. Leonie Hewitt. Mrs. Hewitt, the time is yours.
Okay. There's a bit of a time lag here. I can see that my mouth is not moving when my voice is coming out, but I hope it's okay to watch. Now, do I need to share my screen again?
Yeah,
yes?
Please. Please share.
There we go. Okay. All right. Well, thanks so much for giving me the opportunity of sharing my work that I've been doing, this research for the last 7 years. And but I'm going to start. Hang on, have I got control of my? My slides aren't moving. That's not good.
What happened?
My slides aren't moving. Here we go.
Oh, okay.
I've got it now. So I'd like to start by acknowledging the Kaurna people, who are the traditional owners of the land from which I'm presenting today. And I'd like to pay my respect to the elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people that are present today. So I need to move this because I can't see my screen. There we go. So what model of care provides the best care for childbearing women and babies? Well, we all know it's midwifery-led continuity of care. But I thought we could just go over again why midwifery-led continuity of care is so important. Well, a Cochrane review done in 2016 really highlighted the great outcomes for women and babies. And one of them was that it reduced labour interventions. So it reduced episiotomies, epidurals, operative vaginal birth. But it increased spontaneous birth and maternal satisfaction. And in a world where birth trauma is increasing, we really need to have a look at how we can improve maternal satisfaction. So it's really important stuff. But it decreased premature birth by 24% and fetal and neonatal loss by 16%, which is amazing. There are also cost savings involved in this kind of care, and that's important. But there's increased midwife satisfaction. And I think globally, if we're looking at a potential midwife shortage in the future, we need to look at how to increase midwife satisfaction. Oh. My slides are not moving again. What's happening? Okay, so is it just for high income countries though that we're finding these benefits? Is it only those low risk women from high income countries? Well, there isn't a lot of evidence around from lower to middle income countries, but I did find this study from Ethiopia, and it found that midwifery-led continuity of care increased spontaneous onset of labour and reduced the augmentation of labour. It reduced episiotomy rates and operational birth and perineal tear, and there was also a reduction in premature birth, APGAR score less than 7 at 5 minutes, meconium aspiration, and there was less admission to the intensive care. There was also greater early initiation of breastfeeding. So this is really important stuff, and I suppose lower to middle income countries have different issues in regard to implementation and sustaining these models, but it's really important that we get out there and we do some research, because I'm sure the benefits are just as great, if not greater. So what about complex women or complex pregnancies? Well, there's also not a lot of study out there on complex pregnancies, but we're seeing in Australia a huge amount of an increase in complex pregnancies. So we've got to look at what are the benefits to these women with midwifery-led continuity of care. And what we've found with the limited studies that have been done is that there haven't been a significant difference in the clinical outcomes from continuity of care. But we have found it safe and that it's cost effective. We've also found that it can moderate stress, improve trust and confidence, and provide timely, safer care, as well as enhance communication between the midwife and woman and intercommunication between health professionals. Well, I'm sure that's not surprising to any of you, because what we do as midwives is that we collaborate and we provide a special kind of care that sometimes we're not even really aware of. I know for myself, when I was watching my sister, she was dying of heart, lung, and vascular disease, and she was seeing so many different specialists, and none of them were talking to each other. There was no communication with her. She was getting prescribed drugs that reacted to other drugs from other specialists, and it was a mess. And I kept on thinking, she needs a midwife. Now, she doesn't need someone to look after her in her pregnancy, but she needs someone who will coordinate that care, who will collaborate, who will be available to talk, who will talk to my sister on her level. And so I think sometimes we overlook what we do, but it's really important stuff, and it's really important for these complex women. Now, I did find a study of higher risk Aboriginal groups that found that the babies were significantly less likely to be born premature, require resuscitation, or stay in hospital longer than 5 days. So again, important stuff. Let me see if I can move that slide. Oh, what is happening? Here we go. So how do we give midwifery-led continuity of care in Australia? Well, there's 3 ways. The first way is through private midwifery care. Now, private midwifery care in Australia is different to what it is in New Zealand. In Australia, the private midwife has to charge for her service. She has to have an indemnity insurance, yet she can't get indemnity insurance for intrapartum care at home. To work in a hospital with the women that she has in her caseload, she needs to have an access agreement, and not all hospitals offer an access agreement. In fact, many don't. She also needs to have a collaborative agreement with a doctor, and that can be really hard, especially in rural settings. So consequently, we've made it so difficult for private midwives to actually practice that there aren't a lot of private midwifery care out there, although it is extremely good care. Another way is through team midwifery. Now, team midwifery is where a group of midwives work shifts to cover the 24-hour care of a group of women. So this care is not continuity of carer, it's continuity of philosophy of care. And it does have great outcomes, but it's not as fashionable now as it once was. And what we're finding is that most of the models that are being set up in Australia are being midwifery group practice. And so I'll talk about midwifery group practice. It's working. Midwifery group practice is where women have a named midwife. The midwives work in a group to support their time off. They're on call for their own women, and they take a caseload of women, and that caseload can be anywhere from about 30 to about 40, depending on the complexity of the women. So more complex women, they'd have less of a caseload. Or if they have to cover for each other during birth, so they might have to come in and be the second midwife at a home birth or at a freestanding birth centre or an alongside birth centre. And they're paid an annualised salary. So the annualised salary is a really good thing because it means that if they're not working very much in a fortnight, they still get the same amount of money. And it's really important for sustainability for these midwives that if they don't have work on, if women haven't given birth in that fortnight or whatever, they don't come into work. They stay home and they have a life. So it's great that they get the same amount of money. The problem with the annualised salary is that every state and territory in Australia pays their midwives a different annualised salary, and sometimes there's differences within the state too. And that can be a real problem if you are living on the border and you have hospitals near the border who are in a state that don't pay as much as the other state does. They can have a real problem with setting up midwifery group practice. So even though we've got these great outcomes and we're supposed to be evidence-based, we have a problem implementing and sustaining midwifery group practice in Australia. In fact, only 15% of women can access continuity of midwifery-led care here. And that's in vast contrast to, as you've heard from Andrea today, how New Zealand have been able to offer it to most women, and about 90% of women choose a midwife as their lead maternity carer. Now, the differences are that the funding's different for a start, but those midwives, the majority of them are self-employed in New Zealand, while the majority of midwives providing midwifery-led continuity of care in Australia are employed through a hospital. And so that made me wonder what influence management had on the implementation and sustainability of these models of care. So we'll just take a step back in history for a moment and have a look at how management and management has evolved basically for nursing and midwifery. So if we go right back to the Crimean War, where Florence Nightingale was seduced by the idea of the way the military managed their people, their soldiers. That hierarchical military autocratic style, she found really amazing. She thought, this is how I'm going to manage the nurses that are under me, because she then, from the Crimean War, she then became a matron. She really established the profession of nursing during that Crimean War. And then in 1966, famine also promoted this hierarchical style, this style that was top down, that was people giving orders and others not even questioning it, but going out and doing it. And when I first became a nurse, and I know it was back in the dark ages, but I remember being totally scared of the supervisor, the nursing supervisor, and standing to attention when she came round and hoping to God I didn't have a hole in my stockings or my lace wasn't undone or I didn't have a hair out of place. And so that style was rampant until recently. And in fact, unfortunately, there are still hospitals that are still very hierarchical. Now, what's that got to do with midwifery? Well, about a little over 100 years ago, there was this competition between nursing and midwifery and medicine. And medicine really wanted to control midwives. And so there was this alliance made between doctors and nursing to bring midwifery under the banner of nursing. And in fact, for such a long time, midwives had to train as a nurse to become a midwife. And so midwifery was very much under the control of nursing and under that style of management. So I wondered how we could manage a group of autonomous, highly educated, highly skilled midwives that were basically based in the community within that hospital system. And I thought to myself, micromanagement probably isn't going to work. Midwives are going to probably leave. And what, do we just pay them and sort of have a laissez-faire sort of style where we let them self-manage? What works? And so the aim of my study was to determine the conditions that help to optimise the management of MGP in Australia. Now, I'm not going to go heavily into the research because I know that's really quite off-putting, but I'll just give you an overview of my thoughts and my study so that you can see where I'm coming from. So I used a feminist lens to look at the data, and that was because most people giving birth are women and most midwives are women, and there's still this imbalance, this gender imbalance. So I thought it was really important that I use a feminist perspective. I used a pragmatic approach and leadership as practice. Now, I'll go into this in a bit about this theory, but it's probably different to what you expect. And I used a mixed methods. It was a mixed method study in 2 phases. So phase 1 was qualitative. So it was interviews with MGP midwives and interviews with managers and clinical midwife consultants. And I used the findings of that study, or those studies, or phase 1, to actually determine the questions for the survey, which was of MGP midwives and managers, and it was a national survey. That survey at the moment I'm still analysing, but I will share a few of the findings with you. But let's talk about the interviews. So the interviews with midwives, there was a lot of data, and I analysed it thematically. Now, for those of you who are not into research, it just means that you're looking through the data and you're finding themes. And my overarching theme was value and support. The midwives told me that if they weren't valued and supported, then they're not going to last in a service that they have to give everything to. They were working 24 hours on call, 5 days a week, and they needed to feel valued and supported to be able to sustain that. One midwife said she's just found this nice little sweet spot where she has a supportive manager, a supportive group practice, and a supportive family. And she said for the first time in her midwifery life, she has a manager who sees her midwifery heart. And I just thought that was beautiful. And so I used a nice little sweet spot to talk about how midwives within a group practice, they really need to have a cohesive group. They need to get on with each other. They need to be in each other's lives and be friends. So then they can take the calls and take the phone off the person that might be struggling if they actually know what struggles they're having. They also need to trust their colleagues that they will do the same care. So when industrially in Australia, we need to leave after 12 hours if we've been looking after a woman for 12 hours in labour. And they need to know that when that next midwife comes in, that she will give the same care that you've been giving. They also needed to have a culture within the practice of self-care, that it was okay to say, hey, I want to go swimming today, will you take my phone? Or I need to see this movie that's out, it's really good, can someone take my phone while I'm at the movies? And it needed to be something that everyone did, and a culture within that practice. But it was also important for each individual midwife to have family support. And I remember once sitting at the table having a family dinner, and my phone went, and my kids went, "Oh, Mum, you're not going again." And my daughter actually said to me, "Mum, you care more about your work than you do us kids." And honestly, that nearly killed me. And so how different is it when your phone goes at a family outing and people go, "Oh, wow, you going to a birth, you lucky thing." You know, it's completely different. And so it's so important that people, you know, in the family actually get excited when you're going off to catch a baby. Building relationships and support beyond the model was what the midwives said they needed from their manager. They needed their manager to be going out to the other departments in the hospital and smoothing over things when there was trouble between MGP and say the postnatal or whatever. And it was really important that the manager actually educated people on what midwifery group practice was and what it wasn't. But it was also really important that MGP, or that midwifery-led continuity of care, was really respected and wanted within the community and by the women. The theme, Someone to Stand Up for You, was really about wanting that manager to be someone who would have their back if something happened. And that manager needed to straddle both inside and outside the group. They weren't part of the group, and so they didn't know all the dynamics within the group. But the midwives were saying it was so important that they actually attempted to find out, that they touched base with them to see that they're okay, that they really made sure that they went to meetings so that they could see how everyone is, and really tried to find out what the dynamics were within the group practice. And they also needed to be part of that executive. So be part of the executive and keep feeding up information through the executive about how great the MGP is. So the interviews and focus group I did with MGP managers and clinical midwife consultants was also analysed thematically. The themes of this study, however, were really around the requirements of the manager. So the central theme was that she needed to be woman-centred, a feminist, and have a really strong belief in the model. She needed to seek her own personal growth. So if there was a deficit somewhere, and one of the managers said, and she was an executive manager that said this, she said, if she doesn't understand finances, if she doesn't get the budget, she needs to go and get that education. And it was really important for that manager to be a particular kind of strong leader. Now, that's not that sort of military hero type. She had to be somebody who was tenacious, someone who would know what the group priorities were and where they wanted to head as a group, say taking on new grads or something, and that she would keep fighting for it. She would keep bringing it up, keep finding the evidence as to why they needed to do that or expand the model or whatever it was. And she needed to know where to find her own support. And some of the managers said they had great executive management who were very supportive. Others said they didn't. And they found support from MGP managers that were managing other services, and some of them found support from clinical midwife consultants. But they didn't really fit in with the other managers because they were doing a completely different job. And so it was really important that they found people who understood them and who supported them. The inward-facing theme, midwifing the midwives. This is about how the manager managed the midwives. And so I called it midwife-centered management, but midwifing the midwives is a term coined by Pat Brodie many years ago that was really about looking after midwives so that they can look after women in a way that is similar to how we look after women. So it's respectful, it's giving them options, it's not telling them what to do, it's supporting them. And so midwifing the midwives was something that the managers and CMCs said was an extremely important part of the manager's position. And so they needed to welcome them in. They needed to have an open door policy. They needed to be able to listen to anything that the midwives told them without actually changing their face. So they weren't to look horrified, or they weren't to judge, or they weren't to make the midwife feel like she'd done something wrong. So they had to actually control their facial expressions and really just be open to whatever it was that they were telling them, so that the midwives could come to them with anything. And this is really emotional labour, and so it was really important that the manager recognised that actually took a toll on her, and that she needed to also prioritise her self-care. So the manager needed to trust and value the midwives. They needed to prioritise the midwife's self-care and the care of her family. So having a culture within the group practice of the manager looking after themselves with self-care, and that culture then went across to the midwives practicing self-care. But they also needed to recognise that when a family member of a midwife was unwell or whatever, that midwife needed to be able to go off call and look after their family and put their family first, because they can't give everything to a woman if they're worried about their family. Now, the manager also needed to support professional growth, and this was really important with the satisfaction, with midwife satisfaction as well. And it's very easy for midwives when they're working in MGP to actually get bogged down in, being on call and all the work that they're doing, and they forget about that professional growth. So it's really important for the manager to actually facilitate that and recognise when midwives are not fitting in the group practice. And this was really hard. And I've had to do it myself, where you recognise that it's wrong culturally for a midwife to be in the group practice, and you have to move them into another model. But it's extremely important to do, because it can really disrupt a group practice, and it can make them fall over if you've got the wrong people in it. And the manager needed to ensure that they had the resources they needed. And this was not only tools of the trade, but it was also space. It was making sure that they had a space to do clinic visits, that they had a home, and that home might be someplace in the community where they would have meetings and education and get together. But it was really an important thing for them to have. And also the important resources of making sure that the MGP was always well staffed. They also said that it was important to take the things away from the midwives that they didn't need to be doing so that they could work with the women. And I'll give you an example of that. I set up a clinic in the, it was off-site. It was a flat with 4 bedrooms, and the 4 bedrooms were the clinics. But then I realised that these midwives were coming in and restocking, like getting all the stock and restocking all the time. And it was taking hours out of their day and taking them away from the women. So I had to sort of work out how I could get the stock to them so that they didn't have to come in and take that out of their day. So it's about looking at how you can keep them with the women. The outer or outward-facing theme called Gaining Acceptance was about starting off sustainably. It was about looking outside the model and making sure that everything was right. And this includes when you start a service, you've got to make sure that you've got your policies and procedures all ready to go. You've got to make sure you've done your risk assessment, that you've got the right people involved, that everybody in the facility knows about what MGP is and what it isn't. And you don't spread your managers too thin. If they're off also being the manager of other services, how have they got the time to carefully manage the MGP? So making sure that, you know, MGP can be a priority. Sorry about that. I might just turn off my alarm and turn off my phone. So also you needed to be able to keep women central to the model. So making sure that women were part of this, the starting of the model, but also they were part of every change that you have. Then find ways to have women involved. We used to have a thing called Women on Wednesday, and the women would come in on a Wednesday, and then they would they formed themselves a group called Mums That Ride, and they made sure that they did all the things that they could do as consumers to keep us afloat, to make sure that we weren't closed down, to be in the faces of the politicians. They did all those things that we couldn't do as midwives. And as the manager, you need to debunk any myths that are going around, anything that people are saying. You look at your stats and you see if it's true, and then you debunk it if it's not. And you let your numbers talk. So you let your stats out there, your great stats about your Caesar rate this last couple of months, or the amount of women that are going home straight from birth centre. You make sure that you make all those stats very visible. So what about leadership? Well, if you look at most studies these days about midwifery leadership, you'll find that most of them really advocate for either authentic or transformational leadership. And I was seduced by transformational leadership too. And when my first study, I actually thought that what I was looking at was this need for transformational leadership. But then I realised that every big change I've ever seen in midwifery has been enacted from all levels. And it's never been a single heroic leader. So I've looked at leadership from the theory of leadership as practice. And this is where it emphasises a pattern of connected actions, leaving the responsibility of leadership with the collective and not with those individual leaders. So leadership is decentralized from being about individuals with all their styles or their attributes, and being more about the relations in the activity of us doing work. And I don't know if you've ever been part of a group of midwives in a room wanting change, and all that information is flowing, and it's really exciting, and everyone has their part. And you know, I noticed when we changed the model at RIDE from being a standard medical model to being a freestanding midwifery-led model, it's the first one in Australia, and there were a lot of hurdles to get over, but it wasn't one person that that made that happen. It was everyone. It was from the ward clerk to the midwives to the women to the supervisors to the medical staff. It was everyone, and we all came together, and we all had our job to do. And so leadership for me is about the collective. So I'm sorry if I've disappointed you. So I'll just chat about my survey now. It was a national survey of MGP midwives, MGP managers, executive managers, and it was they were asked that they were to be that they'd either been in that role when they answered the survey or had been in the past in the previous 5 years. Every state and territory of Australia was represented, and but most of them came from New South Wales and Queensland. It was advertised via social media and through the Australian College of Midwives and the Women's Healthcare Australasia. So I had 790 responses, but I was only able to accept 669. 579 of them were MGP midwives, 68 were MGP managers, and there were 22 senior managers of MGP services. I asked if they were full-time, and 60% of them said they were. But of the 40% that said they were working part-time, 9% of them reported that they'd started off full-time but reduced their hours. And the reasons that they gave for reducing their hours were better life balance, family life balance. Some of them said they wanted to work privately and offer home births, and their services didn't offer home birth. 2 said they wanted to study, and 1 said they needed to care for a sick mother. So I asked them if they're still working in MGP, and 18% of them said they weren't. They said they were burnt out because of work-life balance. Their family life was suffering. There was lack of support from management. There was bullying. It was about being on call that was too difficult, or they had an excessive workload. So I then asked the managers if they were still working in MGP, and 23% of them said no. And the reasons they gave were that they had conflict with senior management, usually around direction of service. And the majority of that was about employing early career midwives. They wanted to employ early career midwives, and the executive didn't want them to. They also said that nursing management was problematic because they really didn't get midwifery models, or that their workload was too heavy. So I asked them if they managed other services, and 57% of them said no, but 43% said yes. And it was generally other maternity services that they also managed. One of them said it was a medical ward, and I don't know how that would go. And some actually said they managed several different areas. And that would be really difficult. And I asked them how they found managing another service affected their role as an MGP manager. They said they had no time to provide the support the team required. At times it was challenging. It was busy with not enough time to fulfill all the requirements of the role. But it was challenging to support new grads. It was fragmented, extremely difficult, no time to be an effective manager. They were time poor, and they were unable to prioritise the MGP. I then asked them what characteristics they found the most important in an MGP manager. And I gave them options of firm but fair, that they are efficient and meet their key performance indicators, that they were nurturing and easy to talk to, that they care about and fully understood women-centred care, that they trust midwives and leave them to self-manage the practice, or that they trust midwives and carefully manage them without micromanaging them. So they were asked to say which they found out of those 6 was number 1, and then second, third, and so on. So number 1 was that they care about and fully understand woman-centred care. Number 2 was that they trust the midwives and carefully manage them without micromanaging them. And number 3 was that they're nurturing and easy to talk to. So that was interesting. So firm but fair was 4, being efficient was 5, and leaving the midwives to self-manage was definitely number 6. So if we're going to provide the best care to women, and we're going to sustain that care, then we need to choose our manager really carefully. We need to have someone who gets the model, who understands woman-centred care, who is nurturing and mother-like, and is also a really good communicator. But then we need to support that person. So thank you everyone for listening. These are my references, and I'm happy to take any questions.
Okay, thank you, Mrs. Leonie Hewitt, for the amazing presentation. It's really interesting about your presentation about the management and leadership skills in midwifery. So the manager, you said on your presentation, is it from the midwives themselves? Is the manager from midwife itself, Mrs. Hewitt?
So are you asking if the manager has been employed is also a midwife
itself? Yeah, I'm asking the question because it's really interesting for me.
Yeah, so most managers are midwives, and one of the questions I did ask, which I didn't discuss, was whether they needed to have worked in MGP to manage, but really it's more important that they get the service and they get women-centred care. Oh. So yes, they do need to be midwives. Is that what you meant?
Yeah. I mean, the manager you said in your presentation is from the midwives themselves, right?
Yeah, and I did those 2 lots of interviews where they were from it was
their professions.
Midwives talking about what they wanted from managers, and there were managers talking about what they thought was needed as the MGP manager.
Okay, thank you for the answer. I just want to confirm.
No, that's fine.
Okay, the next session is the discussion. We will accept questions or opinions from the audiences, and also if there are any audience want to share opinions or experiences, we are very welcome. Is there any questions from the audience? Okay, there is one question from Ms. Safira Kansa Madiasari in the chat room. The first question is, nowadays, international midwives has spread around the world. Based on what I know, Australia has high requirement for overseas midwives who want to work in Australia. Not only need to have documents, but also MCQ test and OSCE. As far as I know, the number of overseas midwives in Australia is not as much as overseas nurses. Does Australia not really need midwife from abroad, or is it already enough to have midwives in all area in Australia? Maybe the question is not really related to the topic, but please.
Look, the survey I did actually showed that there was quite a lot of midwives from overseas providing midwifery group practice care. And as far as our numbers are concerned, I think we're all at risk of having not enough midwives in the future. And so we really have to look at how, I think we're probably educating enough, but we need to keep looking at how we can keep them in the profession. So many midwives train to be midwives and then are disillusioned and leave. And so we've got to look at how to attract them and how to keep them. And I think midwifery models, especially midwifery-led continuity of care, is a way of really keeping our midwives in the service. And whether we are going to need midwives from overseas in the future to keep our numbers up, I can't predict that, but I can tell you that it always enriches the culture of midwifery to have people coming from other places.
Okay, thank you for the answer. I'm sorry, Mrs. Sewit, I need to conclude your answer in Indonesian language for the audience.
Oh, sure.
Okay. Baik, untuk jawaban dari yang pertanyaan pertama itu Australia tidak menutup kemungkinan menerima bidan dari luar negeri, namun memang sudah cukup banyak bidan di Australia dan juga yang banyak yang berminat untuk menjadi bidan. Tetapi ya memang tidak menutup kemungkinan untuk menerima bidan dari luar negeri. Okay, Mrs. Hewitt, the second question from Safira. Health leadership is sometimes not really highlighted during studying midwifery, especially in Indonesia. Most of midwives would do learning by doing regarding their position on work. So in midwifery, do we need to learn some additional specific courses about leadership in midwifery or some workshops which will teach midwives who will implement leadership as their role in working area? That is the question.
Yeah, so the question, just let me make sure I've understood it properly. The question was, do we need to be also learning about management and leadership to be a midwife? Is that what the question was?
Yeah. The question,
yeah. And I think, look, I think we haven't done enough study on what is the requirement of management and leadership in midwifery. I think it's something that we've got to keep really researching, because I don't know that we really understand it fully yet. So as far as doing courses, I think it's probably more important that you really do all the things that are required of a midwife, and then maybe be involved in further research of what the requirements are for managers and leaders.
Maybe because in Indonesia we don't have separate course about leadership and management, and
right,
the skills are just got by the practice in the daily life and just learning by doing.
Yeah, and look, they are mostly with us too, but we still, when you set up a course on management, you really need to know what you're teaching, and I guess we haven't still done the basic research to really know what we should be teaching people as far as how to be a good manager and how to be a good leader. So I suppose that's where I'm coming from, is that we've got still some basic work to be doing, and I think on what are the skills required.
Okay. So I need to just confirm that. So there is a special course about leadership and management in Australian midwives.
There are, but there are very few of us doing the research to actually back that up. So how beneficial it is, I'm not sure.
Okay, thank you. Let me conclude it first.
Yeah, sure.
Okay, jawabannya adalah bahwa di Australia sendiri sudah ada memang mata kuliah khusus untuk leadership and management pada kurikulum bidan. Berbeda dengan Indonesia yang mungkin tidak ada course terpisah untuk skill tersebut. Tapi memang di Australia peminatnya memang masih sedikit untuk course leadership and management ini. Jadi memang mereka tetap mempelajarinya lebih kepada praktiknya sehari-hari untuk mendapatkan skill leadership and management tersebut dan juga mempelajari dari sumber-sumber lainnya. Okay, we'll go on to the next question. We have Miss Mirani Safaringa who raised her hand, wants to speak the question directly. Miss Mirani Safaringa, please. Time is yours. Please unmute your mic.
Okay, sorry, I can't to unmute my device because the host. Okay, what an incredible presentation, Miss Hewitt. I'm so I'm so impressed with, especially with midwifery group practice in Australia. So I'm just have a simple question. How to, in the Australian midwife, make the midwifery group practice sustain in or how to maintain that activity midwifery group practice in Australia, and also continuity of care.
So how the midwives sustain themselves in the midwifery group practice? Is that your question?
Yes.
Yeah. So I've been a MGP midwife for a very long time, and so that's why I was really interested in it. But it's really important that you look after yourself and that you really are practicing self-care, that you have a supportive family, and that you have a really good, supportive, cohesive group that you work in. And I suppose things you don't have control over is the attributes of that manager. So the manager needs to be someone who actually really looks after the group practice as well. And unfortunately, in Australia, a lot of MGP managers are looking after other services, which means that they can't carefully manage the MGP. So yes, it's an interesting question, and it's something that I think we really need to do a lot more study on.
Okay.
Have you worked in MGP? Have you provided that care?
In Indonesia, I think it's very just a little MGP activity apply. So, but after this, we will try to learn how to work in MGP so we can apply it in Indonesia.
Right. I'm hoping to get you all enthusiastic about it.
Okay. Okay. Thank you, Ms. Hewitt. Back to you, Ms. Denada.
Okay, thank you, Ms. Mirani. You see, there are many questions in the chat room, and some people are raising their hands. I see that they are interested enthusiastically in this topic. So now we have Ms. Bara Renita who raised her hand to directly ask question. Please. Ms. Bara Renita, the time is yours.
Oh, okay, thank you. It's really interesting presentation, and I have a question, and I'm a little bit confused with the survey answer by the MGP manager. It is fragmented, and can you elaborate more about it?
About the care being fragmented, that was about needing to put your care of other services before you actually care for the MGP. And so it was quite fragmented. If the manager was able to really just look after the MGP, then they had all of their care and their time. But when they had, say, the postnatal ward and the antenatal ward, as well as an MGP, then the care or their management was fragmented. So that's what was meant by that. Does that make more sense now? Yeah, good.
Okay. Okay, maybe that's all from Miss Baranita.
Thank you.
Because there are some questions, yeah, we go on to the next question. From Miss Hotma. According to your research, how management and leadership in midwife as an autonomy profession can improve maternal and baby's continuity of care in Australia, and how is the model on your research?
Okay, so as I said, that Cochrane review was, it actually looked at 4 different countries and about 15 different studies. And so we are constantly looking at what our outcomes are as far as midwifery group practice in Australia, but they are in the UK and they are in other countries as well, in New Zealand and yeah, Denmark. Wherever they're doing midwifery-led continuity of care, they are actually looking at their outcomes. And at the moment, they're doing another Cochrane review. It was Jane Sandel that did that 2016 review, and she's got a few more studies at the moment, and she's doing the review again. So we're going to get new data coming out, and it'll be interesting because last time we didn't actually expect to see that there was going to be a reduction in premature birth and a reduction in fetal and neonatal loss. And we're still sort of wondering why that is. How can you reduce premature birth and fetal and neonatal loss by just providing midwifery continuity of care? And I think one of the things that we're wondering is if it's, you know, that relationship that you have with the women, does that mean that she's more likely to ring you when something is not right and talk to you when something is not right, so that you can actually action it? So we don't know why that is, but that was a very surprising outcome, and we're very thankful that we found it. So the next review, it'll be interesting to see if there's anything else that comes out that surprises us. I'm hoping it's just as good as the outcomes that we've found in the past. Did that answer that question? Sorry, I'm just wondering if my answer was what was asked. Do you want me to rephrase that? Okay, good. What was your second question?
Okay, Leonie.
Yep.
Okay.
I'm sorry, there's no.
Okay. I think it will be continued by Dena.
I'm so sorry. There's a network problem in my home. In my house.
I was worried about that too.
Yeah. Okay. Okay, we'll go to the next question from Ms. Hotma again. How to collaborate our autonomy as a midwife in management and leadership and interpersonal collaboration with another healthcare. How to collaborate?
How do we collaborate? Well, most importantly, and I found this has come up time and time again in the research, is that the manager needs to be really working hard at educating all the different disciplines. So therefore, the doctors really understand how the midwives work in the MGP and how they don't work. And so when there's a really good understanding of the boundaries of midwifery group practice, then they can collaborate a lot better, because when it first starts, people have this view on what midwifery group practice is rather than really understanding it. So education is the key. Getting together and meeting is the key. So it needs to be multidisciplinary, because midwives are not islands. They don't work necessarily on their own, and especially when women deviate from normal, then you need to be able to collaborate with other health professionals. And so them having an awareness of how you work is extremely important. But then I suppose it's really around having good relationships. Did that answer that?
Yeah. You can answer that. Okay. Okay, we go on to the next question. Maybe the question is about the management of COC, or continuity of care in patient with complicated pregnancy. Right. How is the management, or like the rules for the midwife after the mother get referred to the obstetrician after the complex pregnancy? Yeah, how is it managed?
So all women need a midwife, whether they're seeing a doctor or not. And so that role might change a little bit, but you still need a midwife. You still need someone who will give you that continuity, who will be that person that goes to the doctor's appointments with you and then is able to sit down and really nut it out with the woman afterwards, really explain what the doctor was saying. Someone who will take those calls in the middle of the night when you're worried about your baby. So the role is different with complex pregnancies, and there is a lot more collaboration with other health professionals, but that continuity is still just as important. And I suppose we're so much better at giving midwifery-led continuity to low-risk women, and we haven't done enough study on how it impacts complex women, but it seems that it's really still extremely important that all women receive midwifery-led continuity of care.
Oh, so how do we keep the patients to keep coming to the midwife after they see the doctor?
Well, that depends on how complex she is. Now, it might be, I've set up models where midwives have seen the woman one visit, doctor sees them the next. They'll see the midwife the next visit, doctor sees them the next. Or they have an agreement with the doctor that they will see them at booking, that they will see them at 24 weeks, that they will see them at 32 weeks, and again at 36, and the doctor will see them all the other times. So it really is around how complex that woman is, and but it's still really important that they have that midwifery contact, because they don't necessarily get any education if they're seen by medical staff all the time, and they don't have any faith in midwifery care. Now they're going to have midwifery care in labour. Their doctor's not going to be there all the time. So it's really important that they really trust and respect midwifery care, so that they trust and respect that relationship throughout the process of giving birth as well, and postnatally. So having midwives involved in the care all the way through the pregnancy is really important if you want a woman to be well cared for. And so it could be that you also might, if the woman needs to see a doctor every time, then maybe you need to work out that you can, she has a doctor's visit, but then she has a midwife visit at the same time. So there's lots of different ways of doing it, but it's extremely important that you that woman gets to experience that relationship with a midwife, and all that education and all those other beautiful things that we do as midwives to make her feel safe and well cared for.
But it's also important, right, to the doctor to be involved, to educate the patient, to continue the care to the midwives.
Yeah, but what we find is that a lot of women say that they actually don't get as much education from the doctor, and that the doctor is extremely busy. So, and also doctors don't do postnatal care, or most of the postnatal care. So it's really important that you have that continuity through all, the pregnancy, birth, and postnatal period. I can't hear you, sorry.
Okay, thank you for the answer. I need to conclude it in Indonesian language again.
Oh, okay,
I'm sorry. It's muted again.
Okay, yeah.
Oke, untuk pertanyaan yang terakhir, yang tadi itu tentang peran dari bidan setelah pregnancy atau kehamilan dengan komplikasi yang sudah dirujuk ke dokter kandungan, bagaimana selanjutnya peran dari bidan tersebut untuk melanjutkan COC atau continuity of care, di mana ada peran dari dokter untuk mengedukasi pasien agar melanjutkan continuity of care ke bidan dan pentingnya untuk melanjutkan ke bidan seperti apa, dan juga bidan juga tetap harus mengontak dan memberikan kontaknya itu kepada pasien dan memfollow up pada pasien sehingga pasien merasa membutuhkan peran dari bidan. Oke, for the next question, is there any more questions from the audience? If you have any questions, please write in the chat room or raise your hand. Okay. Okay, maybe there is one more question in the chat room from Ms. Isnaini Rofikoh from Muhammad Purwokerto University. What about the laboratory examinations from midwives? Can the midwives do the examinations for the patients in Australia? How far the midwives? Such as supporting examinations such as laboratorium or USG, ultrasonography, or others? How far the midwives in Australia can do the examinations for the mothers?
Okay, so most midwives that are providing midwifery-led continuity of care can do what is required for most normal pregnancies. And when it goes outside of that, then they usually will then collaborate with a doctor. So, and that might be that they will order tests or investigations after speaking to a doctor, or they may send them to the doctor for a visit, and the doctor might order those things. Is that what you meant?
Yeah. I mean, for the midwife itself, how far they can.
Yeah, so we would, if the woman is normal, the midwife would do all the care.
Okay.
So would do everything. But if the woman has complexities, then you would need to bring in a doctor.
Right. Yeah, and refer to it to the doctor. Yeah. Okay. Is there any more questions from the audience? Okay, seems like there's no more questions and opinions from the audiences, because there are already many questions you have already answered. Thank you for the amazing presentations, Mrs. Leonie Hewitt. And I'm sorry for the mistakes that have been made, because it's been a long time for me to speak in English. So.
Oh, look, your English and everyone's English is so much better than my Indonesian.
Oh, really? How good you're.
I really hope you've been able to understand me.
we understand you very well, but I'm
Oh, good.
afraid that you can't understand us because yeah, you know, English is not our native language.
No,
So
but you're doing an
I'm
amazing
sorry
job.
if you- I'm so sorry if you don't get the questions or I have mistakes in delivering the questions to you.
Not a
Okay,
problem.
maybe that's all for this afternoon. I'm so grateful for having you here. Thank you for your presentation. Okay, we'll give it back to the MC. Thank
Okay.
you, Hiwit, Miss Hiwit.
Thank you so much, Dr. Danada and Mrs. Leoni. We would like to thank you as well as the moderator and as well as the excellent speaker in the first and second session. Thank you very much for the very enlightenment presentation from Mrs. Gilkinson and Mrs. Hewitt. And thank you to the participants who were very enthusiastic until now. Baik, mungkin arahan selanjutnya saya akan mengabarkan dengan bahasa Indonesia karena yang sudah sampai pada akhir sesi pertama, sesi pagi di jam 11 ini. Jadi kita akan istirahat sebentar dan akan melanjutkan acara kita pada pukul 13.00. Jadi untuk acara selanjutnya kita masih ada pembicara yang luar biasa sekali dari Associate Professor Louis Walker, yang mana beliau berasal dari the University of Nottingham, UK. Dan juga saya mau mengingatkan kembali kepada partisipan bahwasanya akan ada absensi kedua kalinya pada jam siang nanti. Jadi saya harapkan untuk semua partisipan dapat kembali dan bisa mengikuti kegiatan sampai akhir. Kemudian juga kami persilahkan buat semua partisipan untuk beristirahat sebentar dan juga jika ingin melakukan kegiatan isoma dan juga makan siang, saya persilahkan. Okay, thank you and see you later. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Partisipan boleh tetap stay ya, atau juga boleh leave, tapi nanti join lagi di jam 1. Terima kasih.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all the participants. Welcome back to the second annual Conference of Midwifery ICM 2022 with the theme Investing in the Future, Supporting Midwifery Practice, Research and Education. Thank you very much for preparing yourself to join our event and for the participants who already attend here. Okay, I would like to remind that there are several rules that must be obeyed. Firstly, please rename your Zoom account by writing the name of institution _ your name. Secondly, please turn off the microphone and listen actively during the presentation. Thirdly, we will feel so happy if you could turn on the video in a polite context in the hope that continuity of today's event can be carried out properly. Fourth, Q&A session will be held after the presentation and led by the moderator. And then the fifth, for the participant who wants to ask a question, you can write it in the Zoom chat column. However, we will prioritize the participant who wants to interact directly with our speaker by using raise hand feature. Sixth, your attendance will be proven by fill in the attendance link on the Google form, which is will be shared in the last of this Zoom meeting. And then now we will begin the third topic of our conference today. The keynote speaker for this session is Associate Professor Louis Walker from University of Nottingham, the UK, with the topic of midwifery education, innovation, and approach to increase the visibility of midwifery. So before we get into the next agenda, let me introduce our special moderator that will lead our discussion today. This session will be moderated by Mrs. Mergi Gayatri, SST MSc. But before we begin, let me briefly explain about her background. I will share her CV first. Okay, as you see here, we can see that Mrs. Maggie already finished her master's degree in midwifery in University of Nottingham, which is the same as our speaker today. She also employment in the University of Brawijaya Malang as an assistant professor, which is it's still ongoing since 2019. And then we can see there's a lot of work experience as a lecturer and also as a midwife. The certification also we can see here, she already got a primary consultant of health management from Indonesia Health Management Consultant Association. There's a lot of research and grants that she already achieved since 2014 until 2022, which is recently. And then the other grants here the recently is community service revitalization of integrated health posts for child health in Banjarum village, Malang. And then in 2022, community services preparing women for first 1,000 days of life grants by PNBP, Faculty of Medicine, University of Brawijaya. There's a lot of publication, and I think you can see from 2020 until 2022, she active to publish her work. And then we can see also here, there's a lot of leadership skills that she already achieved in her life. I think it's very inspiring for us. So without any further ado, I think we should just directly greet our moderator here. Good morning, good afternoon. I'm so sorry. I'm so sorry. Good afternoon, Mrs. Vergi.
Yeah, I hope you could hear me okay, because I'm having a sore throat right now.
Yeah, that's very clear on me. So how are you today? Are you okay while you have a sore throat right now?
Thank you. Thank you.
Okay. Before we now I will give the screen and the time for Mrs. Mergi. Time is yours.
Okay. All right. Thank you very much for very kind introduction. Yeah, I hope you could hear me okay right now. And then, yeah, good afternoon, ladies and gentlemen. My name is Mergi, the moderator of this session, and I'm very grateful to be able to be the moderator here today. And then before we go to the lecture in this session, I'd like to introduce you to our honorable speaker. Could you please share the CV, please? The committee. Yeah, could you please share the CV of Louis Walker here? Yeah, or probably I can share mine because I have her CV. All right, so yeah. Our speaker in the session is Louise Walker. She is an associate professor of midwifery at the University of Nottingham. And then currently she holds a provisional lead for midwifery since September 2020, also lead midwife for education, faculty global engagement lead for education since September 2021. And then she is also a school lead for global engagement from January 2022. And finally, UNICEF BFI lead for division of midwifery. And then currently, as I told you, that she is teaching at midwifery at the University of Nottingham. And then this is her contact details. And yeah, she is also a member of professional bodies such as Nursing and Midwifery Council, Royal College of Midwives, and Association of National Teaching Fellows. And then she got some qualifications and professional and academic. And then the latest, I believe that it's a leadership and academy and management academy, a leadership and management academy in 2020. Yeah, and then yeah, she also has a history working as an associate professor right until now at the University of Nottingham, and then seconded a midwifery lecturer at the Montfort University, and then yeah, as you can see that she has also, you know, some have experience in international external work, including Ghana, Vietnam, yeah, Indonesia in 2016. And then, yeah, she's also focuses on education projects such as introducing midwifery students to the world of research, building the basis for evidence-based practice future leaders in 2019. And she is very active in publishing, in publication. And the latest one is Strengthening Research Culture in Midwifery, online seminar presentation at Midwifery Research and Scientific Publication, A Way Forward conference by APCAN Indonesia in 2021. Yeah, also in Brawijaya as well. All right, and other publications. Wow, I'm sure that all of you can't wait for his presentation. So I'd like to call Luis. Hi, Luis. How are you?
I'm very well, thank you. Hello, everybody. So it's a very early morning here.
All right.
In the UK. So it's still dark outside in the morning. But it's afternoon there. So good afternoon, everyone, to you.
Oh yeah, good morning, Luis.
Yeah, thank you.
All right, in this session, Luis is going to give a lecture like for 1 hour, and then at the end we'll have a Q&A session for about 30 minutes. And I would like to remind you, if you have any questions, so you can just turn on your microphone, and then, or you can send your question on the chat box. All right, so without further ado, I'd like to call Associate Professor Louise Walker.
Lovely. I'm going to share my screen. Can you confirm? Can you see the screen?
Yeah, yes.
You can see the, yeah. Lovely. Okay, so hello everybody. So as you know, my name is Louise Walker, and I'm going to talk to you today mostly about midwifery education, but also how we can be innovative in the way that we present that education, and also about how we can maybe increase the visibility of midwifery, because that actually has quite an importance in the way that we develop as a profession. So I know you've just seen my CV, but I just thought I'd give you a little bit of context to who I am. So you can see, you see me on screen, but you can see my other picture there, and you can see where I am in the United Kingdom. So Nottingham is right in the middle of the country. So compared to your country, we're quite small, and we don't have quite as many islands as you do, but we do have quite a few around the coast of the UK. So I've been a midwife for 22 years, and my clinical experience is working in a midwifery-led unit. So that's a unit where there are no doctors. Women come, we look after them during their antenatal period and intrapartum. So we care for them in labour and then care for them postnatally. I've been a lecturer here at the University of Nottingham, coming up to 10 years nearly, and have visited your country, and I'm about to come again. So I fly out to Jakarta next Thursday and arrive on Friday. So I'm hoping when I'm over in Indonesia, and I am coming over to visit you at Andalas University. So I shall see a lot of familiar faces and friends as I return. So where I want to start, just to bring us straight the way back to something that you all know, is what is the definition of a midwife? And so we do know that they have to have done a midwifery educational programme that is recognised within a country to be able to be successfully added to the register of any country, but also to say that you have the prerequisite qualifications to be at least legally recognised as a midwife. And the quote I've put underneath is that this care includes preventative measures, but also the promotion of normal birth and detection of complications of the mother and child, the accessing of medical care and other appropriate assistance whilst carrying out emergency measures. So the scope of a midwife from an international definition is quite wide. Dependent on countries, that can even become a little bit wider or can become a little bit narrower. But fundamentally, we know that midwives need to have completed an education programme. So you might be familiar with the State of the World's Midwifery report, the last one that was published in 2021. And what that really showed us, that investing in midwives saves lives. It improves maternal and newborn health, and it strengthens health systems. You know, we all know when sometimes people don't access health during their normal life, but when they become pregnant, they need to access help. So what that can do is, us as midwives, is actually have a really good public health facing role in order to protect the health and well-being of mums and babies. What this report said, that if we fully invest in midwives, then there's a potential to save 4.3 million lives per year globally by 2035. So that's really huge, isn't it? The amount of lives that we as midwives can share, save. So that's something that's really, really important. It also brought out that the ways in which women and newborns receive the care during childbirth really makes a difference to their health outcomes. So, you know, most women want kind, compassionate care. And if we as midwives provide that care, then the health outcomes again will be improved. We know that midwifery promotes women-centred care because it's women who get pregnant. And also midwifery-led models of care actually achieve the best outcomes. And I'll talk a bit about this in a slide, couple of slides time, to how much, if we provide good standard care, that actually the health of the women improves, but it also costs a lot less than full medicalized care. And this report said that if we develop conducive and enabling environment in which midwife-led continuity of care can flourish, including collaborative partnerships of other healthcare professions, then we know again that's going to help improve the care. So as I go through this presentation, we're going to talk about how, as educators, we can put that together in programs. So I just want to bring you some of the evidence that we know is an advantage of having midwifery-led care. And the Cochrane review is a robust review and database of research that's available globally. And if you look at what the midwifery-led care and models of care says in this database, we can see that it reduces the women's need for regional analgesia, so epidurals and spinal are a whole much less likely. This research, when they looked at the trials, actually showed us no difference between caesarean section birth, which is interesting, but women were much less likely to have an instrumental birth. And what that can say to us is actually when women need a caesarean section, midwives know that, they appreciate that, and the appropriate referrals are made for women to have that type of care. When women need, we as midwives can support women through different birth positions, which might prevent instrumental births. So we know that midwifery-led care leads to more spontaneous vaginal births. We saw in this work that there was no necessarily difference in the perineum to whether that was intact or whether there was any trauma to the perineum. But women were less likely to have a preterm birth. They were less likely to have fetal loss or a neonatal death. Less likely to have interventions such as amniotomy and episiotomy, and less likely to have a fetal loss less than 24 weeks. So you can see from this research that the impact that midwives can have on the care of women and then the outcomes is actually really substantial. And what it concluded was that women receiving midwifery-led care models were less likely to experience intervention and were more likely to be satisfied with their care. So the conclusion was that women should be offered more midwifery-led care where appropriate. So then the next question is, how do we educate midwives so that they're able to provide this type of care that the research supports? So I just want to talk through with you just how we, from a global perspective, can educate midwives, but also just talk through some things that might impact on the way that education is presented. So the first thing I just wanted to look at is what terminology do we use when we refer to midwifery? You know, we use the word education a lot, but we also use other words like training, development, learning. And what we need to think about is how do we actually define those words and how does that impact on the overall education of midwives? And are they the same or are they different? So, you know, all training in the UK is actually done at university level, and the minimum level is graduate. So BSc is the minimum level of training within midwifery, and it has been in the UK for getting on 15 years now. So the terms that we tend to use are more about education, whereas other countries who may not educate midwives to that level might use more of the word of training. Are you training a midwife to do the job? Other terms that we might need to think about is how we learn and how we develop. How do we develop our practice as midwives, but also how do we develop our learning? And those are the things that I think we might all need to debate when we're putting a program together. And the other thing is around, I've talked a little bit about the expected academic education level for midwives. And again, from a perspective of looking at it globally, where do we sit as midwives? So I've already said that in the UK, the minimum standard now is a degree that is earned via a university. We obviously have master's education, postdoctoral education, and moving on. But not all countries educate midwives to that kind of standard, and then that impacts on the type of midwife that is enabled to provide the care. So my next slide is going to show you the highest level of midwifery qualifications that are available in different regions, and also looking at high, middle and low income countries. And this was some data that was produced by the ICM. So you can see from the colour codes where we sit. So the yellow is a bachelor degree, so a BSc degree. So you can see all countries across the regions, Africa, America, Eastern Mediterranean, Europe, Southeast Asia, and the Western Pacific all do offer education at a BSc level. But there are still areas within the world that offer it below a degree level. Then you might be interested to see how many within these regions are supported to doctoral level. So how many midwives have a PhD? But we also need to think about what is that PhD in, because in a lot of countries, midwives who want to be educated to that level tend to step away from midwifery to do that, because there's not the expertise in the countries to actually support doctoral level education. It's interesting to see again what differences there might be within higher, lower and middle to income countries. And again, you might be interested to see that in higher income countries, there is still some countries that do not educate midwives to bachelor degree as standard. There are some operating at a lower rate. So these are the things that we do need to consider when we're putting a program together and taking us through. So I want us to then look at, well, why do midwives need this higher level of education? We want to work with evidence-based practice. And in order to do that, midwives, when they are being educated, need to understand what evidence is. So we need to educate midwives to at least a bachelor degree in order to enable midwives to look at this from that kind of level. When we're training below that level, it becomes that training. It becomes more about the skills of being a midwife rather than the academic skills, because theory and practice match together. We need to be able to have midwives who fully understand why we are doing something rather than just being able to do it. And when midwives are educated at this level of education, then that does improve the quality of care. It enables midwives to be able to create clinical guidelines because they know what the evidence says. We know that it improves safety because, again, midwives have a lot more of being able to look at the evidence and apply that evidence, and that improves the safety. We know that it improves the satisfaction of women and their experiences because of the level of care, the quality of care that they're getting. But it also is about career development, isn't it? I showed you the slide of midwives going on to master's degrees, going on to doing a PhD. And what we want is more of the general population of midwives to be educated to this higher level, because that, again, we know will improve the quality of care. So it helps with career development if midwives have that aspiration to move on, not only within their clinical career, but also within their academic career. We know that if midwives are educated to much higher levels, then they're able to step into leadership roles. And that, again, has a real big impact on how we as a profession are recognised within the wider healthcare systems, but also within society, of where we sit within society. I'm going to talk about research as we move on as well, but that's also key, so that midwives not only understand evidence and research, but also start to do research. It's about being an advocate for our women, but also advocates for ourselves as midwives. And that includes professionalism, of knowing that we as midwives are a professional body and we have an autonomy because our education is at a level. And this is where sometimes it might actually challenge the status quo between systems within health systems. You know, within all countries across the world, there are status quos within hierarchy. And very often it is the medical profession that are at the top of that status quo. But there's no reason why midwives can't be equal partners in that. And if we're educated to the right standards, then we can actually do that. It also supports us changing things, because when we know the evidence, we can see what's happening within our maternity services and know that that might be non-evidence based. So what we can then do is put change management in order to enable safer care and evidence-based care. And this really comes down to us being critical thinkers of when we're looking at research, that we're not just looking at from what it says on the paper, but we're having that real critical mind about what this paper says and then applying that. So having a critical eye is, again, really important. So I'm sure I'm not telling you anything you don't know, because you are all hopefully midwifery educators, and you are striving to educate midwives within Indonesia to this higher level. But I think bringing it back together of why do we need this will hopefully give you some power to talk to higher people within the universities, but also within clinical settings, to why midwives need this level of education. So there is some evidence to support us doing this as well, because we are obviously evidence-based. So in 2014, The Lancet ran a series on midwifery. And what that really did highlight was the quality of care, and how if we could put in an evidence-based framework to this care, then that would really improve the care that women receive. Now, this paper has become one of the most influential pieces of research. It's an example of the impact that education can have on the philosophy and the implementation of midwifery education, and then the impact that has on maternity services. And again, within this paper, it looked that if midwives have an impact within family planning and interventions for maternal and newborn health, then they could avert a total of 83% of all maternal deaths, stillbirths, and neonatal deaths. So, and this is backed up by what the State of the World's Midwifery did in 2021. So you can see the trail of evidence that is supporting each other. So within the UK, this Lancet series really influenced our pre-registration midwifery standards that we've put together. We have the Nursing and Midwifery Council in the UK, who then looked at this evidence and put together some standards for midwifery education. And that is based on this level of research. But there's also some global evidence that you are probably aware of. The World Health Organization in 2020 looked at how we can strengthen the quality of midwifery education. And this is for universal health coverage. And it's got that framework within 2020 that it looked at. And again, this backed up that if over 80% of all maternal deaths, stillbirths and neonatal deaths could be averted if midwives have quality education at an international level. So, you know, the evidence for us moving forward with our midwifery education is out there globally. And this plan put together a 7-step action plan to try and strengthen midwifery education. What it wanted to do is strengthen the leadership and the policy that's put in place. It was about the gathering of data and evidence to support education, which we know is there. It's about the public engagement and advocacy. And I'm going to talk about this in the next few slides of how we need to include some stakeholders in putting education together. It's about preparing educational institutions and practice settings to enable the education of midwives, because we can't do it in isolation in education. It needs to be have a clinical component again. It's about strengthening the faculties that we work in. It's about strengthening our standards and strengthening the curricula that we put together. And it's about then ultimately how we educate our students and then monitor, evaluate and review. And over a period of time, you know, having reviews of our curricula to enable us to stay up to date and contemporary, and also to ensure that we are doing what we want to do, because evidence moves on. So we do always need to revert back to the evidence and see whether it's still supportive. And that, of course, is what we have done. We in the UK, we worked on the Lancet series of 2014, but we know that the World Health Organization backs this up, and also the State of the World's Midwifery also backs it up. So it's continually reviewing the evidence in order to ensure that we're providing good quality education. So the next thing I want us to do is look at how can we develop then an innovative curriculum. So one of the things that is coming out from the evidence is putting a curricula together that is co-created. Now, as midwifery educators, we are the experts, but we're not the only experts in putting curricula together. And very often we need to listen to our students, so past students, current students, to see what the impact of the education programs that we run have on them, what methods work best for their learning, what methods don't. So actually listening to our students is really important when we're putting a curricula together. One of the other really important ones is listening to women, listening to our stakeholders, because ultimately as midwifery educators, we're educating the next generation of midwives, and we are all midwives and we all have a passion for our profession. So we need to listen to our women. What is the impact of care on them? What works for them? What doesn't? What do they want from a midwife? And these are really all important things that when we're putting curricula together, we need to consider. So our voice of educators is also very important, but it's also talking to your clinical midwives who again, as they're practicing, what things are coming up in clinical practice that might actually impact the way that we are educating the future workforce. So really thinking about how we get together and talk. And so, you know, having stakeholder meetings at regular intervals to review curriculum and to put some things together actually might really impact. We need to see midwifery as a multi-dimensional profession. We need to think about how does that reflect the needs of our society, and also the health requirements of our women, families, and the communities. So seeing how we sit as midwives within our communities, again, is really important. And thinking about how that might be it could be initially from a really local level, as a big country, then you will have specific needs within a midwifery service, maybe for different regions. So it could be looking at things in quite a local aspect, but then considering it from a national, but also an international perspective. When we're looking at developing a curriculum, we need to look at that role of the midwife. We need to be dynamic with that changing context of healthcare. When I trained as a midwife 20 odd years ago, the healthcare systems that we were working with were very different from today. There was women who 20 years ago, if they had a congenital heart problem, they wouldn't be getting pregnant. Whereas now we are seeing women who are getting pregnant with very complex health issues, and we need to reflect that, and our role as midwife and our role within building a curriculum needs to reflect that. I've always talked about in the other slide, didn't I, about us being critical thinkers, and that again sits here and when we're putting that curriculum together. But we also, again, learn an awful lot from reflection, and that's reflection on practice that we might see, but also in practice of how we reflect. And actually building that into a curricula is really, again, important. So some of the things that we've introduced, that when our students go out and go on clinical placements, that when we come and bring them back in, we spend quite a while listening to them, they reflecting on the learning experiences that they've had. We can then unpick if there's been any issues or problems. We can discuss the theory that might have impacted on the care that they're reflecting on. And so how we become a reflective practitioner, again, is important that we build that into the curricula. The other thing I've put on here is about valued-centered practitioners. So we want to be both competent and also confident to provide that individualized care. And when we're basing values-based, so we're looking at things like compassion, courage, the way we communicate. There's values that we have that we want to build into being that practitioner, that midwife. We also want them to have that personal responsibility that being a midwife and being part of the profession has, and encourage that advocacy of women and each other. And the biggest one, and I've already mentioned it, is courage. Very often, we need to build our courage and our voice for the profession, but also for the knowledge that we have. So what I want us to then think about is how could a framework be put together that might support this? So I'm giving you an example here of a framework. So one is looking at whether your curriculum could be spiral. And what we mean by that is visiting aspects of care again and again. But what that does is ensures that individual learner actually really understands what is happening. It's about looking at things from different levels, but as we move in through our education program. So the things that we might look in a first year program, you might look again in year 2, but you're looking at it from a very different perspective. And again, in year 3, or if your program's a year 4, you're going back to aspects of the care that you're looking at. And what this enables us to do is to really make sure that your learners have embedded that knowledge. And then as they're looking at it again, they can apply that knowledge. One of the other things that we'll look at is whether you could include interrelated strands when you're putting things together. So if you can look, and hopefully you can see my screen nicely, what we have here is the interrelated strands are at the end of the purple arrows. So within the UK, we have the 6 C's, and what those C's look at are care, commitment, communication, competence, compassion, and courage. So those 6 C's underpin all of the work that we do, excuse me, and they are our interrelated strands. But one of the other things that could be added there is globalization. So again, whenever we're looking at anything, we're not looking at it in isolation, but we're looking at it from a global perspective. And then what we're also looking at is, to start off with, we're looking at how midwives learn. So how do they gain their knowledge? How do they acquire any skills? How do they demonstrate that knowledge? And then finally, how do they apply it? And that's when, if you, the example of a spiral curriculum covers all of those aspects for every bit that you're looking at. So that's just an example of how that could support quite an innovative curriculum, because you're looking at the program as a whole rather than aspects of modules maybe in isolation. So there's other things about what needs to be in an innovative curriculum. So we do need to have a structure that supports students in that acquisition, demonstration, and application of knowledge. There needs to be supportive learning, and there needs to be a conducive learning environment. So that's one thing that has to be in place, really. The other thing that we can look at when we're putting curricula together is what sort of theory practice ratio do we have? So for an example, in the UK, our standards require us to have 50-50. So 50% of the 3-year programme is in theory, and 50% of that programme is in practice. And it's how do we enable and put that together so that students can learn to apply that theory to practice. And the way that we do it here at the University of Nottingham is have a process where students have a block of theory where they learn, and then they go out on a clinical placement for a block to put that learning into practice. And then they come back in, we do some more theory, they go back out, they do some more practice. So they do it in theory blocks. So that is one way. There's other ways of having practice and theory running concurrently, so that on some days students are in doing some theories, and on other days they're in practice doing it. So there's different ways that we can put practice theory together, but it is an important aspect of looking at the curriculum. We're in an age now, aren't we, where digital is the way of life, and since COVID happened, this kind of thing has become more common. So we need to look at how we can use digital learning and platforms to actually support learning. So that's something, again, that is developing in everywhere throughout the world as technology improves. I've mentioned this point before, but we need to make sure that we have high quality midwifery education teams with strong midwifery leadership in education and research. So when you're building, and when we're building faculties, when we're building teams together, we want to have that expertise, we want to develop that expertise, but we also need that leadership so that we can take that forward. So if you have an example at this moment in time, you could see from my CV, I'm the lead midwife for education at the University of Nottingham. So I have, that is a leadership, it's a strategic position within the university that supports the learning. And that's alongside other professors that are within midwifery that support research. So that overall we've got some quite senior strategically paced midwives that are impacting on the university and the faculty, as well as midwifery education. Now, there's also a need to really get into professional learning into our curricula. And we talked about the midwife being that multi-dimensional professional. You know, midwives don't work in isolation. And what we need to establish is that interprofessional learning, very often from early on in a student midwife's program, so that that is embedded again within their learning and within their practice. We know from quite a lot of the safety reports that come out that if professionals work collectively and collaboratively, then the safety of women is improved. And what that interprofessional learning needs to have is professional respect. So, you know, as midwives, we have education, we have the evidence that we are partners in that interprofessional learning, you know, and it's trying to actually lessen the hierarchy of interprofessional learning to make it more partnership learning, and that we know supports the safety. The other thing that you might want to think about is authentic assessments. So as a university, they're getting a degree, they have to demonstrate that they can meet that educational level of gaining a degree at our universities. But we also want to make sure that they are good midwives, they're competent midwives. And so actually having some assessments within a curricula that are authentic can be a really good way to take things forward. And one of the ways that we do that is via OSCE. So it's actually an objective, structured clinical examination where, in a very safe setting of the university, students are examined on their clinical skills. And we run within our program, we run OSCE assessments in all years of the program, starting from something very basic in year one, such as an abdominal examination, some breastfeeding skills, right up into year 3, where they're doing newborn life support. So they're doing neonatal resuscitation as an OSCE. So, and that is something that they will do when they practice, so it becomes authentic. Another example of authentic assessments are doing some oral assessments. We've already said that we want midwives to be partners. We want them to be able to work interprofessionally. So we need to really test our students to see whether they are able to form an argument, but actually present that verbally, so that we have some assessments that are based on either presenting a poster or actually a debate where they have to support an argument with evidence. And then that's what we're hoping is that when they go out on clinical placement, they're able to discuss the evidence quite confidently because they've been assessed on that during their curriculum program. And the last thing, we need to be global, don't we? We are in very much a global environment, and we learn from each other. So you know, bringing in that global perspective into the curriculum actually does help with learning. And it also might have some sort of impact on, again, the health and well-being of our women and our newborns, because we can share good practice from a global perspective. So just some little things that I just wanted to bring together of how we put together our teaching to support this kind of curriculum. So we have something that we call blended learning. So some of our students we have a mixture of whether that's face-to-face teaching with us stood at the front, or whether it's very much that the students have done some work and they come and then do group work within the classroom, and we are facilitators for that, but we're not directly teaching them. We also do a lot with problem-based learning, or it's also called inquiry-based learning. And so that giving the students a problem to consider, and then they go off and find the evidence that would support it and then feed back. So they're actually partners in their own learning. It's not just relying on us as educators to say, this is how you do it. We know that there's a great chance of learning if we make it, again, authentic. So we talk about case studies. So a lot of the time within teaching is actually bringing case studies so students feel that it's quite real. You know, this is a scenario, what would you do in this situation, and bringing that together. And then more formally, there is some work that is done on a flipped learning. So I'm just going to click onto the next slide, and I can talk you through what the definition of flipped learning is. And it is a pedagogical approach in which like direct instruction moves from group learning space to an individual learning space. So it's almost like turning the classroom upside down in some respect. And this is something that we looked at a number of years ago, to how we could incorporate the flipped learning, the flipped classroom pedagogy approach, to see whether that again would improve our learning. So this is again an example of a flipped learning model, and we called it FLAME because it was flipped learning and midwifery education. And what we wanted to do is increase the knowledge as students progress through a topic. And what that meant was that students would do some aspects of learning. So that might be from a problem, from a case scenario, but they would need to look at that problem and then go and do some work themselves before they would come into the classroom and have a facilitated session where they would need to apply and critically analyze that knowledge. And then following that, they would then go back and do some additional learning themselves in order to really bring on and understand and remember. So, you know, what we're doing is moving down the triangle and up the triangle. So we want students to not only, you know, remember and understand, but then taking things right to the top and being a little bit more creative. So this is an example that we've used. I've got some slides here of just some examples of how we've used technology to put together some learning packages that the students could do to support that first part of their learning. So this is an example of just international midwifery, and what they do is it's put together in something that we call an RLO, a reusable learning object, and they work through it. It has some little quizzes through it, so we can kind of check their understanding, and it also might have some other specifics that they would go on to, but putting together some digital learning. So this is how we're combining that innovative curriculum design to really build on the learning. So I'll move on and bring it together now. It's the second part of the question I was given, is how do we increase the visibility of midwifery? And we all have a part to play in building this from our local levels, from national levels, and from international levels, so that we can see how we as midwives can improve that visibility. So there's lots of different strands, isn't there? And this is one of the things that I'm trying to bring together in this slide. So we as midwifery educators have a part to play in making midwifery visible, making it visible within universities, of having programs available for potential students to say, I want to be a midwife. And the promotion that we do to get midwives onto our programs, you know, and that can be like open days and putting seminars on to encourage people to want to come to university to be a midwife. So we as educators have that aspect of what we need to do. I've talked about research a little bit, but again, midwives, we need to have a research strategy for midwives. And again, that becomes local, national, and globally, because we know that midwifery research, especially done by midwives, actually addresses the problems that we might want to solve. We can get this feedback from women and what we need to do to support women. And so midwives doing research is so beneficial to the profession, the visibility of midwifery, but also ultimately for the safety of women. So as midwifery educators, as midwifery researchers, we have a big part to play in making midwifery visible. That also comes with the recognition and also with leadership. So again, having midwives in senior leadership roles, having professors of midwives in our universities, you know, giving people that strategic, visible role, so that when you're interacting with wider universities, that midwifery is known, it's a known profession, and it's recognized there. But also we think about the clinical practice side of things, and how are midwives viewed in hospitals within that hierarchy system. You know, how are we viewed as within the general population, within our cultures, within our communities? You know, is being a midwife seen as a good profession to enter into? And again, sometimes the perception of midwifery is something that we need to work on in order to promote our profession. There's opportunities, there should be opportunities for clinical midwives to also take part in research. So within our hospital settings, you know, is there research groups within those hospital settings so that midwives can have clinical research careers? Can your midwives have clinical education careers and be recognised in both aspects? So all of this really will widen the perception of our profession within institutions, within our society, and that visibility is something that's really important. Now, from some respect, and even in the UK, you know, research by midwives is still considered quite a young phenomenon. Even internationally, there are some very good midwifery researchers, but when you compare it historically to like medical research, then we're still very junior, very young in that development. So and I know that a number of you are getting into research, which is really, really good. And it's about then sharing that research and sharing that global knowledge so that it can be incorporated. Again, that all adds to making midwifery visible. So as I come to a close, what I want us to do, and I brought this quote, is from Sudan, who is a professor of midwifery in the UK. And I kind of think this quote brings together so clearly what we are as midwives. And she says that midwifery knowledge at its best recognizes unique normality, responds ahead of absolute emergencies, constantly assesses the complex situation of a birth, pregnancy, or postnatal episode, and constantly factors in the woman herself, her family culture, and her particular philosophies, ideals, hopes, and aspirations, as well as the formal evidence base. And that, as I think, comes together with a massive demonstration of what we as midwifery educators, what we as midwives, as midwife researchers, what we are about and what we're aiming to do. And we can really see that scope of our practice. And then finally, it's just bringing it back to why we are midwives. And we know that we play a massive part in a woman's birth experience. You know, from the moment that she enters maternity services to the moment she leaves with her baby, the care that she receives needs to have a positive impact. And if we as midwives can give women that positive impact, then we know from the State of the World Midwifery report that that has a huge impact on their health and well-being going forward, and then ultimately on our healthcare systems, because if we have a healthier population, then our health systems will work in a much better way. So that's all the slides I have. So I'm going to stop sharing there. And I would very much welcome any questions and comments on what I've said. So I'll hand it back to you, Mergi.
All right, thank you very much, Louise, for an amazing presentation. A lecture, yeah, I guess. And then what an ending, because it's very strong, right? It's like a kind of reminder for us that actually midwives has very, you know, amazing job, right? It's yeah, I think it should be very insightful for all of us here. And now we are coming to the Q&A session. So if you have any questions, please, yeah, you can turn on your microphone so you can ask your question directly to Louise. So anyone who wants to give a comment or question to the lecture that Louise has delivered. Hello? No? Okay. Oh, okay. So we're having the first questions. She is asking from Mawan Frisanti Naibaho. Thank you very much for the question. So this is very interesting. How could your campus or your university to involve midwives at the hospital to increase skills of the student midwives at your university?
Okay, yeah, no, good question. What we do encourage our clinical midwives is to actually be involved right from the start. So we interview all of our students before they come on the course. In order to get a place, they have to have an interview. And what we do is we ask our clinical midwives to come and support us with the interviews. So they have a part to play in even selecting the midwives who come on our program. And then we also ask them if they want to give either sometimes a specialist lecture on an aspect of their work, or also come in and help with the clinical skills teaching that we do. And also the OSCE that I talked about, the assessment, then we invite midwives, if they want to come in and actually be part of the assessment so that they can see how our midwives are being assessed. And I think when they understand what we're doing in the university, then that helps when they're seeing our students on clinical placement, because they're aware of what we do.
Mm-hmm. And then you mentioned about the interview. Could you please discuss further about the
Yes. So in order to come on our programs, the applicants put in a personal statement so that we can see what their experiences are and what their motivations are to become a midwife. Then they come forward for an interview, and when we interview them, we ask them, when we talk about the values base that I mentioned in the presentation, we do a values-based interview. So what we're trying to see if our potential students have compassion, confidence, courage. So we are looking at how they answer the questions, and very often we give them some scenarios to answer, so that we don't. It's not just a basic ask lots and lots of questions. We give them a scenario and we give them some 5 minutes to answer that scenario. And what we're hoping to get out, say, is that value base, but also we're looking mostly for what we call emotional intelligence. So, these candidates are not yet midwives, but we provide them with a lot of information on our website, and if they've actually looked at that, is, you know, so they understand what a midwife does, understands that compassion is needed. And I think so we ask questions and put them scenarios so that we hopefully bring out those values-based principles right from the start, and then we build our curriculum around those values.
Well, I mean, it's interesting that you also involved in the compassion. I mean, how do you measure whether the students have compassion?
Compassion. So when we have quite a strict marking grid. So dependent on how they answer, they will be given marks for compassion. So, you know, we could have a scenario where we're asking them what they would do in a situation. So, you know, if they bring out that they would consider other people who might be witnessing whatever was happening, then that again shows compassion for other people. So, you know, they can demonstrate in their answers that they give on how that looks. So if I give you an example of a scenario we give them, we say that they've heard another student midwife talking very loudly about a woman and her care in a public area, and we ask the candidate what would they do in that situation. So, you know, the standard answer could be, yes, they would escalate this and report it to their tutor and take that forward. But the compassion side would be that they would be thinking about who's also listening to it in this public area, and how listening to it could impact on them, and how this student talking about a woman, how might that impact on that woman herself. And that's where you're then picking up that they've got some compassion because they're thinking about other people.
Yeah, okay. And then, but you said that you also, you know, involve the clinical midwives, right, in the lecture.
Yeah.
Okay. Let me try to translate in Indonesia just briefly. Jadi tadi katanya Louis, kalau misalnya di sana itu memang dilibatkan ya, yang bidan-bidan yang di lapangan itu, yang di rumah sakit termasuk itu, dari mulai pembelajarannya sampai assessment-nya juga ada gitu, dilibatkan. Kemudian tadi beliau juga menyinggung tadi ya, assessment yang pertama kali yang dilakukan kepada calon mahasiswanya itu lebih ke emosional juga ya. Dan juga kalau compassion itu kayak di kita itu kayaknya kadang susah ya nyari translation-nya yang benar ya apa gitu. Sebenarnya itu kayak rasa peduli, kayak kalau literally-nya kalau diartikan ya di Google Translate itu kasih sayang gitu dengan pasiennya, atau kita sebut klien ya kalau di kebidanan. Nah, mereka juga ngasih scenario ke calon mahasiswanya kalau mereka gimana tuh kalau misalnya menghadapi seperti itu. Nah, untuk menilainya tadi contohnya beliau bilang misalnya mereka ngomong kenceng banget gitu, cerita tentang klien ini gitu. Nah, itu kan udah kelihatan kalau dia tidak memiliki rasa yang care gitu ya, atau tadi compassion tadi ya kepada kliennya. Ya, kurang lebih seperti itu ya tadi yang sudah disampaikan oleh Louis. And then we are moving on to the next question. I think there are Bara, Ibu Bara Renita. Yeah, could you could deliver your question?
Okay, thank you. Hi, Louise, how are you?
I'm very well, thank you.
Good morning.
Good morning.
Yeah.
Or good afternoon to you.
Thank you. Well, actually, I need your suggestion because it's kind of like a big question that I have since a couple years ago. Well, I'll give my little bit background. I was working in a primary healthcare under a district health department in Bandung City. You've been there, right?
Yes, I have, yes.
Yeah. So I worked there as a clinical midwife, and I've been working there for 5 years and a half. And I have a big question because part of my my career, I want to have experience in both sides, like as a clinical, also doing research. But as a clinical midwife working in a public health facility, I only have opportunity working as in clinical practice, but I didn't have any opportunity to do research. So do you have any suggestion for us who are working in a clinical setting? But yeah, for us, for example, if you are working in a university and you have like hospital, then you can work there with the patient and also you can do research in your university. But for us, for example, me, I didn't have that kind of opportunity. Then what's your suggestion for us? Thank you.
Okay, yeah. So one of the things, and I don't know whether it's commonplace within Indonesian hospitals, but having a clinical research group is very common in the UK. So so one of the things that it might be asking within your hospital whether there is a research group. That's more than likely, I would suggest it might be from a medicine perspective, that they're doing clinical research from a medical perspective, but it's about introducing to say that you would want to be involved, and also then say it's about, as I've talked about, improving that visibility of midwifery. So I don't think this is going to be necessarily a very quick solution, because if we go back 20-30 years, for us we didn't have clinical research midwives employed by hospitals, but now we do. So and it's taken time in order to build up that the importance of research around midwifery, and that's something that we all need to do, but from an individual basis, I'd suggest you make some inquiries within your hospital to see what research is being done in the medical side of things, because I would imagine that is being done, and then you might be able to speak to people within the hospital to see whether there's any opportunities for you to be involved, and whether that could involve any more midwifery focused research. But I don't think it's a quick process, because these things do take a little bit of time. But I think just asking the questions of whether it's possible is the first step.
Ya, Bu Bara, apakah sudah jelas untuk jawabannya? Atau do you have still any questions related to this, Bu Bara? Oh, okay, yeah, I think it's clear enough. And well, I mean, it's very interesting question. Because I mean, it's not common in Indonesia. Clinical midwives have kind of opportunity to do research in clinical settings, and then even when we are in academia, it's also limited for us. It's still challenging, to do research, especially clinical ones. So yeah, I think this is like we have to work together, and thank you for your suggestions. You have to speak.
One of the things I might just suggest is obviously, as university are looking at putting research bids together to get and one of the ways to do that is if within your bid you try and bring in a clinical midwife. So some of the research that I did in Ghana a few years ago, we needed clinical staff in Ghana to support the research. So we as a university put the bid in, but part of that bid was to include a clinical midwife in Ghana to take that research forward. So that's another aspect within universities, that when you're putting bids together, that you see if there's any clinical staff you can put within that bid.
Yeah, it's true. I mean, we can involve midwives, right, in clinical settings in our research from academia. Jadi tadi beliau sampaikan untuk Bu Bara yang pastinya berkomunikasi yang pasti sampaikan mungkin yang di rumah sakitnya apakah ada yang kemungkinan bisa ikut gitu di dalamnya gitu penelitian, atau bisa jadi kita bekerja sama gitu yang ada di universitas gitu akademik, mengikut sertakan bidan-bidan yang ada di klinik gitu, di lapangan gitu. Memang, dan setahu saya ada beberapa penelitian yang besar gitu yang ada di Indonesia yang memang juga melibatkan bidan And actually, in Indonesia, there are some very good research, big research funded by international NGOs, for instance. They also actually, involve midwives in their research, but usually they are just like, someone who take the data collection. Yeah, so not that like a primary researcher. But I think it's a good step, to learn research. All right, so yeah, thank you for the question. So we are moving on to the next questions from Ibu Risva Febrindra. What to explore in order to involve women to develop curriculum?
Okay, so again, I can give you an example. We've just last 18 months, we've put a new curriculum together here at Nottingham. So what we did was we invited some women into a focus group and said, what do you want from a midwife? So they talked about they wanted a midwife who was compassionate. So that word comes up a lot. They wanted a midwife who could communicate. They do want competent midwives, but they want midwives who are caring, kind and compassionate. And so when they gave us that information, that actually supported us taking through some like some of the assessments. So one of the assessments where students need to present, so we wanting to build to know that they can communicate orally and do that. We put together something that we call case holding scheme, and women have a student midwife who follows them through their care throughout the whole of their pregnancy. So they the women really appreciate that and enjoy that type of scheme. So obviously there's a midwife who is responsible for that woman's care, but the student follows that woman through the whole journey of her pregnancy and birth. And so what the student does is get to know that woman and appreciates that if women have a good relationship with their midwives, then again, we know care is improved. So, and when we talk to women, these are the things that they tell us they want. So we will try and put that into the curriculum.
Thank you, Louis. Jadi apa yang sudah disampaikan dari Louis tadi itu mereka juga mengadakan FGD ya sebelumnya untuk melihat apa sih gitu yang bisa dilakukan gitu. Kemudian mereka juga ada skema di mana mahasiswa itu akan mengikuti seorang perempuan itu gitu. Kayaknya kalau di kita itu kan ada ya di akademik gitu, mahasiswa profesi yang kita kenal dengan COC ya kan, mengikuti mengikuti klien ya, dari mulai dia hamil gitu sampai setelahnya dia melahirkan, dan itu adalah cara mereka juga untuk memasukkan ke kurikulum gitu agar mereka tahu bahwa dan juga bisa mengajarkan mahasiswanya itu untuk bisa mengenal kliennya gitu. Nah, tadi masih ada kaitannya yang beliau bilang, yang compassionate, terus habis itu juga harus emosionalnya ya, yang dari kalau inteleknya yang tidak hanya dari kognitifnya saja begitu ya. Okay, well, thank you for the questions, and then any questions or comments, or maybe you want to share your experience, yeah? Because we have many midwives here, and I believe that most of you, or each of you has a different experience, yeah, in your setting. Okay, so we have another questions from. Let me check. I cannot see who raised.
There is a hand raised.
Yes. Yeah. Could you please deliver your questions because I cannot see the name. Oh, okay. Ibu Siti Hanisa. Ya, silakan Ibu.
Okay. Thank you, Kak. First of all, I'm very happy to meet you and have this such an opportunity to be lectured by one of the expertise in this field. Although we only meet it through online, but it doesn't reduce the adequacy of the information that you're trying to provide to us. So thank you. When I went through the clinical phase, where I had the opportunity to feel the real atmosphere in the healthcare facilities, and it's put into practice the knowledge that I already gained in undergraduate stage. But unfortunately, it's the situation of pandemic COVID outbreaks. It's interrupt my phase at the time, so that for the sake of safety, everyone should stay at home. That I'm sure the crisis have also happened everywhere, anywhere, and will certainly affect the entire learning curriculum, you know. But I don't know for sure the situation in the UK, but I really want to know, and I'm curious how the midwifery department at Nottingham did alternative learning at that time, because like you said before, it needs to be a 50-50 ratio between learning and practice. So I also wanted to know how the tactics of the educators in order to catching up the lacking experience of the students at that time, because I'm one of the students at that time. Thank you.
Okay, so when the pandemic first came to the UK, it was March 2020, and that's when our country went into full lockdown. Everybody had to stay at home. At that point, we made a decision to take our students away from clinical practice. So they stayed at home, they didn't go on placement. And what we did, we delivered all of our content online we use MS Teams, not Zoom. So we did all of our teaching online, live. And whilst the students, because they couldn't be on clinical practice, we moved all of the content that they would have had later on in their program, and we brought it forward. So they had very much front-loaded teaching. So everything that we would have delivered, apart from the teaching of clinical skills, was delivered. When, after the first lockdown, our students went back out and they then caught up with their clinical practice when they should have been in university, because we'd already taught them the content. So we were able to then actually get back on schedule for programs, because they'd had all of the theory content and then they'd managed to get their clinical placements. And early on, as we went into other lockdowns, we continued with our online teaching, but we still actually came in and did face-to-face clinical skills teaching, but we did it in full personal protection. So we did it in masks, we did it in visors, we did it in gowns, so that we prevented the risk of passing on COVID. But we did bring back clinical skills teaching earlier than we brought back theory face-to-face teaching. So all of our students now are back on track and have caught up with, and our students have qualified on time, which we're very pleased with.
Ya, gimana dari Bu Siti? Yeah, I think it's clear, ya, the explanation from Louis. Ya, jadi sama saja kan sebetulnya kan di UK juga ya, mereka stop gitu, tidak menurunkan mahasiswanya untuk praktek di lapangan gitu, karena memang situasinya memang tidak memungkinkan ya pada saat itu ya. Dan mereka juga akhirnya juga mengajarkan online gitu. Kalau mereka tadi bilangnya nggak, bukan Zoom ya, yang lain gitu platformnya untuk mereka. Tapi sekarang sudah mulai kembali gitu ya. Okay, well, actually we still have like 5 minutes left. So if you still have any questions, share your experience. Yeah. Tadi terima kasih Mbak Siti ya, who has shared her experience as a student. Right? So, and then she literally experienced that situation. Yeah, and then yeah, you survived. Thank you. Yeah. All right. So do you still have any questions or comments? And yeah, again, I think Maybe one last question, Luis. I'm still, wondering about compassionate, because I mean, I feel like it's quite hard to teach someone, right, to be compassionate, and then I can't sometimes, because it seems like it depends on that personality, and then how you build your students to be that compassionate to the clients.
Yeah, I think compassion covers a number of aspects, doesn't it? And I think, being compassionate educators, so that the way that we convey compassion to our students then is also important. We have a whole module on compassion. The very first module that our student midwives do is about compassion, and so that it's actually developed right from the start. So they learn a bit about the theory of compassion, and also we give them again some case studies so that they can see where compassionate care and why it's important, and we get them to talk about it. And when all's said and done, if we were being cared for, we'd want someone to be compassionate to us, wouldn't we? So it's trying to bring learning together so that the people can relate to it. And if you would want somebody to treat you in such a way, then you should treat others in that way as well, and having that as a philosophy of care. So and it is also part of the students are assessed on compassion as part of their clinical assessment. So it's very forefront in our curricula, so that we put that importance on it.
Well, what's the difference with the respectful care?
I think it's respectful care is about compassion as well, but respectful care is knowing that the person you're caring for has rights and has a voice, and we should be partners in care. So somebody could provide respectful care, but they might not necessarily show them true compassion. So it is very similar, but sorry, it is very similar, but not necessarily exactly the same. Respectful care takes in to beyond that basic compassion, but being enabling the women that we care for to have a voice, to be respected, and not to be abused during the care that they're receiving. So yeah, I mean that could be a whole session on its own, Mergy, couldn't it?
Well, thank you, Luis, for your answers, and also your insightful lecture for us today. And then we learned that midwifery education that we can improve, and then so not also that we can support the practice, as well as we also have a discussion on research as well here. And then thank you very much, Luis, for your lecture, and then thank you for all the participants, and then this is a very amazing conference, to be honest, because UNAND holds this conference annually, and then this is a good start for, I think, Indonesian midwives in general. Okay, thank you for all kind of attentions. Sampai berjumpa lagi. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Luis, and I'm give it back to the MC.
Hopefully, I'll see some of you in the next when I'm over in Indonesia. I look forward to it.
Yeah, I'm looking forward to meeting you.
Thank you.
Okay, thank you. We would like to thank our moderator, Ms. Mergy, for help to direct us through this session. We also hope that you're getting better sooner from that sore throat, as well as the excellent speaker in this third session. Thank you very much for the very enlightenment presentation from Ms. Wolf. Okay. Ms. Walker. Now, we will begin the last session of our conference today. The keynote speaker for this session is Dr. Emi Nurjasmi MKes, yang mana beliau adalah Ketua IB Indonesia, with the topic of midwives step up in practice and regulation, the importance of association for sustainability midwifery care. Okay, this last discussion will be led by Bu Aldina Ayunda Insani, BD MKes, as a moderator. But firstly, let me give a brief explanation about her background. Oke. Sudah terlihat di layar ya. Berikut adalah CV beliau. Saya mohon izin untuk menjelaskan dalam bahasa Indonesia. Selanjutnya, jadi Bu Aldina Ayunda Insani ini sudah memulai sepak terjangnya dalam dunia kebidanan dan pendidikan kebidanan sejak tahun 2006 dan secara bertahap terus mengejar mimpinya, terus mengejar gelarnya sampai ke di 2016 meraih gelar magister di Universitas Andalas Sumatera Barat. Dari pengalaman penelitian beliau juga sudah sangat berpengalaman sejak dari tahun 2016 dan melalui pendanaan yang bermacam-macam, ada yang LPDP, ada yang PNBP, kemudian ada yang LP3M, dan juga terakhir itu sebagai ketua pada tahun 2020 Midwifery Skill Block 6C, Infection and Neoplasm in the Reproductive and Breast System, yang dibiayai oleh LP3M Universitas Andalas. Juga beliau menghasilkan banyak sekali karya ilmiah, mulai dari buku, jurnal, dan artikel yang sudah terpublikasi pada jurnal-jurnal terakreditasi. Pada yang terakhir kali itu yang terbaru di tahun 2021, itu jurnal kesehatan berkaitan dengan faktor-faktor yang berhubungan kinerja bidan dalam pemberian pelayanan kehamilan. Beliau juga tetap aktif dalam publikasi lainnya berupa makalah dan poster, meraih beberapa penghargaan yang luar biasa sekali. Ini bisa kita lihat sepak terjang beliau dan sangat menginspirasi saya. Jadi beliau ini adalah dosen saya ketika saya masih berkuliah di kebidanan UNAND. Baik, mungkin langsung saja. Selamat siang Bu Yunda. Apa kabar Bu?
Ya Ani, alhamdulillah sehat Ani.
Baik Bu, selanjutnya Hani serahkan layar dan juga mikrofon kepada Ibu. Silakan Ibu.
Terima kasih Hani. Baiklah ibu-ibu semua, kita lanjut untuk kegiatan hari ini, di mana saat ini kita untuk narasumber selanjutnya adalah Ibu Emi Nurjasmi yang memang tidak asing lagi bagi kita semua. Namun sebelumnya karena partisipan kita saat ini yang bergabung, Yunda lihat mayoritas adalah kita Indonesia. Mungkin kita lanjutkan kegiatan kita yang sore ini dalam bahasa Indonesia. Baiklah, kita undang terlebih dahulu Ibu Emi. Assalamualaikum Ibu. Assalamualaikum Ibu. Mungkin suara apakah dari, mohon izin Ibu.
Ya, udah, baru di unmute.
Oke.
Ya.
Selamat siang Ibu. Alhamdulillah
siang.
sehat ya Bu.
Alhamdulillah.
Nah, terima kasih Ibu.
Ya.
Alhamdulillah Ibu sudah hadir bersama kita di sini walaupun dengan banyaknya dan padatnya aktivitas Ibu baik dari dalam maupun di luar, dan alhamdulillah Ibu menyempatkan dalam kegiatan kita saat ini dan merupakan kita sangat apresiasi juga Ibu dukungan penuh dari Ibu dalam kegiatan kita saat ini. Baiklah ibu-ibu peserta webinar kita hari ini, di sini narasumber kita adalah Ibu Emi Nurjasmi yang merupakan di sini sebagai Ketua IBI, Ketua Pusat IBI. Kemudian di sini kita baca terlebih dahulu kurikulum PT Ibu, di mana lahir di Sawah Lunto, yang merupakan juga orang awak. Kemudian jabatan saat ini adalah Ketua AIPKIN, dan juga beliau sebagai asesor BAN PT, Dewan Pendiri LAM PTKes, Vice President of Midwives Alliance of Asia, ICM Board Member, representatif Asia Pasifik. Dengan riwayat pekerjaan juga sebelumnya beliau merupakan bidan rumah sakit di Bukit Tinggi, kemudian bidan di Puskesmas Oransbari Kabupaten Manokwari Irian Jaya, kemudian staf Sudin KIA dan KB Dinkes Provinsi Jawa Tengah di daerah Provinsi DI Aceh, kemudian juga Kasubit Pendidikan Keperawatan dan Kebidanan Depkes pada tahun 93 sampai 2006, Kasubdit Bina Pelayanan Kebidanan Kemenkes RI, dan saat ini juga sebagai dosen Poltekkes Jakarta 3 dari bulan Juli 2011 hingga sekarang. Riwayat pendidikan Ibu, D3 Kebidanan, kemudian S1 Administrasi Negara, S2 Kesehatan Masyarakat, dan S3 Pendidikan. Baiklah, mungkin di sini Yunda tidak memperpanjang waktu di dalam untuk bagian awal, mungkin langsung saja untuk waktu diserahkan kepada Ibu menyampaikan ataupun sharing terkait dengan topik hari ini, yaitu Midwives Step Up in Practice and Regulation, the Importance of Association for Sustainability Midwifery Care, di mana di sini ibu-ibu semua akan membahas, Bu Emi akan membahas, menjelaskan terkait langkah bidan dalam praktik dan regulasi, pentingnya asosiasi untuk asuhan kebidanan yang berkelanjutan. Baiklah Ibu, Yunda persilahkan kepada Ibu. Lebih kurang waktu kita di sini ada 2 jam, di mana 1,5 jam mungkin bisa kita sharing, kemudian setelah itu kita lanjutkan dengan diskusi. Kepada Ibu, kita silahkan.
Wah, lama ya. Iya, baik, Mbak Winda ya.
Iya Bu, Yunda
ya,
Ibu.
Ya, baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Mohon maaf, saya lagi ada di satu event. Saya lagi mojok, ya mungkin agak rame. Kedengaran ya? Enggak?
Kedengaran Ibu.
Sebentar, saya tak tutup pintunya dulu.
Baik Ibu.
Wah, sama aja. Sama aja, Mbak. Sama. Rame ya?
Tapi alhamdulillah suara Ibu jelas, Bu.
Masih rame?
Enggak kok, Bu. Jelas kok, Bu, suara Ibu.
Iya, karena memang lagi rame di sini. Saya lagi ada pertemuan di ini. Kita lagi mau menyusun instrumen akreditasi untuk internasional. Jadi kita lagi ada meeting di UT. Baik, terima kasih Mbak Winda. Tadi saya sudah Assalamualaikum warahmatullahi wabarakatuh. Selamat sore dan salam sejahtera. Jadi ini yang pertama, sekali lagi saya memberikan apresiasi ya kepada teman-teman di Department of Midwifery di Fakultas Kedokteran UNAND yang sangat aktif sekali melakukan berbagai kegiatan dalam konteks bagaimana kita memperkuat pemahaman kita terhadap profesi. Tadi dari narasumber-narasumber yang luar biasa ya, saya juga sangat appreciate sekali kepada para expert kita, pada speaker kita. Thank you. Ada Louis, ada siapa lagi tadi?
Andrea Gilkensen.
Iya, Andrea.
Dan juga Leonie.
Dan juga Leonie. Jadi tadi saya mungkin nggak bisa mengikuti secara utuh juga karena sedang ada kegiatan lain. Baik, nggak apa-apa. Ini saya selalu ini internasional seminar, saya menyiapkan slide dalam bahasa Inggris ya, karena ya sekalian juga belajar gitu ya, nggak apa-apa. Jadi nanti kita coba diskusi dalam bahasa Indonesia. Yang diminta saya ingin izin share screen ya.
Baik, Ibu.
Sudah?
Sudah tampak, Bu?
Sudah tampak ya, oke.
Oke, Bu.
Nah, yang saya tangkap dari TOR dan juga dari tema yang diambil, bagaimana kita asosiasi profesi atau ikatan bidan ini berjuang, berupaya untuk kita dapat mempertahankan pelayanan kebidanan di masyarakat, ya, tentu dalam konteks pelayanan yang selalu meningkat sesuai dengan kebutuhan, berkembang sesuai dengan situasi. Inilah apa saja yang dilakukan oleh IBI ya untuk sustainability of midwifery care, bukan cuma midwifery care ya, sustainability of midwife as a profession, independent profession. Ya, itu yang kita lakukan. Dan alhamdulillah tadi mungkin juga sudah di beberapa slide, beberapa ini saya mendengar juga sepintas tadi. Sebetulnya memang membangun pengakuan stakeholder terhadap sebuah profesi itu bukan pekerjaan yang mudah, ya. Dan tadi disampaikan juga oleh siapa tadi yang dari UK? Yang barusan?
Louis Walker, Bu.
Ya. Louis?
Ya, Louis
ya.
Walker.
Oh, oke, Louis Walker. Ya, bahwa di negara-negara, banyak negara, perjuangan untuk pengakuan terhadap profesi bidan itu luar biasa dan tidak sama posisinya. Ya, tadi juga dari awal, mulai dari Australia dan lain sebagainya saya mengikuti tadi. Tapi enggak apa-apa, kita tidak boleh putus asa, itu yang kita lakukan dari organisasi profesi, kita selalu berjuang. Nah, bagaimana struggle-nya, bagaimana beratnya, tantangannya kita dalam perjuangan ini, bahwa kita alhamdulillah sudah memenuhi kriteria. Kalau kita lihat dari sini sebagai syarat minimal sebuah profesi, kita harus berpendidikan di pendidikan tinggi, sekarang kita sudah punya diploma 3, udah profesi, udah magister, dan insya Allah nanti ke depan sebentar lagi pendidikan doktor, ya. Kemudian juga kita sudah punya ruang lingkup keilmuan sendiri dalam konteks kompetensi. Kita sudah punya ruang lingkup juga untuk kewenangan praktek. Dan ini yang tadi dijelaskan juga oleh Louis ya, yang terakhir research based body of knowledge. Ini akan selalu berkembang setiap saat. Mas, tolong tutup, Mas. Akan selalu berkembang setiap saat sesuai dengan kebutuhan dan tentu saja sesuai dengan hasil-hasil penelitian. Nah, alhamdulillah ini kita di teman-teman kebidanan banyak sekali penelitian-penelitian tadi disampaikan juga untuk moderator saja betapa besarnya, betapa banyaknya penelitian yang sudah dihasilkan. Nah, kita dari asosiasi profesi sangat menunggu hasil-hasil penelitian itu untuk bisa memberikan kontribusi terhadap peningkatan kualitas pelayanan. Kemudian tadi kita sudah punya scope of work, kita punya kode etik, kita punya asosiasi, ya tentu sebagai sebuah asosiasi kita sepakat, kita berkomitmen untuk bergabung di dalam satu organisasi profesi Ikatan Bidan Indonesia, dan kita selaku pengurus yang terpilih tentu akan kita perjuangkan. Kita bekerja, berjuang, bicara untuk kepentingan anggota, kepentingan profesi. Ya, ini yang kita lakukan. Nah, ini dari ICM sendiri ini sudah bolak-balik juga teman-teman tahu bahwa memang pilar-pilar ini sangat penting untuk kita perkuat, untuk kita perkokoh agar pengembangan profesi kita ini stabil, selalu mengikuti kebutuhan, dan dari masa ke masa bagaimana supaya bidan-bidan ini memang dapat menunjukkan perannya dalam rangka kita berkontribusi bukan hanya untuk target sasaran. Kita bukan lagi bicara tentang kuantitas. Ya, kalau kita kuantitas, kita tahu hasil-hasil riset kesehatan dasar itu sebagian besar pelayanan itu dilakukan oleh teman-teman bidan, tapi kita akan bicara tentu tidak cukup bicara kuantitas, tapi kita bicara bagaimana kualitas kita yang dipercaya oleh masyarakat untuk dapat memberikan pelayanan yang berkualitas. Tadi disampaikan yang respectful, compassionate, dan lain sebagainya. Nah, ini pilar education, pilar regulation. Kalau nggak ada regulasi, yaitu tadi, rekognisinya, pengakuan terhadap sebuah profesi, itu sangat lemah sekali. Kemudian bagaimana asosiasi, ya alhamdulillah kita punya Ikatan Bidan Indonesia yang solid, ya mudah-mudahan kita selalu bekerja sama dengan stakeholders lainnya, baik teman-teman dari pelayanan, dari pendidikan, dari manajemen misalnya yang di kementerian dan lain sebagainya, serta teman-teman kami yang ada di asosiasi profesi. Nah, ini juga ICM tadi sudah disampaikan juga kalau saya tidak salah, tapi saya tidak mendengar ya. Bagaimana ICM professional framework itu kita bangun ya dengan berbagai komponen. Ya, kita melihat di sini bagaimana midwifery filosofinya, esensial kompetensi kita sudah tahu, esensial kompetensi bidan. Kemudian juga kita tidak cukup sudah punya regulasi, sudah punya standar profesi, nggak cukup itu untuk kita bisa memberikan peran yang lebih optimal lagi dan kita bisa berkembang secara terus-menerus. Kita harus didukung di samping di asosiasi, tadi sudah kita sampaikan, untuk berjuang demi profesi kita, demi anggota kita, dan lain sebagainya. Tentu ujung-ujungnya demi masyarakat ya. Kemudian didukung dengan kapasitas leadership ya, karena kita sebagai profesional kita bekerja sama, berkolaborasi dengan banyak pihak. Kita juga punya peluang untuk jadi pimpinan atau pemimpin di dalam fasilitas pelayanan kesehatan. Kapasitas leadership ini perlu kita asah secara terus-menerus. Kemudian riset tadi sudah disampaikan bagaimana membangun asuhan kebidanan berkelanjutan ya, midwife-led continuum of care. Kemudian tadi pendidikan sudah disampaikan dengan jelas tadi bagaimana pada saat pandemi COVID juga bagaimana mahasiswa melakukan praktek-praktek dan lain sebagainya serta regulasi. Nah, inilah yang menjadi concern kita. Kemudian ini tentu kita sudah memenuhi semuanya kalau tidak didukung dengan lingkungan kerja ya yang memenuhi syarat, yang dapat mendukung tugas-tugas profesi, tentu juga tidak bisa kita melaksanakan tugas profesi secara optimal. Seperti misalnya kita ditempatkan di desa, tapi tidak didukung dengan fasilitas, dengan sarana prasarana. Tentu sangat terbatas kita bisa memberikan pelayanan sesuai dengan standar-standar yang ada karena tidak tercukupi kebutuhan sarana prasarana. Ini yang harus kita perhatikan juga. Kemudian di dalam konteks kita sebagai bidan, kita juga punya filosofi bagaimana gender equality ini menjadi salah satu bagian dari paradigma kita. Ya, bagaimana perempuan yang sebagai target atau sasaran utama kita di beberapa daerah, di beberapa negara bahkan. Bukan cuma di Indonesia, yang namanya posisi perempuan itu perlu kita perkuat, perlu kita dukung sehingga gender equality ini harus kita upayakan. Nah, kita lihat berbagai regulasi yang sudah kita dapatkan ya sebagai upaya yang kita lakukan bertahun-tahun ya untuk undang-undang kebidanan lebih dari 15 tahun, alhamdulillah sekarang sudah terwujud. Nah, ini ada beberapa saja, saya tidak akan mengupas ini. Ada undang-undang kesehatan, tenaga kesehatan, kita masuk di situ, disitulah kita mulai berdiri sendiri. Mulai terpisah profesi kita dengan keperawatan. Kemudian kita tindak lanjuti dengan lahirnya undang-undang kebidanan yang mengatur secara utuh tentang profesi kita. Kemudian kita juga sudah punya standar profesi, kita juga masih menggunakan PMK 28 untuk pengaturan tentang penyelenggaraan praktek bidan. Karena itu tidak bertentangan isinya dengan undang-undang sehingga masih bisa dipakai sebagai rujukan. Kemudian kita juga sudah memiliki Kementerian keputusan Menpan berkaitan dengan penyesuaian untuk jabatan fungsional bidan merujuk ke undang-undang. Dan kita juga tadi standar profesi di sini yang mengatur tentang kompetensi baik itu D3 maupun profesi, dan juga di sini mengatur tentang kode etik bidan. Nah, ini yang baru saja keluar, kita juga ada satu standar kompetensi kerja bidan. Ini penting buat teman-teman praktisi karena ini nanti akan menjadi dasar bagi mereka untuk diberikan penugasan dimanapun mereka bekerja, baik di puskesmas maupun di rumah sakit. Nanti akan ada penugasan klinis. Nah, dari standar kompetensi kerja itu kita sudah merumuskan kompetensi kerja kita ada 25 unit. Nah, nanti di dalam kompetensi kerja itu dari 25 kita membuat levelingnya, dan itulah yang akan dipakai oleh teman-teman di rumah sakit. Dulu kita bicara credentialing itu berlaku di rumah sakit untuk dibuatkan surat tugas daftar kemampuan klinisnya. Tapi sekarang puskesmas juga kita sudah menyiapkan karena sudah keluar dari Kementerian Kesehatan, di puskesmas nanti juga akan diberlakukan kredensial seperti yang ada di rumah sakit. Ya, nah kita sedang menyiapkan itu dan ini akan berlaku untuk puskesmas maupun di rumah sakit. Dan persiapan di sini untuk kita membuat sistem penilaian kinerja itu sudah kita mulai sebetulnya dari 3-4 tahun yang lalu. Kita sudah melakukan pelatihan-pelatihan asesor di rumah sakit, tapi belum semua. Kita terhenti hampir 3 tahun dengan COVID, dan ini tanggal 31 Oktober kita mulai kembali melatih asesor untuk penilaian kinerja bidan di rumah sakit. Tanggal 31 besok akan ada pelatihan di Rumah Sakit Sutomo. Dan di Sumatera Barat juga sudah pernah di M. Jamil ya. Jadi sudah ada asesor-asesor bidan di sana. Nanti akan kita latih juga asesor-asesor teman-teman di puskesmas. Karena itu akan berlaku dan sudah keluar kebijakannya. Nah, di dalam undang-undang kebidanan itu kita mengatur, saya mengambil yang penting saja yang sangat urgent menurut saya. Di sini adalah pengakuan terhadap bidan itu sendiri. Ya, dia seorang lulusan pendidikan kebidanan, mau level D3 mau profesi itu tentu diberikan pengakuan sepanjang sesuai dengan persyaratan dan memenuhi syarat untuk bisa melakukan praktek kebidanan. Kalau kita bicara memenuhi syarat berarti dia punya sertifikat kompetensi, dia punya STR, dan untuk bekerja dimanapun dia akan bekerja, dia harus punya surat izin praktek bidan. Kemudian di sini juga memperkuat kita, memberi kekuatan terhadap pelayanan kebidanan itu sendiri. Bahwa pelayanan kebidanan ini adalah bagian dari pelayanan kesehatan. Sebagai pelayanan profesional yang terintegrasi di dalam pelayanan kesehatan yang diberikan, yang dilaksanakan oleh bidan. Baik bidan secara otonomi, dalam konteks kolaborasi, maupun dalam konteks kita merujuk dan dalam tim. Kalau kita di puskesmas bicara tim, ya. Kemudian di sini juga diberi pengakuan bahwa tempat praktek mandiri bidan itu adalah bagian dari fasilitas pelayanan kesehatan yang memberikan pelayanan langsung kepada klien. Ini penting. Ketetapan ini, ketegasan ini penting sekali oleh sebuah profesi. Inilah yang harus diperjuangkan oleh profesi kita dimanapun. Di negara-negara lain itu belum banyak ya. Tapi kayak di UK itu sudah sangat berkembang, sangat kuat. Juga sekarang di Australia, di New Zealand, di Belanda itu kuat sekali. Tapi belum di semua negara. Nah, kita perlahan-lahan mencoba bagaimana penguatan dan pengakuan terhadap profesi bidan itu secara utuh. Nah, ini yang diatur di dalam Undang-Undang Kebidanan. Alhamdulillah dalam undang-undang kita mengatur secara utuh dari A sampai Z, dari hulu, mulai dari pendidikannya, bagaimana registrasinya, bagaimana asosiasinya, ya, kemudian juga bagaimana bidan dari luar negeri, bagaimana praktek kebidanannya, bagaimana hak dan kewajibannya, kemudian bagaimana organisasi atau IB itu sendiri, bagaimana pendayagunaan, serta bagaimana monitoring dan pembinaannya. Nah, ini pendidikan kebidanan. Kita tadi mendengar juga di UK sudah bachelor langsung 4 tahun, hanya di kita tentu tergantung dari sistem pendidikan di masing-masing negara. Di sistem pendidikan kita tidak bisa langsung menjadi bidan profesi, harus melalui pendidikan bachelor plus profesi. Bachelor ataupun setara dengan bachelor, itu diploma 4. Kemudian mengambil internship. Nah, ini dia akan menjadi professional midwife. Kita punya diploma 3, nanti akan menjadi vocational midwife. Nah, kita juga sudah punya bachelor. Ini untuk doktorat kita sedang mempersiapkan. Kita pasti membutuhkan karena sudah ada 9 program studi yang menyelenggarakan S2 kebidanan. Tentu kita membutuhkan syarat, memenuhi syarat sebagai S2 kebidanan, dosennya minimal berpendidikan D3. Minimal yang inline, ya, yang linear tentu harus ada linear dalam disiplinnya. Banyak sekarang alhamdulillah sudah D3, S3, tapi mungkin belum yang spesifik S3-nya di midwifery, tapi di berbagai disiplin. Tapi bukan berarti itu tidak penting, sangat penting, tapi akan lebih penting lagi kita juga punya program S3 kebidanan. Nah, kalau di luar tadi, kayak di UK, di Filipina, mereka bachelor-nya itu 4 tahun. Langsung jadi bidan profesional. Tidak melalui bidan vocational. Di Filipina juga sama. Tapi di negara lain ada yang bachelor-nya itu 3 tahun. Seperti di Bangladesh, itu bachelor-nya 3 tahun. Nah, jadi kalau di luar, minimum pendidikan kebidanan itu dari ICM, bachelor, 3 tahun, kemudian after nursing minimum 18 bulan. Tapi tadi saya mendengar juga dari Andrea ya, bagaimana di Australia. Nah, ini bagaimana registration kita. Kita setiap bidan yang akan menyelenggarakan, akan melakukan tugas-tugas profesi harus teregistrasi. Nah, registrasi itu akan diberikan oleh konsil. Alhamdulillah nih saya infokan, konsil kebidanan sudah terbentuk. Di bawah konsil tenaga kesehatan sudah ada SK perpresnya. Ada konsil-konsil tenaga kesehatan, ada konsil keperawatan, konsil kebidanan, konsil farmasi, dan sekarang kita sudah punya konsil kebidanan. Dan juga tentu sebelum konsil kebidanan kita juga sudah punya kolegium kebidanan sebagai think tank-nya kita, sebagai tim pengembang terhadap profesi kita. Jadi sudah cukup lengkap. Ada kolegiumnya, ada konsilnya, tinggal kita bagaimana memperkuatnya, bagaimana melaksanakan tugas-tugas masing-masing konsil dan kolegium dan IB juga, ini penting sekali. Kemudian registrasi ini akan berlaku selama 5 tahun, tentu ada syarat-syarat. Kemudian setiap 5 tahun diperpanjang, memenuhi syarat lagi, kita sudah sepakat di dalam portofolio, kita harus mengumpulkan sekian kredit profesi untuk bisa perpanjangan STR, 25 kredit profesi. Nah, untuk praktek, bidan bisa praktek di mana saja, di fasilitas pelayanan kesehatan, termasuk di tempat praktek mandiri bidan. Mau di puskesmas, mau di desa, mau di posyandu, di pustu, ya di rumah sakit, di klinik itu bisa. Nah, ini di dalam transformasi kesehatan, Kementerian Kesehatan mengembangkan program itu nanti akan ada posyandu prima. Jadi akan direvitalisasi posyandu yang kemarin sudah mulai agak kurang aktif, apalagi dipengaruhi oleh kejadian pandemi COVID, ya, ini akan diperkuat lagi. Itu posyandu prima sebagai salah satu program dari Kementerian Kesehatan untuk transformasi kesehatan. Ini artinya apa? Nah, kita teman-teman bidan itu akan punya peluang, punya peran besar di posyandu karena sekarang memang bidan itu sebagian besar juga banyak sekali yang masih ada di desa. Kemudian tentu di dalam melaksanakan praktek harus sesuai dengan kompetensi kewenangannya, patuh terhadap peraturan perundang-undangan, menerapkan kode etik bidan, kemudian standar-standar profesi, SOP, itu menjadi kewajiban kita sebagai seorang profesional. Nah, bagaimana izin ya? Setelah kita punya STR, tentu kita harus memperoleh surat izin praktek bidan. Ya, kita harus surat izin praktek ini juga dikeluarkan oleh Dinas Kesehatan Kabupaten Kota. Dan untuk mendapatkannya tentu tadi syaratnya punya STR dan kita punya tempat praktek. Dimanapun kita praktek, mau di rumah sakit juga sekarang butuh SIPB, mau di puskesmas juga butuh, apalagi di tempat praktek mandiri bidan. Nah, ini keberlakuan izin ini juga selama 5 tahun sepanjang STR-nya masih berlaku. Ini saya mereview saja sih sebetulnya karena kita bicara apa yang dilakukan bidan. Ya inilah pengembangan yang kita lakukan bagaimana untuk eksistensi profesi kita agar dapat memberikan pelayanan kebidanan secara terus-menerus. Apalagi nanti secara spesifik tadi juga udah dibahas baik oleh Andrea, tadi juga oleh Lois ya, bagaimana pelayanan kebidanan itu dengan menerapkan midwife-led care, continuity of care, respectful midwifery care dan lain sebagainya. Nah, area kita itu mulai dari maternal, child health, women reproductive health and family planning, kemudian juga kita ada pelimpahan kewenangan ya di dalam kondisi-kondisi tertentu kita juga bisa diberikan tugas-tugas tambahan oleh pemerintah sesuai dengan kebutuhan. Seperti kemarin pada masa Covid kita dapat keputusan Menteri Kesehatan tentang bidan diberi tugas penugasan bidan sebagai vaksinator ya. Ini merupakan tugas-tugas pelimpahan. Nah, tentu saja tadi sudah di dalam melakukan tugas-tugas kita juga melakukan secara otonomi tadi dengan berkolaborasi, kemudian juga secara bertanggung jawab dan akuntabel ya, kemudian juga selalu kita menyesuaikan, mengikuti kompetensi dan kewenangan yang ada. Tidak boleh kita melakukan sesuatu tindakan yang kita tidak kompeten, apalagi kita juga tidak berwenang. Karena antara kompetensi dan kewenangan itu seperti mata uang. Ya, nggak bisa salah satu kita miliki. Kita kompeten tapi tidak berwenang juga nggak boleh. Kita diberi kewenangan tapi tidak kompeten, tidak boleh juga. Nah, makanya di dalam pengaturan tentang standar profesi itu dibuat bersama-sama dengan profesi lain. Kita pengaturan standar profesi 320 tahun 2020 itu kita punya berita acara dengan dari POGI punya berita acara, dari IDAI, dari PPNI, dari IAKMI, dari farmasi ada berita acara bahwa apa yang kita rumuskan di dalam standar profesi bidan itu tidak kalau gray area kemungkinan ada gray area, tapi dipahami gray areanya sampai sebatas mana, sehingga semua profesi itu sudah mengikuti, sudah tahu, sudah menyetujui apa yang kita atur di dalam standar kompetensi. Nah, itu yang kita katakan tadi, kalau kita membuat standar kompetensi semua kita bisa, tapi kalau nggak berwenang ya nggak bisa. Kita punya kewenangan nggak kompeten, ya nggak bisa. Nah, kompetensi itu diatur melalui standar profesi yang disetujui, diakui oleh semua profesi. Jadi ada pun mungkin satu profesi dia bisa katanya melakukan ini, tapi kan tidak berwenang. Begitu juga sebaliknya, kita udah diberi kewenangan tapi kita belum kompeten, ya itu juga tidak boleh ya. Nah, itu dalam konteks kita harus patuh terhadap aturan perundang-undangan. Nah, kita di dalam lingkup tadi kita bicara maternal care ya, mulai dari sebelum hamil, kehamilan normal, persalinan normal, pada masa nifas, kemudian melakukan tindakan-tindakan kegawat daruratan, melakukan deteksi dini ya, dan kita melakukan pertolongan pertama untuk dirujuk. Begitu juga pada pelayanan kesehatan anak ya, kita mulai dari bayi baru lahir, bayi, balita, sampai sekarang ini ke preschool. Preschool itu umur 6 tahunan, jadi agak sedikit melebar. Tadinya kita selalu balita, tapi di dalam undang-undang sampai preschool. Kemudian kita juga memberikan imunisasi sesuai dengan standar program pemerintah, kemudian melakukan pemantauan tumbuh kembang bayi dan balita, sama melakukan deteksi dini juga, melakukan tindakan-tindakan emergensi juga terhadap kasus-kasus bayi dan balita. Nah, keluarga berencana dan kesehatan reproduksi perempuan, ya, kita memberikan komunikasi, informasi, edukasi, kemudian konseling, memberikan pelayanan kontrasepsi. Pelayanan kontrasepsi bisa pil, bisa suntik, bisa IUD, bisa implan sesuai aturan yang berlaku. Nah, ini untuk IUD dan implan itu ada syaratnya, ya. Kalau sekarang karena kita di dalam kurikulum D3 pemasangan IUD dan implan itu capaian kompetensinya pada level 3, berarti di bawah supervisi. Nah, kalau kita mau memasang secara mandiri IUD implan, kita harus pelatihan dulu, harus mendapatkan sertifikat CTU, kontrasepsi technical update, contraception technical update, ya. Ada sertifikasinya. Nah, tapi untuk program profesi sesuai dengan standar 320 tahun 2020 itu ada perubahan. Lulusan pendidikan program profesi bidan, lulusan program pendidikan profesi bidan itu untuk pemasangan IUD dan pemasangan implannya sampai di level 4. Bisa dilakukan secara mandiri. Tapi kalau diploma 3 sampai di level 3. Nah, ini nanti yang akan membedakan pada akhirnya. Lulusan profesi nggak perlu ikut pelatihan CTU. Lulusan D3 masih membutuhkan sertifikasi. Itu nanti yang akan membedakan. Tapi tentu saya lagi bicara juga dengan teman-teman di pendidikan, baik di kolegium, di asosiasi, ya. Bagaimana nanti kita menunjukkan bukti bahwa lulusan pendidikan profesi itu memang bisa diberi kewenangan untuk melakukan secara mandiri pemasangan IUD dan implan. Kenapa? Karena kita sudah ada di dalam sistem yang sudah terbentuk terlebih dahulu. Sekarang ini untuk bisa dibayar jasa pemasangan IUD dan implan dari BPJS, syaratnya itu harus punya sertifikat CTU. Nah, ini nanti tentu kita harus berkoordinasi dengan BPJS, kita harus menunjukkan bukti bahwa lulusan profesi sudah bisa tidak membutuhkan sertifikat CTU. Tapi nggak bisa kita begitu lulus terus kita ini yang sedang kita cari mekanismenya. Karena apakah kita mau masukkan di dalam transkrip atau nanti ada surat keterangan. Nah, ini yang perlu koordinasi yang sangat penting sekali dengan semua stakeholder. Ini yang sedang kita persiapkan juga ke arah sana. Kemudian untuk pelayanan kesehatan reproduksi perempuan, ya, ini diatur spesifik di dalam KMK 320 tentang standar profesi. Di dalam Women Sexuality and Reproductive Health Services kita melakukan deteksi dini, kemudian kita melakukan promotif preventif, kita melakukan counseling, ya, untuk konteks kesehatan reproduksi perempuan dan seksualitas. Nah, kita bicara di sini counseling di dalam sexual violence against women, ya, bagaimana untuk kekerasan terhadap perempuan. Kemudian juga kita bagaimana merujuk kasus-kasus, melakukan asuhan pada kasus-kasus post aborsi, ya, post aborsi, bukan melakukan aborsi, tapi post abortion care, ya. Kemudian juga pada masa klimakterium ini diatur dengan rinci di dalam standar kompetensi dalam 320 tahun 2020. Ini kemudian bagaimana scope of work tadi sudah kita bahas di dalam upaya kesehatan yang kita lakukan. Scope of work-nya tadi kita bicara scope of work dalam konteks mulai dari prahamil, hamil, bersalin, nifas, bayi baru lahir, balita, anak, pelayanan kesehatan reproduksi, pelayanan keluarga berencana. Nah, ini konteks kontinumnya. Ini konteks kontinum dalam konteks standar pelayanan kesehatan, mulai dari upaya promotif preventif, kemudian kita memberikan pelayanan-pelayanan normal, kemudian kita melakukan tadi screening, melakukan tindakan-tindakan emergensi itu secara sequence, ya, kemudian merujuk dan kita melakukan pemberdayaan dan mengikut sertakan masyarakat. Nah, bidan sebagai tenaga yang ada di depan, paling depan, ya, kita memberikan pelayanan maternal and child health dan family planning. Kemudian bidan sebagai care provider dengan strategic and unique, ya, the unique role, ya, kita juga berkolaborasi dengan perempuan, ya, dalam mengelola kesehatan reproduksinya. Kemudian juga kita sebagai bidan ini yang ada di ujung-ujung tombak pelayanan sebagai change of agent, kita yang memberikan informasi-informasi. Kemudian juga kita sebagai kolaborator, karena kita ada paling bawah, paling ujung. Kita yang nanti melakukan screening, melakukan deteksi dini, mana yang harus dirujuk kemana, apakah bisa ke puskesmas ataukah harus ke rumah sakit. Kita sebagai kolaboratornya, ya. Nah, ini penting sekali peran bidan yang ada di komunitas. Nah, bagaimana konsep midwifery care ini tadi juga saya dengar sudah dibahas, enggak apa-apa, bahwa ada beberapa konsep, ya, yang menunjukkan keunikan dari bidan, ya. Kita memulai dari promotif, ya, kemudian kita juga berpartner dengan perempuan tadi, kemudian respect terhadap hak-hak perempuan, kemudian melakukan advokasi, ya, untuk memperjuangkan kesehatan perempuan, hak-hak perempuan, kemudian sensitif terhadap budaya, termasuk working with women, bekerja dengan perempuan. Ini sensitif terhadap budaya ini kalau di kita penting sekali karena banyak juga masih mitos-mitos, ya, banyak juga budaya-budaya yang tidak selalu relate dalam mendukung upaya kesehatan. Kemudian kita juga melakukan promotif preventif tadi untuk kita berupaya bagaimana agar setiap klien-klien kita dapat menjalani kesehatan reproduksi dengan baik. Dalam persalinan bagaimana kita juga mengupayakan persalinan normal, ya. Kalau memang sudah ada indikasi atau risiko tinggi, bukan kita memaksa untuk persalinan normal, tapi bagaimana mengelola ibu hamil dengan promotif preventifnya, dengan KIE dan konselingnya, dengan nutrisi yang baiknya, kemudian melakukan screening, dan sekarang berkolaborasi dengan puskesmas dalam USG, ya, 2 kali selama hamil. Nah, itu bagian dari upaya-upaya kita supaya ibu ini kalau memang tidak ada indikasi itu dipromosikan, diutamakan untuk bisa menjalani persalinannya secara normal fisiologis. Nah, ini continuum of care dari pelayanan kebidanan di Indonesia. Ini mungkin tidak persis sama dengan di negara lain, karena negara lain berhenti di maternal neonatal, sementara kita sampai ke kesehatan reproduksi remaja. Karena di dalam kesehatan reproduksi tadi bukan cuma kesehatan reproduksi pasangan usia subur atau sebelum hamil, tapi juga mulai dari kesehatan reproduksi remaja. Jadi mulai dari pasangan usia subur, pregnancy-nya, kemudian persalinan, asuhan bayi, anak balita, kemudian kemudian imunisasi kepada anak, kesehatan reproduksi remaja, sampai kepada premenopause. Jadi lebih luas role kita, lebih luas scope of work-nya bidan-bidan kita di Indonesia. Nah, ini pentingnya kita membuat menyelenggarakan pendidikan yang sesuai dengan standar agar dapat mencapai kompetensi-kompetensi atau outcome yang sudah disusun, yang sudah diatur di dalam setiap program studi. Ya, ini, nah, kita bicara juga distribusi bidan. Ini yang saya kotakkan ini ada 169.000 lebih bidan di puskesmas. Ini hasil dari Risvaskes tahun 2019. Dari puskesmas ada 169.000, ada 44.000 lebih tempat praktek mandiri bidan. Luar biasa. Kemudian ada 20.000 lebih Polindes yang masih beroperasi. Tentu dengan adanya program tadi Posyandu Prima, ini Polindes ini tentu nanti akan ada bidan dilengkapi, dipenuhi untuk dapat berperan di dalam Posyandu Prima. Nanti di dalam Posyandu Prima itu kalau nggak salah saya ada 3. Tapi minimal 1, tapi nanti kalau bisa memungkinkan pemerintah akan meng-hire 3, ada bidan, ada perawat, dan ada tenaga penyuluh kesehatan. Nah, karena kita kan punya peran berbeda, ya. Bagaimana nanti di desa kasus-kasus TB, ya TB itu kan berkaitan dengan bagaimana pemantauan kepatuhan minum obat dan lain sebagainya. Kita akan berbagi peran nanti di desa. Kemudian kalau data dari Pusdatin itu masih 45.000 bidan yang ada di desa. Nah, di sini Polindesnya sendiri yang masih aktif 20.000. Bisa jadi bidan di desa itu dia tidak punya Polindes, ya. Saya juga tidak tahu kok tidak sama hasilnya. Tapi ini hasil yang didapatkan dari riset Vaskes tahun 2019. Ini juga 2019 dari Pusdatin. Nah, kalau kita lihat bagaimana kontribusi bidan, ini juga berulang-ulang teman-teman udah tahu ya, bahwa hasil dari Riskesdas 2018, ANC yang dilakukan oleh teman-teman bidan itu 82,4%, 41% diantaranya di tempat private midwife clinic, ya, independent praktisi midwife. Kemudian pertolongan persalinan juga sama. 61% ditolong oleh bidan di semua vaskes dan 29% diantaranya di tempat praktek mandiri bidan. Begitu juga untuk keluarga berencana 76,5%, 54,6% diantaranya dilakukan di klinik mandiri bidan. Jadi besar sekali peran bidan di dalam pelayanan kesehatan ibu terutama, ya, termasuk kesehatan bayi juga. Jadi dengan begitu besarnya peran kita, begitu besarnya kepercayaan masyarakat kepada kita, tentu seyogyanya kita harus senantiasa meningkatkan kemampuan kita agar dapat memberikan pelayanan yang berkualitas sesuai dengan kebutuhan, dengan menerapkan prinsip respect terhadap klien. Ini penting. Nah, kita lihat bagaimana midwifery services di dalam sistem pelayanan kesehatan. Dalam sistem pelayanan kesehatan kita, ini ada kita primary, kita ada 3. Ada pelayanan kesehatan primer, ada pelayanan kesehatan rujukan tingkat 1, ada pelayanan rujukan tingkat 2. Itu sistem dari pelayanan yang ada di Indonesia. Dan di fasilitas pelayanan primer itu ada puskesmas, pustu, ya. Kemudian ada bidan-bidan di desa. Kemudian di sini termasuk private midwife clinic tadi masuk di dalam kelompok fasilitas pelayanan primer. Nah, kalau kita bicara di TPMB atau di tempat praktek mandiri bidan, tentu kita melakukan upaya promotif preventif sesuai dengan scope of work tadi. Essential obstetric services including imunisasi, ya, essential midwifery services, ya, bukan obstetrik. Kemudian melakukan deteksi dini, kemudian melakukan kolaborasi, pertolongan pertama, dan melakukan rujukan. Kalau di puskesmas, ini agak sedikit berbeda. Di puskesmas kita bekerja di dalam tim multiprofesi, multidisiplin. Kalau di sini di tempat praktek mandiri bidan kita juga tidak bekerja sendiri, tapi bisa kita bekerja berdua, bertiga, tapi bisa dalam satu disiplin ataupun juga ada profesi lain, nggak masalah. Tapi kalau di sini sudah pasti multidisiplin. Nah, di sini kita sama melakukan preventif promotif, melakukan pelayanan-pelayanan kebidanan esensial normal, termasuk memberikan imunisasi, deteksi dini, melakukan kolaborasi, dan kita bagian dari tim PONET, penanganan obstetri neonatal emergensi dasar. Ya. Kemudian kita juga membina UKBM, unit kesehatan berbasis masyarakat, kita mensupervisi posyandu dan lain sebagainya, mensupervisi bidan di desa. Ini adalah teman-teman di puskesmas. Kalau kita di referral, baik itu level 1 maupun level 2, nah di sini kita bekerja di dalam tim juga, mengelola kasus-kasus risiko tinggi, kasus patologi, kasus komplikasi. Ya, nah di dalam penanganan kasus-kasus abnormal ini atau kasus-kasus yang bukan normal fisiologis, kita di sini juga sangat berperan bagaimana kita melakukan screening awal pada saat menerima pasien rujukan, karena yang menerima pertama itu biasanya bidan, ya. Kemudian setelah itu kita berkolaborasi dengan tim PONEK komprehensif. Bisa dokter obgyn, bisa dokter anak, ya, dan lain sebagainya. Kemudian setelah dilakukan tata kelola kasus, kemudian kita melakukan asuhan lanjut dalam konteks interprofessional collaboration, baik di level 1 maupun di level 2. Nah, bagaimana pengembangan kita ke depan itu sudah diatur juga, alhamdulillah, di dalam PMK 320, bahwa pengembangan pelayanan kebidanan ini sesuai dengan kebutuhan, ya, kebutuhan pelayanan baik secara global maupun nasional tentunya. Jadi kita harus melihat di sekeliling kita bagaimana peningkatan kualitas kita di dalam pelayanan kebidanan ini mengikuti perkembangan-perkembangan yang terjadi, baik perkembangan kebijakan maupun perkembangan teknologi, perkembangan informasi, ada evidence baru gitu ya. Nah, kita sebagai seorang profesional tentu kita harus selalu berkembang, selalu mempertahankan dan meningkatkan profesionalisme kita. Dan namanya profesional itu sangat erat kaitannya dengan kompetensi. Nah, kompetensi kita sebagai seorang profesional tidak cukup hanya kompetensi klinis, tapi harus dilengkapi, harus juga didampingi oleh kompetensi-kompetensi non klinis, termasuk kompetensi socio-cultural. Tadi bicara juga bagaimana analisis thinkingnya, kemampuan advokasi, critical thinking, kemampuan improvement, kemampuan dan kreativitas dan lain sebagainya. Jadi ini pengembangan profesi kita arahnya sudah punya arah-arah yang cukup jelas. Nanti tinggal kita melihat kebutuhan untuk pengembangan itu sejauh mana, itu nanti akan kita upayakan. Nah, bagaimana pengembangan pendidikan? Tadi penguatan di pendidikan, ya, mulai dari pendidikan, tentu juga kita bicara menguatkan pendidikan kita untuk mewujudkan visi bidan. Visi bidan kita itu adalah mewujudkan bidan profesional berstandar global. Alhamdulillah setiap kita mengembangkan profesi, rujukan kita adalah ke standar global. Baik yang dikeluarkan oleh ICM terutama, tentu juga yang dikeluarkan oleh WHO, oleh WHO. Ya. Nah, di dalam pengembangan pendidikan ini kita sesuai dengan kompetensi yang sudah diatur di dalam kebijakan 320, kemudian standar pendidikan yang sebentar lagi kita berharap disahkan oleh Kementerian Dikbud, karena sudah selesai kita buat, tinggal pengesahan. Dan tentu saja juga kita mengikuti sistem yang ada di Indonesia berdasarkan kepada kualifikasi tenaga kesehatan KKNI. Itu sudah kita rujuk dalam pengembangan pendidikan kita. Ya, mulai dari kita juga melihat kebijakan-kebijakan tentang pendidikan, tentang kesehatan, WHO dan lain, dan juga kita merujuk kepada pengembangan-pengembangan yang dirancang oleh asosiasi profesi sendiri. Ini waktunya udah mau habis ya, ini udah tinggal 2 slide lagi. Bagaimana upaya kita di dalam meningkatkan kualitas pelayanan kebidanan? Ya, kita punya program di IB, menstandarisasi utamanya memang yang coverage kita itu, yang kita cover itu adalah bidan-bidan yang praktek mandiri di dalam program Bidan D5. Di dalam program Bidan D5 itu aktivitas yang sangat penting kita lakukan itu adalah melakukan supervisi fasilitatif, kemudian melakukan monitoring dan evaluasi, kemudian juga kita melakukan memfasilitasi untuk pendidikan berkelanjutan secara terus-menerus kepada bidan delima. Itu program di bidan delima. Tentu kalau CPD tentu juga kita juga melakukan memberikan fasilitasi kepada bidan-bidan siapapun, itu tidak hanya untuk bidan delima. Nah, kita melakukan pelatihan-pelatihan baik yang klinis maupun yang non klinis ya, APN, pengambilan keputusan, kemudian CTU, manajemen laktasi, kelas ibu hamil dan lain sebagainya. Tadi PONET, PONEK, LSS, life saving skill, tadi PPGDON ya. Ini PONET, ini PONEK. Nah, kemudian untuk konseling ASI dan lain sebagainya. Kemudian kita juga melakukan berbagai webinar ini selama pandemi COVID, hampir 300 kali kita melakukan webinar. Ya cukup banyak dan alhamdulillah bisa diakses oleh teman-teman bidan. Kemudian kita juga terlibat di dalam pengembangan standar-standar baik yang dilakukan oleh Kementerian Kesehatan, OBKKBN, Kementerian Pemberdayaan Perempuan maupun dengan stakeholder-stakeholder lainnya. Dan tentu juga peran kita di dalam memfasilitasi anggota tadi, berjuang untuk anggota, kita juga melakukan advokasi. Bagaimana peran-peran bidan di dalam BPJS itu. Kemarin saya baru rapat BPJS dengan di Kementerian Menko PMK ya. Bagaimana kita mengusulkan, mengupayakan perubahan tarif ya. Insya Allah itu akan ada perubahan tarif, tapi belum disahkan. Kemudian juga itu yang harus kita perjuangkan. Kemudian juga bagaimana kita menjalin kerjasama dengan baik dengan profesi kesehatan lain maupun dengan berbagai stakeholders yang dapat mendukung dan mensupport kita dengan POGI, dengan IDAI, kita dengan PPNI, dengan IAKMI, dengan kita punya forum organisasi profesi. Ya, untuk semua ada 33 profesi, tapi forum kecil kita juga punya, itu yang kita intens sekali. Antara Ikatan Dokter Indonesia, Ikatan Dokter Gigi Indonesia, IBI, PPNI, dan IAI. Ada 5 profesi yang kita selalu berkomunikasi, kita punya WhatsApp group, karena banyak juga masalah yang harus kita bicarakan secara bersama-sama. Nah, bagaimana strategi program kita, yaitu penguatan tadi pendidikan tadi, kemudian penguatan profesionalisme, kemudian bagaimana pendidikan bagi teman-teman yang praktek mandiri, karena ini diatur di dalam Undang-Undang Kebidanan 2026 yang bisa mengelola tempat praktek mandiri bidan atau fasilitas pelayanan praktek mandiri bidan itu bidan lulusan profesi. Ini sedang kita upayakan, sebetulnya sudah selesai. Modulnya sudah selesai, semua sudah selesai, tapi kita menunggu pengesahan, bukan pengesahan, SK penugasan dari Kementerian Dikbud. Kemudian bagaimana kita juga, nah ini kenapa kita spesifik bikin early detection? Karena ada hasil survei yang menunjukkan keterlambatan itu masih terjadi, ya keterlambatan di dalam melakukan diagnosa, keterlambatan di dalam melakukan rujukan, dan keterlambatan juga di dalam penanganan kasus-kasus rujukan. Jadi ini mendapat perhatian kita dari berbagai masukan supaya kita lebih memperkuat kemampuan bidan ini harus ditingkatkan di dalam deteksi dini ya untuk kasus-kasus dan stabilisasi. Karena di dalam data menunjukkan yang dilakukan stabilisasi pada saat rujukan itu rendah sekali porsinya, rendah sekali persentasenya. Nah, kemudian kita juga tadi sudah melakukan kolaborasi dengan kerjasama dengan profesi lain, kemudian juga kita mengembangkan riset tadi yang saya sampaikan, dan kemarin sebelum kita pandemik, teman-teman ini yang punya publikasi-publikasi ilmiah bisa disajikan pada scientific meeting, annual scientific meetings kita, tapi berhenti ini selama 3 tahun. Ini tahun ketiga kita tidak melakukan pertemuan ilmiah ya. Mudah-mudahan nanti ke depan kita akan melanjutkan lagi karena mudah-mudahan ini sudah mulai situasinya sudah mulai membaik, dan juga kita mempublikasikan melalui Scientific Journal of Midwifery yang sudah terakreditasi oleh Dikti. Nah, ini slide terakhir, strategi objektifnya: strengthening midwifery, enhance midwifery professionalism, kemudian promote midwifery research, advocate for midwifery extent, and the influence of midwife in policy development that drive service direction. Jadi konsil sudah terbentuk, kemudian juga mendorong strategi kolaborasi kita dengan organisasi-organisasi terkait, mulai dari pendidikan, interprofessional education, interprofessional collaboration dengan lokal maupun nasional level maupun international level. Ini adalah tujuan kita mengembangkan bagaimana strategi-strategi kita di dalam pengembangan profesi ini. Nah, ini tadi sudah disajikan juga dari ICM, ini tambahan saja. Di ICM kita juga punya visi 2030 itu bagaimana supaya setiap perempuan itu harus telayani. No one left behind, ya. A universal pathway, a women's right to health. Setiap perempuan berhak untuk sehat, ya. Kemudian ini juga di dalam SOMI 2014 ini juga disajikan bahwa 87% itu di essential care itu dapat dipenuhi oleh bidan. Tentu bidan-bidan yang dengan pendidikan yang terstandar, diakui, diberi dukungan untuk fasilitas dalam melaksanakan tugas-tugasnya. Nah, ini yang kita lakukan juga advokasi kepada pemerintah sendiri, ya, bahwa di sini kesimpulannya ini 87% essential care women, kemudian continuum of care dalam along a women life cycle, kemudian investing in midwifery ini disajikan juga di sini. Jadi memberikan dukungan kepada pengembangan profesi bidan itu akan mendapatkan benefit yang sangat besar sekali. Nah, ini kita lihat juga di WHO, ya. Di WHO introducing respectful care model in maternal and newborn care. Nah, di sini untuk memberikan tadi respectful, bagaimana kita membangun pengalaman yang menyenangkan, yang positif pada saat kita melayani ibu hamil. Jadi seorang ibu hamil itu tidak trauma dengan dia hamil atau tidak merasa ketakutan pada saat dia hamil, tapi dia akan merasa happy, dia punya pengalaman positif karena selalu berkoordinasi, berpartner dengan bidan yang dapat memberikan support, ya. Support secara psikologis, support melalui informasi agar dia dapat menjalani kehamilannya dengan baik. Nah, begitu juga pada saat pertolongan persalinan, mereka juga berharap supaya mereka mendapatkan pengalaman positif di dalam mengalami kelahiran, melahirkan. Ya, itu tentu bagaimana sikap kita sesuai standar APN, bagaimana kita memberikan hak-haknya untuk didampingi oleh suami ataupun oleh keluarga, bagaimana mereka juga bebas untuk bergerak dan lain sebagainya. Ini prinsip-prinsip dari standar asuhan persalinan normal. Nah, kita bicara di sini untuk respectful care model. Ini harus didukung dengan fasilitas essential physical resources, ya. Kebutuhan sarana prasarananya ada, kemudian tenaganya sudah kompeten, ya, dengan tentu motivasi yang tinggi tadi, compassionate dan lain sebagainya, caring dan lain sebagainya. Nah, kita bicara respectful labor and childbirth care. Kita memberikan support emosional. Kita melakukan komunikasi, edukasi yang efektif dengan klien-klien kita, dan kita dapat juga mengupayakan pain relief strategies, ya. Pain relief strategies, banyak strategi-strategi yang bisa kita pakai. Sekarang banyak sekali teman-teman mengadakan pelatihan-pelatihan hypnobirthing dan lain sebagainya dengan complementary, ya. Kemudian juga pemantauan patograf, kemudian pemenuhan nutrisi, kemudian juga bagaimana mereka dapat bebas bergerak pada saat proses kala 1, kala 2. Ini harus kita berikan dukungan. Kemudian bagaimana kalau membutuhkan rujukan kita melakukan stabilisasi dan kita melakukan continuity of care. Nah, tadi continuity of care itu ada banyak kalau kita continuity of care, satu pasien mulai dari hamil, bahkan sekarang calon pengantin ya, kita mundur ke calon pengantin. Mulai dari hamil dengan bidannya, nanti persalinan dengan bidan, nanti membawa bayi balitanya ke bidan, kemudian apalagi di tempat praktek mandiri bidan. Ya, kenapa porsinya atau persentage-nya tinggi? Ya, karena sekali dia sudah ke bidan, dia akan melanjutkan asuhan, melanjutkan kebutuhan untuk pelayanan kesehatannya ke bidan tersebut. Nah, ini peluang bagi kita bagaimana kita bisa memberikan pelayanan-pelayanan terbaik kepada masyarakat agar bidan ini tetap menjadi pilihan utama dan pilihan pertama dari masyarakat untuk kasus-kasus normal. Kalau yang sudah risiko tinggi, patologi, apalagi komplikasi, ya itu sekarang kita tidak mulai dari awal kita sudah harus membangun kolaborasi dengan profesi kesehatan lain. Begitu kita terdeteksi ada risiko atau ada patologi dan lain sebagainya, penyimpangan lah dengan penyakit penyerta ibu hamil, ya itu udah harus kita kolaborasikan. Jadi, nah ini dalam framework for quality maternal, ini menggunakan tadi filosofi ya kebidanan bagaimana kita memberikan edukasi health promotion di sini, melakukan screening, kemudian mengupayakan persalinan normal, kemudian melakukan pertolongan pertama pada kasus-kasus komplikasi, dan kita ini sudah di fasilitas rujukan ya. Kemudian di sini akan mendapatkan tata kelola kasus-kasus medical obstetric and neonatal. Nah, bagaimana fasilitasnya harus tersedia, bisa diakses, diterima dengan kualitas yang bagus ya, didukung dengan resources yang cukup. Kemudian kita menerapkan values, nilai-nilai dalam pendekatan kita ya. Bagaimana pendekatan kita di dalam memberikan pelayanan, respect dengan komunikasi yang efektif, kemudian pemahaman terhadap tadi sensitif terhadap budaya dan lain sebagainya. Filosofinya bagaimana mengupayakan kapasitas secara biologi, psikologi, meningkatkan kapasitas dari perempuan, dari klien-klien kita, kemudian juga care providers-nya, kita bicara tentang clinical knowledge and skills-nya, kemampuan interprofesionalnya, kemudian cultural competence-nya, tadi pemahaman terhadap budaya-budaya itu juga diperlukan. Nah, bagaimana kita bicara tadi universal health coverage untuk no one left behind ya. Every woman, setiap perempuan berhak untuk sehat. Bagaimana supaya dia bisa sehat? Tentu dia bisa akses terhadap pelayanan kesehatan. Untuk itu bagaimana ketersediaan pelayanan ini menjadi utama. Ini selalu saya sampaikan juga di Kementerian Kesehatan, ya termasuk dengan Pak Menteri. Saya pernah presentasi juga supaya bidan-bidan di desa ini dilengkapi kembali. Nah, sekarang sudah masuk kepada posyandu prima. Itu artinya apa? Ya nanti di desa-desa itu ada sekitar 83.000 lebih posyandu prima yang akan dibangun, yang akan diperkuat di target transformasi kesehatan oleh Kementerian Kesehatan. Jadi ketersediaan bidannya, kita bicara pelayanan kesehatan ibu dan anak ya. Ketersediaannya bidannya ada, kemudian dia bagian integral dari pelayanan kesehatan, bukan kita di luar sistem, tapi kita di dalam sistem ya. Kemudian si perempuan mudah untuk mengakses, makanya didekatkan pelayanan itu ke masyarakat. Mungkin ada pelayanan lebih bagus tapi kan jauh, susah untuk diakses. Nah, konteksnya untuk universal health coverage adalah mudah untuk diakses. Kemudian ada bidannya, kemudian sesuai dengan kebutuhan masyarakat, kemudian didukung dengan financial protection. Alhamdulillah sekarang hampir semuanya sudah bisa menggunakan BPJS. Bagi yang tidak mampu nanti akan di-cover oleh PBI, bagi yang mampu tentu akan membayar premi tersendiri. Dan acceptable. Nah, ada dia di situ, mudah diakses, tapi kalau tidak diterima oleh masyarakat, tentu ini juga tidak akan efektif, ya. Nah, sehingga acceptable ini kita bicara bagaimana mereka datang, kita memberikan providing respectful care, ya, recognizing dengan value-value yang mereka miliki, respect, kita menghargai human right dan lain sebagainya. Kemudian yang terakhir, tentu kita bicara effective coverage, itu harus bicara kualitas. Nah, kualitasnya kita tambah di sini, providing respectful care, competent and enable to provide quality care. Harus ada dukungan fasilitas sarana prasarana. Nggak bisa ditempatkan di desa terus dibiarin, nggak didukung. Nah, itu tidak akan bisa memberikan kontribusi yang maksimal. Dan yang paling penting kita bicara kualitas adalah continuous quality improvement, monitoring, evaluation, and learning. Ya, sekarang tambah L sekarang. Jadi monitoring, evaluation, and learning. Jadi kita belajar dari mengambil pembelajaran dari setiap kasus-kasus yang ada. Nah, summarize-nya, ya, midwifery care as one of a central part to play in conducting to the maternal neonatal health. Improving quality midwifery education program penting sekali to achieve the competency standard. Midwife as one in a front line of health services need supported by appropriate facilities, regulation, and need to maintain the capacity by continuing professional developments. The capacity of midwife to implement the quality midwifery care and lead the care by follow the regulation and policy. Teman-teman di tempat praktek mandiri itu mengelola fasilitasnya, kemudian needs to be increased so that all women can access them with good quality. And kita bisa membantu mewujudkan untuk a universal pathway, a women's rights to health. Ini improving the quality of midwifery care, quality, respectful, kemudian have the right to work within the enabling environment, kemudian recognize, educated, regulated, ya, kemudian building greater advocacy capacity in country to extend the influence of midwife within national policy. Nah, ini penting juga nih. Ya, alhamdulillah kami kemarin mengadakan survei pengumpulan data karena dibutuhkan juga dari global. Itu sekarang teman-teman bidan banyak yang jadi kepala puskesmas, kalau nggak salah ada 700 secara keseluruhan. 700 bidan yang jadi kepala puskesmas. Kemudian bidan yang menjadi kepala dinas kesehatan kabupaten kota ada sekitar 8. Jadi ini bagian dari kita punya pendidikan higher education. Kita membekali dengan kapasitas-kapasitas keilmuan, kapasitas-kapasitas baik keilmuan yang berkaitan dengan disiplin profesi maupun yang berkaitan dengan managerial and leadership. Jadi kita juga punya peluang yang sama, ya. Ultimate outcome achieving the quality led and women center midwifery care. Ya, itu yang dapat saya sampaikan. Terima kasih. Mungkin ini sudah berulang-ulang, tapi nggak apa-apa. Yang kita upayakan, ya itu selalu. Ternyata memang kalau saya melihat saya udah cukup lama di IBI, kayaknya perjuangan kita nggak akan pernah berakhir. Ya, ada aja tantangan-tantangan baru yang membuat kita juga harus punya mengantisipasinya dan mampu untuk beradaptasi dengan tantangan-tantangan tersebut melalui penguatan-penguatan profesi kita. Jadi itu yang dapat saya sampaikan. Terima kasih, Mbak.
Terima kasih kepada Ibu atas pemaparannya, Bu. Alhamdulillah berkat informasi ini dari IBI Pusat terkait dengan baik itu tadi adanya regulasi, baiknya informasi terkait dengan data, ternyata alhamdulillah sudah adanya perkembangan bagi kita bidan yang sudah ada yang memimpin untuk pimpinan sebagai pimpinan puskesmas ataupun malah ada yang menjadi kepala dinas. Nah, alhamdulillah artinya di sini ibu-ibu partisipan jadi tidak menutup kemungkinan dengan kita selalu meningkatkan untuk pendidikan dan meningkatkan untuk upaya kita dalam leadership dan manajemen, insya Allah dengan lambat launnya kita bidan ini akan semakin berkembang dan semakin meningkat, dan memang itu butuh banyak peluang, dan memang itu memang butuh untuk dukungan kita bersama, kerjasama kita baik dari IBI pusat. Di sini juga alhamdulillah juga ada PDIB kita yang dari Sumatera Barat, Ibu.
Oh, ada Bu Hasna ya.
Iya, ada Bu
Ada Bu
Hasna.
Hasna.
Ada iya, dan juga dari cabang Ibu Laila, dan alhamdulillah juga dari rumah sakit, dan jadi diharapkan memang bersama-sama kita untuk mendukung ini semua. Baiklah Ibu, kita lanjut untuk sesi tanya jawab. Kita lihat di room chat ini Ibu. Di sini ada pertanyaan dari bidan inisiator di mana terkait dengan pemerataan bidan di daerah. Namun juga bisa apakah apa tindakan atau di sini memang dia langsung ini ya Bu ya, langsung ke Yonda. Di sini yang diminta upaya dari PPIB terkait dengan perjuangan pemerataan bidan di daerah, namun mereka juga penggunaan dana desa atau dari dana Kemendes Pemda setempat. Nah, itu kira-kira bagaimana pendapat Ibu? Dipersilakan Ibu.
Ya, ini bagus sekali pertanyaannya. Tadi ada hubungannya dengan apa yang tadi saya sampaikan, bahwa sekarang Kemkes akan melakukan yang namanya program transformasi kesehatan. Dia akan bicara lebih hulu lagi. Tidak akan fokus kepada setelah sakit orang baru dikelola, tapi bagaimana mencegah itu lebih diutamakan. Sehingga Posyandu Prima akan dibangun kembali. Bagaimana posisinya nanti di Posyandu Prima itu yang tadi saya sampaikan di dalam konsepnya, itu di Posyandu Prima nanti ada bidan. Posyandu Primanya terdaftar sampai kemarin itu lebih dari 83.000, tapi tentu kemungkinan saya tidak tahu akankah bertahap atau bagaimana, tapi itu di dalam planning sudah ada untuk pemerataan ya bagi masyarakat dan juga kesempatan bagi teman-teman bidan. Dan sekarang kalau kita lihat ini ada lagi program yang dari BKKBN untuk melalui Perpres 72 tahun 2021 ya tentang percepatan penurunan stunting. Nah, di situ juga ada program yang namanya tim pendamping keluarga. Nah, dalam tim pendamping keluarga itu ada satu bidan sebagai koordinator, kemudian ada PLKB dan ada perwakilan dari PKK. Kita memang bicara di desa. Nah, alhamdulillah yang tadi disampaikan pada ini kita sedang bergerak cepat ya pemerintah sekarang, terutama dengan Kemkes, dengan Bappenas itu setiap hari ada rapat, dan dengan Kementerian Menko PMK. Kemarin di Menko PMK pun kita bicara tentang tim pendamping keluarga ini ya, yang ada 200.000 kebutuhannya. Sepertinya sudah dibuat oleh oleh BKKBN, hanya mungkin statusnya. Saya kemarin menanyakan bagaimana statusnya, bagaimana penghargaan yang diberikan dan lain sebagainya. Dan untuk teman-teman bidan yang kemarin juga mungkin sudah tahu, sudah mendapatkan info. Dulu kita berjuang untuk teman-teman bidan PTT jadi CPNS, dan itu alhamdulillah sudah 43.000 lebih. Nah, sekarang kita sedang menunggu juga realisasi, kita berjuang untuk bidan-bidan honorer menjadi ASN. Nah, kemarin minggu lalu saya dapat forward dari Komisi 9 DPR RI, sudah keluar juknis untuk pengangkatan tenaga honorer. Kita bicara honorer kesehatan ya, dari Menpan. Dan kita juga sudah menyampaikan usulan ke Menpan, kita juga udah ke Dirjen Nakes, kemudian saya juga sudah presentasi di Komisi 9 berkaitan dengan tenaga honorer. Nah, mudah-mudahan tentu ada syaratnya, mudah-mudahan memenuhi syarat yang sudah terdaftar di sistem informasi tenaga kesehatan. Nah, itulah yang akan diproses. Saya rasa teman-teman sudah tahu itu karena kami selalu menyebarkan informasi untuk memberikan kesempatan kepada teman-teman bisa memanfaatkan kesempatan-kesempatan seperti ini.
Baik, terima kasih Ibu. Di sini ada kelanjutan dalam penjawaban Ibu bahwa dari penjelasan tersebut namun pada kenyataannya ketika kita di desa tidak didukung oleh regulasi atau malah kami kesulitan memperjuangkan posisi padahal di desa tersebut kegiatan kami cukup optimal. Nah, mohon bantuan untuk penjelasannya Ibu.
Iya. Jadi ini kalau di dalam level nasional itu kita udah bahas karena di dalam rapat Menko PMK itu ada dari Depdagri, ada dari Kementerian Desa, ada dari BKKBN, ada dari Kemkes, ada kita, ada di bawah koordinasi Menko PMK itu sudah dibahas. Ya mudah-mudahan lah kemarin hasil pembahasannya kita minta agar kebijakan untuk pemanfaatan dana desa dalam konteks mensupport pelayanan kesehatan di desanya itu dikeluarkan oleh kementerian. Sehingga karena kadang-kadang di desa kalau tidak ada kebijakan dari pusat mungkin nggak berani juga. Tapi apapun itu, karena kita dalam sistem pemerintahan kita ini kan sekarang desentralisasi. Ya, tidak selalu apa yang sudah kita gembar-gemborkan yang udah berbusa-busa di pusat, tapi nanti di daerah belum tentu. Nah, sehingga kita yang ada di daerah pun harus melakukan advokasi sesuai dengan levelnya. Saya selalu sampaikan juga ke teman-teman PDIB, ini ada Bu Hasna, ada Bu Lela ya. Bagaimana kita melakukan advokasi ke provinsi, di kabupaten kota, bahkan teman-teman kalau ada di desa itu teman-teman di kabupaten kota dengan Pemda setempat begitu. Jadi di pusat kita sudah membahas itu, tapi tentu perlu di follow up karena sistem pemerintahan kita desentralisasi. Nah, itu yang perlu kita tindak lanjuti. Ya.
Baik Ibu, terima kasih untuk jawabannya. Di sini dari Bidan Inisiator juga menyampaikan terima kasih atas penjelasannya Ibu. Baik Ibu, kita lanjut untuk pertanyaan kedua. Di sini ada dari Bu Laila Rahmi. Assalamualaikum, izin Bu Emi. Apakah sekiranya memungkinkan adanya regulasi yang mengatur dan memberikan izin kepada bidan yang bertugas di akademik atau sebagai dosen untuk bisa ikut berperan juga dalam berpraktik di pelayanan, Bu? Nah, mohon tanggapannya
Itu
Ibu.
sangat dibutuhkan. Justru kita mendorong teman-teman dosen itu dia membuka praktek juga agar kemampuan skillsnya juga tetap terjaga. Jadi kalau ada teman-teman dosen yang akan membuka pelayanan di tempat praktek mandiri itu kita sangat-sangat mengharapkan itu. Karena yang menjadi masalah di pendidikan kita, salah satu dan menjadi masalah terbesar juga, dosen-dosen kita itu tidak punya pengalaman klinis. Lulus dari D3, langsung D4, langsung S2, langsung jadi dosen, langsung jadi direktur, nggak pernah punya pengalaman klinis. Udah terpaku aja duduk di kampus. Nah, inilah kelemahan kita. Bagaimana kita bisa membimbing mahasiswa kita sendiri nggak pernah mengalami. Sehingga di dalam standar pendidikan yang kita buat, yang saya katakan tadi, insya Allah dalam waktu dekat disahkan, syarat untuk dosen itu harus punya pengalaman klinis. Dan kalau belum punya pengalaman klinis, sudah terlanjur menjadi dosen, dia bisa melakukan kegiatan-kegiatan klinis di luar jam kerja. Atau dosen bergabung, beberapa dosen buka itu fasilitas pelayanan praktek mandiri. Nah, itu bedanya pendidikan kebidanan dengan pendidikan kedokteran. Kalau dosen-dosen di kedokteran mereka merasa praktek. Kalau kita kan enggak. Nah, ini tantangan terbesar kita. Dosen-dosen kita ini sangat minim pengalaman klinisnya. Kalau ada yang berminat untuk itu, kita akan sangat support. Ya.
Oke. Baik Ibu. Namun di sini dilanjutkan, hal ini juga berharap dinilai sebagai salah satu tugas dan tanggung jawab dosen pada Tridharma perguruan tinggi. Artinya, kalaupun kita memberikan pelayanan di praktik, mungkin bisa dijadikan sebagai salah satu pengabdian masyarakat, mungkin gitu ya Bu ya?
Betul sekali, betul sekali.
Oke, terima kasih Ibu. Kemudian Namun di sini, oh iya, di sini dari Ibu Novrice Anggreni setuju Bu, setuju dalam pendidikan dan juga diimbangi dengan adanya praktik. Artinya IBI mendukung dan memfasilitasi kehadiran dosen untuk berpraktik di praktik mandiri bidan.
Sangat
Sesuai
mendukung.
syarat dan ketentuan yang berlaku.
Sangat
Gitu ya, Bu,
mendukung,
ya.
ya.
Oke, baik Ibu. Nah, di sini mungkin Yunda sendiri juga ada pertanyaan ini Bu, terkait dengan leadership ini Bu. Kenapa Yunda bertanya ini? Mungkin di sini kita masih banyak menemukan mahasiswa yang apalagi pada tingkat vokasi di sini Bu, sulit untuk mengungkapkan pendapat mereka gitu, atau mereka hanya berpikir karena saya vokasi, saya hanya bekerja. Nah, sehingga untuk mengungkapkan pendapat ataupun ide itu sulit untuk mereka menyampaikan. Nah, kira-kira apa trik ataupun sosialisasi apakah yang difasilitasi dari IBI untuk membangun kepercayaan diri bagi mahasiswa kita ini?
Iya. Sebetulnya bagaimana membangun kepercayaan diri mahasiswa itu prosesnya melalui pendidikan yang utama ya. Bagaimana model pendidikan yang kita bangun, ya bagaimana kita memandirikan mereka. Mulai dari proses belajar kita sudah bisa membangun kemandirian, membangun leadership ya. Ya, jadi kan kita kan punya strategi-strategi belajar ya. Women center student misalnya, apa namanya, pembelajaran yang berfokus kepada mahasiswa, dia yang lebih aktif,
learning ya Bu ya.
Itu jadi ini tergantung dari proses bagaimana kita membentuk mereka selama proses pendidikan. Nah itu penting sekali, makanya sebetulnya di dalam standar kompetensi kita ada kompetensi tentang komunikasi efektif. Ya, karena itu penting sekali. Karena memang sekarang terbuka peluang untuk kita jadi leaders ya. Tadi yang saya contohkan ada 8 sudah jadi kepala dinas kesehatan kabupaten kota, ada lebih kurang 700-an yang sudah pegang apa namanya kepala puskesmas. Itu karena kapasitasnya di samping kapasitas klinis, dia punya kapasitas non klinis dan manajemen kapasitas leadership. Nah, itu penting sekali. Barangkali model-model pembelajaran di kelas yang harus juga kita bangun. Kan kita selalu membuat kelompok-kelompok, presentasi dan lain sebagainya. Itu untuk membangun, melatih mereka berani bicara. Ya, jadi kita juga harus melihat, kalau saya ya dengan mahasiswa saya sendiri, kelompok-kelompok ada 5 kelompok. Nanti setiap pembagian kelompok dia aja terus yang presentasi. Nah, saya nggak mau, harus bergiliran. Itu membuat mereka juga melatih untuk bicara di depan orang lain gitu.
Jadi tercapai untuk semua mahasiswa, tercapai kompetensi mereka gitu juga ya, percaya diri insya Allah. Terima kasih Ibu. Untuk selanjutnya Ibu, ini ada pertanyaan di kolom chat dari Ibu Rizky.
Barangkali mungkin setelah ini satu lagi ya Mbak. Kebetulan saya nih orang lagi bicara di sebelah, saya mojok ke sini. Ya.
Oke, baik Ibu. Ini dari Ibu Rizfa Febrindra. Assalamualaikum Ibu. Izin bertanya Bu, bagaimana bentuk pelatihan yang membuat keputusan untuk bidan Bu? Pelatihan pembuat keputusan, pengambil keputusan.
Pelatihan pengambil keputusan. Iya, itu kan melalui ya di dalam pelatihan termasuk pelatihan klinis, apakah itu pelatihan APN? Ya, itu di situ kan ada, kita bicara tentang komunikasi, kita bicara di dalam standar asuhan kebidanan, mulai dari pengumpulan data objektif, subjektif, bagaimana analisis datanya, menghubungkan antara informasi satu dengan yang lain, ya, bagaimana data-data penunjangnya. Nah, jadi pengambilan keputusan melalui proses. Ya, mulai dari pengumpulan data, analisa data, baru kita bisa mengambil keputusan. Dan itu sebetulnya harus di dalam pelatihan-pelatihan, apalagi kita bicara pelatihan komunikasi dan konseling. Kan kita punya KIPKA, komunikasi, informasi, dan konseling. Itu kan pengambilan keputusan. Nah, itu sangat dilatih sekali. Ya, termasuk sekarang untuk pelatihan keluarga berencana, konseling berimbang, ya. Pernah dengar konseling berimbang, pelatihan konseling berimbang itu juga bagian dari proses kita di dalam mempengaruhi, di dalam menentukan keputusan, tentu sesuai dengan data-data yang kita kumpulkan. Ya kalau pada kasus klinis ya kita udah punya standar, bagaimana SOP, standar asuhan kebidanan, mengumpulkan data subjektif, data objektif, data penunjang, lakukan analisis, kemudian planning, kemudian implementation, kemudian bagaimana untuk monitoringnya, evaluasinya, dan pencatatan dan pendokumentasiannya. Kita kan punya standar asuhan kebidanan. Itu adalah siklus dalam problem solving, ya. Jadi pendekatan, jadi midwifery care approach kita menggunakan problem solving standar. Ya, nah itu perlu latihan. Tadi yang disampaikan juga bagaimana kalau selama mahasiswa nggak pernah mengelola pasien sama sekali, bagaimana dia tidak membuat laporan kasus, ya tentu akan sangat mungkin tidak mudah buat mereka pada saat mereka sudah bekerja nantinya. Tapi kalau dari awal sudah dilatih, sudah terbiasa mengelola satu kasus, dia mengumpulkan semua data yang dia butuhkan, melakukan pemeriksaan objektif penunjang yang dia butuhkan, dia menghubungkan antar informasi, dia melihat kemungkinan-kemungkinan dan lain-lain. Itu melalui proses ya.
Baik, Ibu. Terima kasih untuk jawabannya, Ibu. Mungkin satu lagi, Bu, dari rumah sakit, Bu.
Oke.
Terkait dengan pendidikan. Jika bidan sudah S2 kebidanan, sudah S3 kebidanan, sudah kerja dan mengajar, masih harus ikut pendidikan profesi, Bu?
Nah, itu dua hal yang berbeda ya. Jalurnya kan berbeda. Ini kita udah tahu nih, ini jalurnya udah berbeda. Saya ini S3 nih. Ini saya mau masuk profesi. Ya, jadi itu jalurnya itu tergantung kebutuhan kita. Kalau kita nggak perlu ada di situ, seperti saya nyaman dengan saya manajemen, saya nyaman dengan saya sebagai dosen, ya belum tentu saya akan mengambil profesi. Tapi kalau saya membutuhkan profesi di dalam karir saya, atau mungkin saya ingin lebih memperkuat diri di dalam klinis, ya bisa saya mengambil. Tergantung kepentingan masing-masing. Apakah menurut Ibu yang sudah di rumah sakit barangkali sudah jadi pimpinan juga, kepala ruangan dan lain sebagainya, apakah perlu ngambil profesi? Ya itu tergantung dari keputusan masing-masing. Yang diwajibkan untuk mengambil profesi adalah bidan-bidan yang akan mengelola tempat praktek mandiri. Di luar itu nggak ada diwajibkan, tergantung masing-masing kita. Kalau kita membutuhkan ya kita masuk. Kalau menurut kita enggak lah, saya udah nggak perlu, ya nggak apa-apa. Saya nggak akan berkurang juga, misalnya jabatan fungsional dosen saya kalau anak saya tidak profesi, ya nggak akan turun juga. Tentu saya akan mengajar sesuai dengan bidang ilmu yang saya kuasai. Saya tidak bisa mengajar nanti dalam asuhan kebidanan. Nah, begitu juga untuk teman-teman di rumah sakit, ya kita harus merefleksikan kepada diri kita masing-masing. Kita mau bagaimana? Kita mau alurnya kemana? Tapi yang wajib untuk profesi adalah hanya yang teman praktek mandiri. Kalau enggak apa-apa.
Baik, Ibu. Dan mungkin juga nanti teman-teman ataupun ibu-ibu peserta juga bisa nanti membaca lebih atau memahami lebih lagi di Undang-Undang Nomor 4 tahun 2019 gitu ya, Bu ya. Begitu juga terkait dengan yang tahun 2022 yang tadi peraturan dari Menteri Kesehatan ya, Bu ya, 1262. Mungkin bisa itu lebih kita dalami, kita baca bersama dan pahami bersama. Baik, Ibu. Ucapan terima kasih pencerahannya Bu dari rumah sakit. Nah, baik Ibu, dikarenakan waktu juga lah yang memisahkan
Ya,
kita.
ya.
Insya Allah di lain waktu, ataupun kalau misalnya ada pertanyaan lanjutan, mungkin nanti kita mohon bantuan Ibu, kita via chat ataupun email ya Bu ya.
Coba saja.
Oke. Baik, ibu-ibu peserta semua. Jadi dalam kegiatan kita di sesi keempat ini dapat kita simpulkan di sini bahwa cukup besarnya minat masyarakat terhadap kita sebagai bidan, di mana dibuktikan dengan tingginya persentase dalam baik masyarakat melakukan pemeriksaan atau pemanfaatan layanan primer. Kita bidan sebagai ujung tombak diharapkan dengan adanya evidence base, bukti-bukti untuk kemajuan pelayanan dapat kita kembangkan. Kerjasama yang kuat antara akademisi dan provider atau penyedia layanan dan dukungan penuh dari organisasi profesi diharapkan kita bersama-sama dapat meningkatkan kualitas bidan sebagai penyedia layanan dan pendidik, kualitas wanita sebagai partner bidan dan ujung tombak dalam keluarganya, sosialisasi dan implementasi bersama model layanan kebidanan, baik itu continuity of care, lab care, dan menyongsong dan mendukung untuk filosofi normality women center care. Maka diharapkan nantinya tercapainya kualitas pendidikan pelayanan kesehatan dari saat ini diharapkan untuk tujuan bersama di tahun 2030 setiap wanita berhak untuk sehat. Terima kasih Ibu. Mohon maaf dengan adanya kesalahan dan kekurangan dari Yunda selaku moderator sore hari ini. Yunda mohon maaf. Terima kasih sekali lagi kepada Ibu. Terima kasih juga kepada panitia. Yunda akhiri. Wabillahi taufik wal hidayah. Assalamualaikum warahmatullahi wabarakatuh. Kita kembalikan kepada MC.
Ya. Salam buat teman-teman semuanya ya.
Ya Bu, insya Allah.
Terima kasih sekali dan sukses untuk kita semuanya.
Ya, terima kasih Ibu. Saya selalu Ibu.
Ya.
Ya.
Baik, terima
Dikembalikan
kasih
kepada MC Hani. Dipersilahkan Hani.
Ya baik Bu. Terima kasih Bu Yunda atas konklusinya, sudah sangat mencakup semua dari hasil pembicaraan dengan Bu Emi tadi. Terima kasih juga kepada speaker kita yang sangat luar biasa. Saya yakin tidak hanya saya, tapi semua yang mendengarkan di sini terinspirasi dan juga memberikan semacam motivasi dan keberanian untuk membuat langkah-langkah perbaikan demi perkembangan kebidanan dan pelayanan kebidanan yang lebih baik lagi. Terima kasih untuk teman-teman partisipan yang sudah hadir di hari ini. Saya harap dapat menikmati dan juga belajar banyak dari presentasi dari pagi ini sampai sore ini. Kemudian juga saya ingin mengucapkan terima kasih atas antusiasmenya karena dan juga teman-teman yang masih bertahan sampai sesi akhir di sore hari ini. Baiklah, saya informasikan kembali kepada partisipan yang belum melakukan registrasi untuk absensi di sore ini dapat diakses pada laman chat kita di Zoom ini. Kemudian juga saya akan melakukan share screen terkait kegiatan kita pada esok hari. Baik, bisa kita lihat di sini bahwa besok kita akan ada oral presentation dari jam 8.05 sampai jam 9.30, yang mana kelompok 1, 2, 3, dan 4 akan nantinya bergabung ke break room masing-masing. Kemudian juga untuk peserta lainnya dapat mengikuti seminar yang dimulai pada pukul 9.30 sampai dengan selesai di jam 17.00. Saya harapkan teman-teman tetap antusias untuk berbagi ilmu, untuk menyerap kembali atau merefresh kembali ilmu yang sudah ada, sehingganya nanti kita mampu untuk selalu memperbaiki diri, untuk selalu mengupgrade ilmu setiap saat. Baiklah, demikian acara kita pada sore hari ini. Pada hari ini, saya sebagai perwakilan dari Departemen Kebidanan, S1 Kebidanan, dan juga Profesi, Fakultas Kedokteran Universitas Andalas, mengucapkan banyak terima kasih dan juga maaf jika ada banyak kesalahan selama proses acara kita pada hari ini. Kemudian juga terima kasih kepada seluruh panitia yang sudah mengangkatkan acara pada hari ini sehingga dapat terlaksana dengan baik. Baiklah, saya tutup. Saya undur diri. Assalamualaikum warahmatullahi wabarakatuh. Sampai ketemu besok. Baik, untuk peserta mungkin diizinkan untuk brief meeting. Terima kasih.